Tshisekedi Chilombo, Chairperson of the African Union and President of the Democratic Republic of Congo, Your Excellency Dr. Tedros Ghebreyesus, Director General of the World Health Organization, Honorable Minister Mustafa Mijiawa, Minister of Health of Togo, and Chair of the Governing Board of the Africa Center for Disease Control and Prevention. I recognize all honorable ministers that are present. Dr. John Kengasong, Director, Africa Center for Disease Control and Prevention. I recognize all distinguished guests and ladies and gentlemen. It gives me great honor and pleasure to welcome you to this Ministers of Health on the objective of this gathering is to review the state of the COVID-19 pandemic in Africa and evaluate the implementation of the joint continental Honorable Mustafa
on ne les entend pas.
Apologies, Excellencies, we had a technical hiccup. I have the honor to invite Honorable Mustafa Mujiawa, Minister of Health of Togo and Chair of the Governing Board of the Africa Center for Disease Control and Prevention, to make a statement.
Bonjour à toutes, bonjour à tous. Je ne sais pas si vous m'entendez.
Good morning to you all. Can you hear me through the interpreter? Thank you very much. Excellency, President of the Democratic Republic of Congo, the Chairperson, Your Excellency, President of the Republic of South Africa, Director General of WHO, the Regional Director of WHO Afro, the Director of CDC Afro, distinguished invited guests. Good morning to you all. I thank you for responding to this meeting. This meeting is of paramount importance because of the issue under consideration. The two themes that we are going to discuss are very important. The first having to do with the continental strategy, which started about a year ago, and the second is the digital recording of the fight against the COVID-19. After the Africa recorded its first case of COVID-19, the whole continent became so concerned. And recently, we have been informed of other or second wave of the virus, which is more dangerous, which propagation is faster than the first virus identified. In our various countries, we have three major pillars for the response. First of all, legal and legal measures. Second, strengthening of our health systems. And third, strategies to lessen the socio-economic impact on our people. The World Health Organization, the African Union, the CDC Africa, and thanks to the leadership of our respective head of state, have played a significant role in the implementation of our strategy. Allow me the opportunity to thank them. The African Union has swiftly taken the bull by the horns through the fight against this pandemic. The African Union has also put in place a platform to facilitate the procurement of logistic and health equipment supported by the head of state of the Republic of South Africa. And these are all firm, concrete demonstration of the commitment of our government. Today, we want to thank His Excellency, the President of the Democratic Republic of Congo, and all other leaders for putting together this meeting. We also want to thank the WHO, together with the CDC Africa, for all the support they have been giving to our respective government. Indeed, there are many other partners. We want to thank the Director General of WHO, through whom the African Union, through the leadership of the African Union's Commission, has invested in all the phases of the response, more proactive and effective mechanism. Indeed, may I also acknowledge the effort and support from you all, especially the Director of CDC Africa. Their swift response has translated into the less cases of death of COVID-19 that we have recorded on the continent. Today, we are fighting for vaccination through 3 initiatives: the COVID initiative, the Gavi and WHO, the initiative, which is linked to the African Union platform, and also other bilateral mechanisms, has as objective 60% of vaccination coverage of the entire continent. The meeting today will enable us to take stock of the riposte against the COVID-19 pandemic on the continent, and also taking stock of all the strategies that we have taken. It will also be an opportunity for us to examine the impact of the pandemic in our respective health systems. I am convinced that with the commitment of you all and that of our respective head of state, we will soon say goodbye to the COVID-19 pandemic and bring our respective economies back to their respective feet. Thank you so much for your attention.
Thank you, Honorable Minister, for your statement. I now invite His Excellency, Dr. Tedros, to make a statement. Thank
you. Thank you so much, moderator. Your Excellency, President Tshisekedi, Your Excellency, President Ramaphosa, Your Excellency, Your Excellency Musa Faki Mohammed, Your Excellency Professor Mustafa Mijiawa, and my colleagues Dr. Moeti and Dr. Kenga Song, Excellencies, Honorable Ministers, dear colleagues and friends. Good afternoon, and thank you so much for the opportunity to join you today. Since the beginning of the pandemic, WHO has called consistently for national unity and regional and global solidarity. And that is exactly what the African Union has demonstrated. Africa is the only region to have developed a unified continental strategy on COVID-19. And that strategy has delivered results. And I would like to thank His Excellency President Ramaphosa and His Excellency Musa Faki Mohammed for their leadership, and to all ministers who have participated in the first meeting and pushed on since then, and also for the continued leadership of President Tshisekedi. Although our continent has suffered, we have not yet seen the same scale of devastation in Africa as we have in some other regions. We have seen an encouraging decline in cases and deaths since the peak in mid-January. However, several countries in the continent continue to report sustained transmission and increase in some areas. It's critical that none of us are complacent. What's happening now in many other parts of the world can happen in our Africa if we let down our guard. In many countries, the emergence of rapidly spreading variants combined with premature easing of public health and social measures and the inequitable distribution of vaccines is having tragic consequences, as we all know. But we know what works. There are many countries that have shown that with a consistent and tailored use of proven public health measures, this virus can be controlled, even without vaccines. Although our continent has seen fewer cases and deaths than other regions, Africa has suffered from major disruptions to health systems and health services. New WHO data show that as a result of COVID-19, 60 immunization campaigns are currently suspended in 50 countries globally, including many in Africa. Measles campaigns have now been delayed for more than a year, and serious outbreaks have erupted. WHO and our partners are working with countries to restore immunization services. The disruptions to services for HIV/AIDS could potentially result in as many as 500,000 excess deaths globally. And we all know that Africa will bear the heaviest burden. In Africa, services for tuberculosis and neglected tropical diseases have been disrupted in about half of countries, and malaria services in more than 1/3. About half of the countries in the region report severe disruptions for services for non-communicable diseases such as diabetes, hypertension, and mental health. WHO remains totally committed to supporting every AU member state to restore, maintain, and strengthen these essential services. And we remain totally committed to supporting every AU member state to access the tools to end this pandemic, including vaccines. We are all painfully aware of the shocking disparity in the global distribution of vaccines. We're pleased that with the support of COVAX, 47 countries in the African continent have started vaccinating, but we know the volumes of vaccines are nowhere near enough. So far, Africa has administered 19.6 million doses, or 2% of the global total. Meanwhile, 80% of all doses administered globally have been in high and upper middle income countries. The inequitable distribution of vaccines is not just a moral outrage. It's also economically and epidemiologically self-defeating. I have said this many times. And the gap is very tragic between the haves and the have-nots. Of course, it's critical not only to increase access to these life-saving tools, but also to make sure they're distributed properly and before they expire. ensuring that financial and human resources are available to reach the last mile is imperative. WHO is working day in and day out to urgently increase the production and equitable distribution of vaccines with countries, companies, and partners, including the African Vaccine Acquisition Task Team and the Partnership for African Vaccine Manufacturing. We're seeing some progress. As you know, the United States has announced its support for efforts in the World Trade Organization to waive intellectual property protections for COVID-19 vaccines. That's very historic. And we thank South Africa for its bold leadership in this initiative. And we're calling on other countries to follow suit. And for Africa as a continent to push this agenda forward. We continue to work with countries and companies to find ways of sharing technology and know-how for this difficult to make vaccines. Excellencies, I would like to leave you with 3 specific areas that I believe must be our priority in the coming months: production, prevention, and preparation. First, production. The pandemic has demonstrated that Africa cannot rely solely on imports of vaccines from the rest of the world. We must build that capacity, not only for COVID-19 vaccines, but for other vaccines and medical products. WHO remains committed to working to establish the African Medicines Agency, which we expect to strengthen regulatory capacity and stimulate local production. I congratulate my brother Michel Sidibe on his appointment as AU Special Envoy for the Africa Agency. And we look forward to working closely with him, and we have already supporting him through African Union. I also commend the Africa CDC and the African Union for the launch of the Partnership for African Vaccine Manufacturing last month. And we seek the support of African Union countries for the draft resolution on local production at the forthcoming World Health Assembly. Second, prevention. Vaccines are giving us all hope of light at the end of the tunnel. But to quote my friend Tom Frieden, we cannot allow ourselves to be blinded by that light. The same public health measures that have been the bedrock of the continental strategy must remain central to the response. That means strengthened surveillance, increased testing, careful contact tracing, supported quarantine, and compassionate care. And it means empowering and engaging communities to continue with the individual precautions that we know work. Physical distancing, avoiding crowds, wearing masks, cleaning hands, covering coughs, and opening windows. We may sound like a broken record, but these measures work. We must all stay the course. We encourage the use of digital tools such as the Trusted Travel Program for safeguarding public health. But we must take care to ensure that they do not become another reason that some people are left behind. And third, preparation. Even as we focus on extinguishing this fire, we must prepare for the next one. We must all learn the lessons the pandemic is teaching us and do everything we can to prepare for, prevent, detect, and respond rapidly to future epidemics and pandemics. That is not someone else's job. That's our job. Every leader, every government, every institution at every level. We thank those AU member states that have expressed support for the idea of a treaty on pandemic preparedness and response. And we seek the support of all member states for the treaty at the World Health Assembly later this month. We know the pandemic treaty will be a game changer and prepare as well for the future. Such a treaty would provide a framework for international cooperation and solidarity, rooted in a strengthened, empowered, and sustainably resourced WHO. If the pandemic has taught us anything, it's that division only fans the flames of insecurity and makes us all less safe. But with a commitment to trust, cooperation, and solidarity, we're all safer. I thank you. Thank you, moderator, and back to you.
Thank you, Director General, for your statement. It is now my honor to invite President Felix Tshisekedi to make a statement. Colleagues from CDC, we are waiting for you. I understand you have a statement.
Excellences, Mesdames et Messieurs les ministres, distingués invités,
Excellencies, honorable ministers,
nous voici réunis
once again
pour
we
le
are
bilan
meeting to take stock of the fight against the COVID-19 pandemic, a pandemic that has impacted our lives, our families, and
d'une mauvaise
our
nouvelle,
societies.
un décès lié
A single
à cette
day
pandémie.
can never pass by without news of death due to COVID-19 pandemic. In January 2019, WHO has declared the COVID-19 pandemic as
Depuis, le nombre de cas ne cesse d'augmenter.
a health
Au 28 avril 2021, nous comptons 4
concern. Today, we are recording more than 118,000 deaths across the continent. And 29 countries as of today have recorded new variants of the virus. The African Union, under the leadership of President Cyril Ramaphosa, has held many meetings in order to strengthen the collaboration in the fight against the COVID-19 pandemic among member states. His Excellency, the President of South Africa, is the champion of the response against the COVID-19 pandemic. Today, we are meeting at an emergency level of all health ministers of the African Union. We want to take stock of the fight against the pandemic, issues concerning access to the vaccine, and also equity in accessing vaccine. Through this meeting, we are mandating to work in building capacities and strengthening collaboration and communication amongst member states in the response against the COVID-19 pandemic. This meeting, CDC will help us put in place and strengthen the
Et la réponse au
task
nouveau
force
coronavirus,
working against the COVID-19 pandemic.
une
We
stratégie
also need to define a common continental strategy, the establishment of a platform for the acquisition and distribution of medical
africain
logistics and
d'accéder
equipment in the member state of the African Union to have equitable access to these logistics. We must also ensure that the special envoy are also playing their key roles in ensuring that we have access. Today, we're also going to take stock of the capacities of all member states in the fight against the COVID-19 pandemic. Today, 16 countries in strengthening their capacities in doing tests and also to adequately detect the new variants in circulation. We have been also be able to deploy community health professionals across the continent.
contre la COVID-19 dans nos différents
The fight against the COVID-19 in our respective countries has led
sur barrières, y
us
compris les
to
mesures de
implement protocols.
confinement quand cela s'est avéré nécessaire.
We've also been able to close our borders in order to control movement of people.
La réalisation des tests à plus ou moins grande échelle
Care of given to people who have been infected according to the recommendations of the WHO. And all these actions
membres du continent
are taken in close collaboration with
étroite
many
avec
partners.
plusieurs partenaires et je
And
voudrais
may
ici
I make mention, first of all, the various regional WHO office in Africa, the COVAX initiative,
partenaires privés comme
partners such as Alibaba Foundation that have enabled us to maximize our response across the continent. We want to say a big thank you to all of them. It is also important for us to highlight the fact that many protocols have been adopted on the continent, and we want to use the opportunity of this meeting to operationalize some of the decisions we have taken. Hélas,
dû à la pandémie de COVID,
despite the efforts that the continent has deployed,
luttes
we
mises
are
en
still
place
recording
ont
deaths,
également
and many of our life,
impacté plusieurs aspects de la vie.
many of our societal activities have been impacted because of the COVID-19 pandemic.
D'autres secteurs, notamment l'économie
The
et l'éducation.
economy is not spared, education not spared as well. And in these measures in the fight against the COVID-19, the pandemic has brought to health burdens, both for our respective countries and on the international front. Knowing very well that already we have fragile health systems on the continent, and which is already battling with HIV/AIDS, malaria, and many other diseases. COVID-19 has also come to show us once again how fragile our health systems are. Let me also acknowledge the contribution of our women in the fight against the pandemic. Our women once again have demonstrated not only good in taking care of us and our homes, but also they are very, very strong for women. Today, we want to know if we will be able to attain our 60% vaccination coverage, which the African Union has fixed for itself.
Périlleux
Au
vu de l'évolution de la situation de COVID-19 dans le monde, et particulièrement en Inde, un des pays qui produisent les vaccins.
Across the country, which is a big vaccine producer, to see how best we can 60%
examiner la menace.
But also critically analyze the dire
d'explorer le
of the
rôle
pandemic, how our economies are fragile vis-à-vis this pandemic. We therefore need to put in place innovative economic activities so that our respective economies will be back on their respective feet. And I wish to say that it is through your commitment and the support of our respective partners that we can reaffirm our direction in Agenda 2063. I would like you, during these 7 hours of deliberation, have in mind the interest of the people of Africa. The whole of Africa is counting on you that sooner than later, there will be no longer in the continent. Thank you so much for your attention.
Excellence, for your statement. I now call upon Dr. John Kengason, who is going to give an update on the state of COVID-19 pandemic in Africa and the need for a new strategy. Thank you.
Yeah, protocol, can you see my screen?
Yes.
Okay, good, thank you. Excellencies, Chair of the African Union Commission, President Tshisekedi, Excellencies, the Chair of the African Union Commission, Musa Faki Mohammed, Dr. Tedros, Dr. Moeti, Excellencies, all ministers of health present and colleagues. It is almost exactly 1 year ago that we met on this platform to discuss the pandemic in Africa. And at that time, we were just starting. The pandemic was just beginning to hit our continent. And today, I would like to do 3 things. One is to give you an update on the epidemiological situation of the COVID-19 pandemic on our continent. Then secondly, invite all of us to look at critically the situation of COVID-19 in India. And then segue and conclude with some proposed next steps in terms of an adapted strategy, as President Tshisekedi has talked about and Dr. Tedros nicely outlined in his opening remarks. So first of all, let's look at the epidemiological situation of COVID on our continent. So exactly 1 year ago, His Excellency Musa Faki Mohammed convened an emergency meeting on February 22nd in Addis Ababa, where most ministers of health, most of you were present. Dr. Moeti, Dr. Tedros, and others all came together. At that time, the continent had recorded only few cases in Egypt, about 2 cases in Egypt. And the map you see on your left-hand side shows where we were about 1 year ago with the pandemic, where globally about 75,000 people were infected and just about 2,200 deaths were recorded across the world. Let me invite you to look at our continent of Africa at that time, exactly on February 20th. The only blue spot you see here is Egypt, where I think 1 or 2 cases were recorded, and we immediately reacted and convened the meeting that I just mentioned in Addis Ababa. Slightly over 1 year after that, this is where we are. We've evolved from about 2 cases in Egypt to about 4.6 million cases across the continent with over 123,000 deaths. We have to be humble enough to assume that the 4.6 million cases you see on your left-hand side are underestimates, because we now are seeing serologic data, including some of our own data we've generated, that shows that this number can be and is possibly a gross underestimate. If you now look at the curve on your right-hand side, it clearly shows that we have gone through two peaks. And one thing we learned from these peaks is that the second peak, which happened around January this year, was definitely higher than the first peak. And I'll try to go into that carefully as we dig deep into the regions and countries. But I would like to bring your attention to where we are. That as a continent, we have fought a very strong battle, and the numbers have come down after the second peak nicely. However, what you see at the very tail end of that shows a trend that is undefined. It clearly shows that some countries continue to see an increase in number of new cases, whereas some countries are witnessing a decline in number of cases. Let us now look at the different regions. In Southern Africa, for example, over the last few weeks, we have observed a slight increase of over 4%. And this is the region where they have bent their curve from the second wave very, very nicely. Then we look at West Africa, very similar trend, but again, which shows that the second wave was higher than the first wave, but they continue to decrease their numbers over the last 4 weeks or so nicely with about 10%. Then we look at Central Africa. Again, the second wave seems more aggressive than the first wave. And over the last couple of weeks, we have recorded about a 64% increase in the cases, daily cases. North Africa, we see that after bending their curve very nicely, they are now beginning to see a slight creeping up as a region of about 0.2%. And East Africa, interestingly, they have gone through their third wave, where not all countries, some of them, and I'll go into that subsequently, but it's a slight, nice decline slowly. So the continent, as I leave the regional trends, showed a very heterogeneous pattern across where we are with respect to the second and third wave. So this is a summary of what we have seen. As of the 3rd of May, 52 countries, 95% of all member states have experienced second wave. And 40% of that, or 77%, are more severe. 13 countries or 24 countries have experienced the third wave, and 10 of those numbers, that is 77%, seem very severe. Let's look at a few cases. Angola, for example, nicely bent the curve in the first wave, but you can see that the second wave, how much they are increasing. Cape Verde continues to see an increase in number of cases just the last couple of weeks. Algeria has bent the curve twice, but we see a slight increase in number of cases now, about 56% increase, edging towards the third wave. Egypt, very similar trend. I mean, they've gone down the trough, gone up the mountain, and now they are going up again. So let's look at Kenya, which is really a demonstration of strong leadership, strong public health measures. And let me just echo what Dr. Tedros mentioned, that we have the tools in our hands to fight this pandemic and continue to blunt spread. And Kenya is a good example. The lessons to be drawn from this one is that each time you get the next wave, it is higher than the previous wave, as you can see in the situation in Kenya. But the beauty here is that Kenya has been able to, without extensive spread of vaccines, been able to bend their curve three times, I beg your pardon. The first time around July, August last year, the second wave around November, December, and the third wave around April and May. And we can see that over the last couple of weeks, they have actually bent their curve nicely with about minus 56%. Côte d'Ivoire, also clearly showing that with the reinforcement of public health measures, you can continue to bend the curve despite the persistent threat that the virus poses on us. So we are not totally helpless. We have some tools in our hands that we can continue to apply
in a very consistent and deliberate manner. But unfortunately, the trend across our continent shows that there's clearly a pandemic fatigue setting in. The curve you see on your left-hand side shows in blue the self-reported adherence to mask, wearing of face masks, which we know protect us and protect your loved ones. And the red bars indicate the changes in the behavior with respect to wearing of masks and other public health measures over time in select countries. You clearly see that some countries have begun to neglect those public health measures, and 56% of member states surveyed indicated a decrease in adherence to wearing face masks compared to the last PEC, which is the public health surveys that were conducted. And this is a practice that we strongly call on all of us on this call could collectively continue to encourage our communities, advocate for public health measures, because I've just shown in the previous slides that they do work. And we don't need to wait for vaccines before we fight this pandemic. We have some of the tools in our hands. Let me now transition to testing. As a continent, we have collectively tested about 44.8 million, conducted 44.8 million tests, with 9.7 tests per reported case, and with a positivity rate of 10%. We need to do more. We are almost just at the threshold of where we should be. But given where we are with the pandemic, we should all intensify our efforts and do more testing. This slide summarizes for you where we were during the first, second, and third wave. And I'll walk you through carefully. For the first wave, during the peak, 14, that is 26% of 53 countries we surveyed had adequate testing capacity. During the first trough, 40 or 85% of 47 member states had adequate testing capacity. Currently, 62% of member states have adequate testing capacity. Subsequent waves, as I have shown, are becoming more intense. And we experienced that 95% of member states experienced the second wave, 40% more severe than the first, 13 or 24% member states experiencing the third wave, and 10% of those more severe. So this begs the question as to our efforts to continue to increase our ability to expand testing, which is the only way for us to know where we are with the pandemic. Testing a radar of which we are flying this plane. There is the war against COVID-19 pandemic. We have more tools, and these are tools that are coming from the ACT Accelerator. The antigen testing is being expanded across the continent. And if you look at this, I'll just focus on the last bullet. During the epidemiologic week 17, we observed the following: 11 out of 12 countries, that is 92% of those countries, were actively using and reporting on antigen test numbers. 24 out of 34 member states were not using and reporting on antigen tests. We strongly urge all member states present here today and those who are not present to increase the uptake of the antigen test, which is, in my view, potentially a game changer if we do it and use it well. Let me now transition to the pathogen genomics. Together with WHO Afro, we set up a network of pathogen genomics at 3 levels. Level 1 are specialized laboratories, indicated in blue. The second level are regional labs, and the last level are the national labs. So these capabilities and resources exist for all of us to take advantage of in a coordinated fashion, leverage the existing capacity to access sequencing data or enable viruses to be sequenced so that we can know exactly what is going on in each member state. And this is a simple diagram of how we organize. We have a very strong and active referral system that moves specimens from member states to either regional labs or specialized labs. And once the sequencing is done, the data is immediately provided to member states to be used for action. This is just some example of what we have done. We've supported about member states with about $2 million sub-grants to strengthen their capacity, distributed over 25,000 sequencing kits, and upgraded several laboratories in different member states. We continue to make progress with a total of about 12,700 sequences generated. And the graph on your right-hand side shows the increased number of sequences that have been generated since January. And we'll continue to expand that effort to reach all member states. We are calling on every member state of the 55 countries in the Union to work with us so that we can increase the ability to refer samples to regional labs or specialized labs. Now, on the issue of variants, where are we as a continent? Let me just use this slide to summarize for you some of what we know about variants. We know that the B117 variant was originally identified in the UK. We also know that the B1351 variant was originally identified in South Africa, and the P1 variant in Brazil. And to this, I'll add the variant, the 617 variant in India. Some of them have been demonstrated. For example, the B1351 variant to show reduced effect on the ability for vaccines to protect against them. So where are we as a continent? At a continental level, 23 countries have reported the B1351 variant. 22 countries have identified the B117 variant. And about 4 countries have now identified the B1617 variant. That is the variant that is predominating the pandemic in India. I call on you to look at this website, the Africa CDC website, which has a dashboard, and subsequently Nikesh in his presentation will share more light on this website, where each time you can go on and track where countries are with respect to generating the sequences. Let me now segue to the situation in India. That way we provide at least a background as to why we are proposing that we intensify our strategies going forward, as highlighted by Dr. Tedros in his opening remarks. But before I do that, let me bring you back the picture of the continent and highlight the area in circle. And I just want to zoom in here for 1 second and walk with me through this very carefully. If you see that area that I just zoomed in, it shows that at the trough of our pandemic, we're recording about 11,000 cases per day. And the deaths were about 300 deaths per day, almost at the same period. Now, let's just keep a mental note of that picture and see the picture in India, which strikingly looks like the situation in Africa. At the peak of the first wave in India, and you are looking at the thick red line, which is a 7 days moving average, they were recording about 90,000 cases per day. They brought down the curve very nicely, but around the end of March, they started recording about 58,000 cases per day, and they have since increased drastically to about 400,000 cases per day. The deaths have followed the same. At the peak last year in September, they were recording about 1,000 cases of deaths per day. Reduced that to about 150 deaths per day in March. But as we speak today, they are recording about 3,700 deaths per day. It's strikingly similar to what the continent as a whole, a continent that has almost the same population size as India, is recording. So what does the India situation translate into the reality in the field? The graph on your left-hand side, or the picture on your left-hand side, shows the hospital beds that are filled. And the red bars there indicate the percentage occupancy. And the blue indicate the vacancies in 3 cities. That is Mumbai, New Delhi, and Ahmedabad. You clearly see that over 80% of the beds have been occupied due to the COVID situation in those 3 big cities. If you now look at the graph on your right-hand side, it shows the same. The red bars are the ICU units that are occupied, and the blue are those are vacant. You can almost conclude that all ICU unit beds have been occupied in those three cities, major cities in India. So that's what happens when you are hit massively with an outburst of COVID-19. At times, it's good to translate statistics or numbers into reality, human lives, and you can see how hospitals are overwhelmed and are running out of beds. And the picture on your right-hand side shows patients being treated in their cars because you just don't have beds anymore to accommodate patients. Oxygen is in short supply across that country, which actually produces quite a good number of that commodity. This slide shows you the crematoriums that are filled almost on an hourly basis in India. It shows you how overwhelming this pandemic can if it takes us unawares. So why are we seeing what we are seeing in India? First of all, the number one lesson is that if we relax public health measures too soon, for example, we organize big religious gatherings, reopen most public places, and begin to crowd together during elections, we are inviting that same scenario into our countries or our continent. Second is the presence of the new variants. Thirdly, the possibility of reinfection because of loss of antibodies. So we are still dealing with a virus that we've learned a lot about, but we are still learning more about this virus. Let me just leave this page by citing this quote from an Indian colleague who says, COVID-19 had not gone anywhere and a tsunami would hit us if urgent actions were not taken. Sadly, a tsunami has indeed hit us now, end of quote. These are some of what you mean by relaxed public health measures, religious ceremonies, where people thought that the pandemic was over, and then suddenly they were surprised. The new variant I've just described is spreading in that country aggressively, more transmissible. For example, the doubling time has moved from 8% to about 16% in that country. That is the rate of test positivity. So just to conclude, what does this mean for us? And as a continent, as we chart out the next strategy. First of all, we have to readapt our strategy and look at strong prevention measures. And I've argued in this presentation that they work, that we are not helpless. If we intensify those measures, then we can actually blunt the situation, a similar situation of the India happening here. Second is to increase our monitoring. When we drafted the first strategy and launched in February last year, we didn't know about the variants. There were no vaccines. So there's a lot that has changed since last year, and that's why we are proposing to adapt our strategy. And of course, treatment. We don't want to be caught off guard with no oxygen supplies. Let me now walk you with 3 slides into each of these. The first of them is prevention. And we are relying on at least 3 things. One is to be sure that the vaccine acquisition is increased and the vaccination itself is accelerated together with enhanced public health measures. Vaccine acquisition is critical. We have set up a platform through the leadership of President Cyril Ramaphosa when he was chair of the African Union. That is the AVAC platform. It is at this point that I really like to make a solemn appeal to member states to go to the platform and secure their vaccines, because we have signed a contract with Johnson & Johnson for 220 million doses of vaccines. Many countries have secured their doses, but several others have not. We need to intensify and develop a risk communication strategy and deploy more community workers so that they can increase our community engagement. The virus is in the community now, and there's not much we can do other than make sure that the community leads the efforts, own the efforts, and continue to be the drivers of this process. Second is to monitor, increase our monitoring. Endorse new tools, and some of those tools will be discussed at this meeting. Encourage member states to report more so that we have a collective sense of what is going on. and establish and strengthen sequencing capacity for surveillance. I've already shared with you the network we established with the World Health Organization that you can build on to understand what is going on in the country with respect to surveillance for genomics. Enhance our diagnostic capacity and contact tracing, and continue to do serosurveys and enhance our surveillance capacity across all member states. This is the dashboard that we've produced at Africa CDC that can give you an indication of where the hotspots are. And it's ranked into several levels, level 1, 2, 3, and 4, depending on the severity, where you can use that to at least address and track where some hotspots will be so that you can increase your response activities there. And lastly, in terms of treatment, to ensure that we have the necessary essential medicines for COVID treatment, equip ourselves with oxygen so that we are not surprised by the lack of oxygen, and employ adequate guidance to ensure that COVID is managed both in the hospital or in household settings. Let me just conclude then on this slide by recalling for you the three key things that we are proposing. Continue to engage in vaccine acquisition, both through AVAC and COVAX, enhance our public health measures, and enhance testing, enhance our surveillance, genomic analysis, increase testing, and adopt a harmonized continental new tool for travel and vaccine certification. And my colleague and friend, Dr. Edem, will have the opportunity later today to explain how these tools have been set up through the trusted travel that we are calling on all of us to endorse them across the continent. And lastly, to be sure that we equip ourselves with oxygen supply and essential medicine so that we are not surprised if we are faced with a situation, similar situation with India. I thank you all for the opportunity to share this update with you. Over to you, Protocol. Protocol, please.
Your Excellency, thank you very much. This marks the first part of our ceremony, our program. Now we are getting into the second session, which is an update on the implementation of the joint continental strategy. This session will be moderated by Dr. John Kengason and Dr.
So thank you, Protocol. And I would like to invite my colleague and friend, Dr. Moeti, to lead us in this part of the discussion. Chidi, please, over to you.
Your Excellency of the African Union, Chairperson of the African Union Commission, Mr. Musafa chairs the Africa CDC board, Honorable Ministers of African Union, Dr. Tedros, WHO Director General, and of course, I'd like to also greet Dr. John Kengason, Director of the Africa CDC, who is my co-chair of the Africa Task Force on COVID-19 Steering Committee. Dear partners, distinguished guests, ladies and gentlemen. It's a great pleasure to join this ministerial meeting at a critical juncture in our collective response to the COVID-19 pandemic and to chair or co-chair this session on the implementation of the continental strategy for COVID-19. It's already been said several times and very elaborately by John with many illustrations that what we're observing in India could indeed happen in our continent. So it is vital that governments and partners invest in and maintain a heightened state of preparedness and adapt our response accordingly. Thank you, John, for presenting that so well. As WHO, we are working closely with the African Union and the Africa CDC in coordinating and steering the delivery of the COVID-19 continental strategy. We are engaging intensely at the political and technical levels, including through the AFCO Steering Committee and its technical working groups, where many partners come together to provide contextualized guidance to member states, which are translated into action. Our colleague from the Africa CDC, Dr. Wessam Mankula, will present the work of the Steering Committee and the technical working groups. I'd like to say on behalf of all of us, how as well to have with us Her Excellency President Johnson Sirleaf and also Prime Minister Clark, who will provide a briefing on the Independent Panel for Pandemic Preparedness and Response. This panel was established because it's been made clear time and again how important it is to ensure that the preparation for, the response to, and the management of epidemics and pandemics is equal to the tasks in its various aspects. This is very much needed at the moment. As the co-chairs of this panel, they've led an independent and comprehensive review of the global COVID-19 response. This assessment will provide an evidence-based path for the future, taking forward insights and lessons learned so that countries and partners, including WHO specifically, are equipped to respond effectively to the next pandemic. So I'd just like to express our thanks to the panel for its work, and especially to the co-chairs for having taken up this task and for having joined us today. So to kick off our discussions, I'll now hand over to Dr. Mankula to tell us more about the actions taken by the AFCO Steering Committee. Dr. Mankula, you have the floor.
Thank you so much, Dr. Muti, His Excellency, President Tshisekedi, Chairperson of African Union, and President of the Democratic Republic of Congo, His Excellency, Health Minister of Togo, Professor Mustafa, His Excellency Moussa Faki Mohammed, Chairperson of African Union, Dr. John Kingston, Director of Africa CDC, Dr. Muti, Regional Director of WHO, all protocol observed. Thank you for giving us the opportunity to share our experience in Africa CDC and the journey over the last 1 year in dealing with COVID-19, key achievement and challenges with the implementation of joint continental strategy through AFCO Technical Working Group and AFCO Steering Committee. So next. Since the beginning of this pandemic, we adopted 6-pronged approach to deal with this pandemic. And usually we modify our strategies and activities based on the progress of this pandemic and how it goes. So we started with Africa Joint Continental Strategy and AFCO Task Force early at the beginning of this pandemic, with the first case reported in Egypt, mid of February. African Union and Africa CDC, in collaboration with WHO, invited for emergency ministerial meeting. In this ministerial meeting, Health Minister in Africa adopted the Africa Joint Continental Strategy as a way for coordinating and operation communication between member states. Also, they adopted Africa Task Force as a continental mechanism for coordination and giving technical support and guidance to the response to COVID-19. This is in addition to a wide range of initiatives that we adopted over the last 1 year, including PACT, Africa Medical Supply Platform, COVID-19 vaccine strategy, and also Africa Against COVID-19 Saving Lives, Economies, and Livelihood. In my next slide, I'll go through all these initiatives. Next. So this is the Africa Joint Continental Strategy. Our aim from this strategy to enhance cooperation, collaboration, coordination, communication for COVID-19 response. And during this time, we have 2 main goals. The first one is to prevent severe illnesses and death from COVID-19 infection. And second one is to minimize social disruption, and economic consequences. And we have also two main objectives: the coordinate efforts of member states, African Union, agencies, WHO, and other partners to ensure synergy and minimize duplication. Also to promote evidence-based public health practices for surveillance, prevention, diagnosis, treatment, and control of COVID-19. Next. In order to achieve these goals and objectives of these continental strategies, the health ministers in Africa, they adopted Africa Task Force for COVID-19, AFCOR Task Force, as the continental mechanism for this coordination and collaboration. At the top of this task force, we have African Union Bureau of Head of States, which include the representative from President of Member State, in addition to African Union Chairperson, and also Director of Africa CDC. Under this African Union Bureau for Heads of State, which gives strategic direction for our response, we have three ministerial committees. One of them for Health Minister, another one for Transport and Logistics Minister, for Finance Minister. Then we have Continental AFCOR Steering Committee that co-chaired with Director of Africa CDC and Regional Director of WHO AFCOR. And then we have 7 technical working groups. Each one focus on certain technical area. We have surveillance, clinical care management, infection prevention control, supply chain and stockpiling, preparatory diagnosis typing, in addition to risk communication and research standard. All these technical working groups, they are working in collaboration with different regional health coordinating committees. Next. For the steering committee, as I mentioned, is co-chaired by Africa CDC Director and Regional Director for WHO AFRO. All the technical working groups chaired by experts from member states, and it has a membership from Africa CDC expert, WHO expert from member states. This is in addition to partners and other UN agency. In addition to this, we have also bi-weekly strategic coordination meeting between Africa CDC, top management, and WHO as well. Next. During the journey of the response to COVID-19, we have noticed that there is decrease in number of tests conducted in the continent. This is why we launched PACT initiative, Partnership for Accelerated COVID-19 Testing, early at the beginning of this pandemic. And we had ambitious target at this point of time. And we targeted within a month, we need to conduct 1 million tests to be distributed to member states and 10 million tests to be conducted in Africa within 4 months. This is in addition to also start training 100,000 healthcare workers, in addition to support deployment of 1 million community health workers to support contact tracing in the continent and also raising the community awareness. Next. We managed so far to exceed even some of these targets. Currently, we have more than 45 million tests conducted in Africa. Africa CDC distributed over 10 million COVID-19 PCR testing and antigen tests to member states. Also, for the workforce development, we managed to provide different kinds of training, either online training or cascade training in the member states and using different platforms. We managed to train more than 73,000 healthcare workers in Africa. And for the community health workers, we managed to deploy community health workers to more than 23 countries in the continent. Also, we managed to develop platform for procurement, African medical supply platform. Next. One of the key challenges that faced the continent at the beginning of this pandemic is to get access to key commodities and key supplies, either for test kits, for IPC supplies, and recently for COVID-19 vaccine. This is why we launched Africa Medical Supply Platform. It's an online platform. All the member states have access to this platform, and this platform includes vetted manufacturing and procurement partners from the continent and from the world. So all the member states will have access to this medical supply and also the vaccine as well. And MSP is open now for having pre-order for COVID-19 vaccine. Next. Then the fifth part of our project, 6 project approach is COVID-19 vaccine. we launched Africa COVID-19 Vaccine Development and Access Strategy, which contained 3 main pillars. The first one is to accelerate African involvement in clinical development. And in this regard, we rolled out consortium for COVID-19 vaccine clinical trials, it's called COMVAC. Second pillar, focus on Africa to get access, sufficient access for the vaccine supply. This include access, include financing, include procurement, and also support manufacturing capacity in the continent. Third pillar related to the regulatory part and the delivery and uptake part. Next. In this regard, His Excellency President Ramaphosa, President of South Africa, established African Vaccine Acquisition Task Team. This is to facilitate having access to the vaccine supplies. Next. And also 2 weeks ago, under support of His Excellency President Tshisekedi, African Union and Africa CDC, in collaboration with WHO, we conducted a large conference focusing on pushing vaccine manufacturing in the continent. Next. And in this conference, we have more than 40,000 participants joined our conference from 70 countries across the world. Next. And the key outcome from this conference, BAVAM initiative was launched. You can move to the next slide. His Excellency President Tshisekedi launched BAVAM initiative partnership for African vaccine manufacturing. This is to push the agenda for vaccine manufacturing in the continent, not only for COVID-19, but also to be expanded beyond COVID-19 and enhancing the capacity in the continent in vaccine manufacturing part. Next. Another key initiative also that we launched last year is Africa Against COVID-19, Saving Lives, Economies, and Livelihood. Yes, COVID-19 is not only affecting health, but also have a great impact on our livelihood and economies. In this regard, we focus on 3 main areas. If we can move next. The 3 areas, first one is to protecting borders and travel. Second one, protecting economies and livelihood. Third is protecting our school and encouraging our kids to return back to a safe school. And we have lots of activities under each one of these initiatives. Let me focus on the protecting borders and travel. We launched a trusted travel platform, which is enable member states to have access about travel restriction across the countries. Every individual can have access to this information during travel, have access to also airline companies have access to this platform. Also, it will be easy through this platform to share authentic information about COVID-19 testing. And also this platform can serve as a platform for sharing information about COVID-19 vaccine individuals as well. Next. So this is how the platform looks like. We can use it for sharing information about COVID-19 testing. We can use it for sharing information about people who are the people that got COVID-19 vaccine as well. Next. Let me also go quickly through some of the key achievements by specific technical working groups. For example, for the laboratory technical working group, more than 13,000 people have been trained on PCR testing. Jointly with WHO, we worked on enrolling more than 488 laboratory for external quality within member cases in collaboration with ASM, organized 44 echo sessions, more than 21,000 managed to develop and distribute many of training and guidance documents. And we developed some of these documents in collaboration with WHO. Next. One of the key achievements also that Dr. John referred to it's pathogen genomic sequencing. Africa CDC in collaboration with WHO Afro established pathogen genomic sequencing surveillance network. This is to strengthen genomic sequencing capacity in the continent. At the beginning of this year, we have only 5,000 genome sequencing. Within the last 4 months, we moved from 5,000 to more than 12,000, and our target to reach by the end of the year to more than 50,000 genome sequencing to be conducted in the continent. Next. The same for surveillance. We managed to train more than 25,000 healthcare workers. Jointly with WHO, we trained 73 participants in 18 member states and also 29 officers from 7 member states. And we developed 10 guidelines and SOPs. And currently we're conducting seroprevalence survey in 17 countries. This is in addition to support rapid mortality surveillance in 2 member states. Next. The same for clinical care management. More than 15,000 healthcare workers have been trained in COVID-19 case management. And we have different platforms for ensuring having clinical community of practice, responding to questions from physicians and clinicians across the continent. Next. And we developed 8 guidance and advisory documents for case management. Also, we developed training curriculum in community health workers, focus on the case management part. Next. And for infection prevention control, we managed to train infection prevention control from 40 member states. Jointly with WHO, we managed to support training in 10 member states. 19,000 participants joined these different kind of training. We managed to publish 12 IPC guidelines and 2 advisory. Next. For the risk communication, we established Africa CDC rumor tracking system. And in collaboration with WHO, we launched Africa Infodemic Response Alliance, IRA. This is in addition to implementation of COVID-19 prevention campaign on social media. Next. For science standard and regulation, we published around 40 scientific updates published. This is in collaboration with WHO, and in addition to partnership for evidence-based response for COVID-19 with wide range of partners. And we launched Africa CDC COVID-19 vaccine dashboard on our website. Next. Some of achievement for stockpiling and emergency supply chain technical working group is to manage the logistic for distribution over 10 million COVID-19 tests, distribution of over 336 distribution flights have been sent to distribute these commodities. We managed to distribute over 1,610 tons of commodities, which worth over 131 million USD. And we managed to distribute over 12 million masks, 9 million doses of dexamethasone, 887 ventilators, 1,420 oxygen concentrator. Next. When it comes to the challenges that we are facing in our response, there are 3 main challenges so far. The first one, challenges about data sharing. Challenges of having timely and regular access for data from the member states. We are tracking the whole continent, and in order to get appropriate decision at appropriate time, so this need to have access for the data from member states. And this data should include the EP data about cases, about deaths, about lab testing, and also the response related data about different kind of information, teams deployed, about capacities of the hospitals, ICU bed availability, and so on. So this different kind of data, once it become available at the continental level, so it's enable us to take appropriate decision and modify our strategies accordingly on a timely manner. The second challenge is travel and border restriction. So there is inadequate cross-border agreements for harmonized implementation of agreed strategies between member states. Each country, they have different policies when it comes to travel and border restrictions. So this also may handle the easy movement of the people and goods from country to another. So it's important to harmonize this kind of policies between member states. Third one is related to the vaccine. So there is a lack of joint regulatory review for faster implementation and introducing new vaccine. Each country, they have their own regulatory mechanism to approve a certain kind of vaccine. So if we manage to harmonize this regulatory review, this will be easier and faster track the introduction of the vaccine in the country. One last thing related to the vaccine, also lack of data about countries' capacities and the slow roll out of available doses once it become available. It's important to to have access to the data about the country capacity. This will enable us to better distribute the vaccine among member states and enhance the uptake of the vaccine by member states. So this is in brief the key achievement, key challenges we're facing so far. Thank you, Excellency. Over to you, Dr. Moeti.
Thank you so much, Mangula. Very extensive account and analysis of a huge amount of work that has been carried out by continents over a year since the was launched. I think what we reflect on in the discussions is the lessons we've learned, and based on the conversation that has already been going on about the continuing risk highlighted by the experience of India, we see how we adjust based on this very solid basis of action and take our action forward for concrete results. Thank you very much. It's my great pleasure now to invite Their Excellencies President Johnson Sirleaf and Prime Minister Clark to share with us the information that they have gathered in analyzing now the results at the global level and what is coming out and suggestions from them about how the world can adjust in different aspects, the institutional level, building capacities, some of the challenges that have been reflected in the South Africa experience, better prepared, able to fund the future. So I'd like to pass the floor. I've seen that President Johnson Sirleaf is connected. Your Excellency.
Thank you so much, Dr. Moeti. Excellencies, honorable ministers, it is an honor to join you today to discuss the work of the Independent Panel for Pandemic Preparedness and Response. Let me begin by extending the regrets of my co-chair, former Prime Minister Helen Clark, who could not join me. I would like also to introduce a member of our panel, Mrs. Precious Matoso, Director of Health Regulatory Science Platform, University of Witwatersrand, South Africa. I commend all of you, ministers, Kengasong, you experts in the field, for the impressive efforts you continue to exert to contain the COVID-19 menace. The pandemic continues to cause devastation around the world. Thanks to you and the efforts of many frontline health workers, many African nations have responded in exemplary ways to the pandemic and are examples of best practice around the world. But the virus is also placing immense strains on the continent's health systems, even as we speak. In May 2020, the World Health Assembly requested the Director General of WHO to initiate an impartial, independent, and comprehensive review of the international health response to COVID-19. And experience gained and lessons learned from that, and to make recommendations to improve capacities for the future. Dr. Tedros asked Prime Minister Clark and me to convene an independent panel to report to the World Health Assembly this year. As co-chairs, we assembled a diverse panel from a range of backgrounds. With the support of our Secretariat, numerous literature reviews, original research, and in-depth interviews have been conducted. We have hosted expert roundtable discussions and heard from many on the front lines of the pandemic response through town hall style meetings. Our report will be launched on May 12th. The main report will be accompanied by a series of background papers, including a summary of defining moments in a steady march from outbreak to pandemic and an authoritative chronology of what happened. The panel has concluded that COVID-19 went from being a localized outbreak to a pandemic because of the myriad of failures and gaps in pandemic preparedness and response. Most countries were not well prepared to respond, despite years of warnings of the need to do so. International rankings of pandemic responses have been shown to be deficient, with many of those who scored most highly having the worst response to COVID-19. Such rankings fail to take into account factors like the role of political leadership, trust in institutions, and the level of social cohesion. Investigations by WHO were constrained by the international health regulations. WHO is not sufficiently empowered to investigate, validate, and confirm a dangerous outbreak rapidly. The procedures under which it operates are simply not conducive to taking a precautionary approach. A public health emergency of international concern was declared on 30 January. The panel has identified a month of relative inaction, with many countries adopting a wait-and-see approach rather than getting prepared. Then, as successive countries' health systems were overwhelmed, a global scramble for PPE and therapeutics ensued. Many countries, including some of the wealthiest, devalued science, denied the disease severity, delayed response, and sowed distrust among their citizens. This exacerbated the crisis, overburdened health system, cost lives, and devastated societies and economies. COVID-19 continues to cause devastation. It has cost over 3 million lives, including those of 17,000 health workers, and will have wiped out $10 trillion in economic output by the end of this year. It has pushed up to 125 million people back into extreme poverty. It has caused immense suffering to women and girls, not least through disruption to sexual and reproductive health services, millions of girls being unlikely to return to school, more early forced marriages, and a sharp spike in domestic and family violence. Our panel will put forth a package of recommendations that we believe, if fully implemented, will enable us to end this pandemic and prevent the next one. The uneven access to vaccination and the emergence of vaccine nationalism are debilitating to the global response. Some countries have purchased enough doses to vaccinate their population at least twice over. We will make specific recommendations on how to immediately increase access. We welcome the recent announcement of United States President Biden on a TRIPS waiver and hope that this will build momentum in WTO. In this respect, we also recognize the role of South Africa in proposing this waiver. Urgent investments must be made in scaling up capacity for vaccine production and in giving access to diagnostics, therapeutics, and oxygen. it was promising to hear the news from the G20 earlier this year to fully finance COVAX. We recognize that the World Health Organization has an indispensable leadership role in this area. But as mentioned before, it is currently underpowered and underfunded by member states. A greatly improved system for disease surveillance and alert is also needed. The current one is an analog system operating in a digital age. WHO must have the clear authority to investigate outbreaks of concern rapidly. There must be clear and transparent criteria set about the declaration of a fake. Currently, funding for pandemic preparedness and response is too often too little and too late. It is necessary to think beyond aid and official development assistance order to finance such global public goods. In transforming the international system, the panel sees a need to build in political leadership at the highest level. Although health ministers and health systems are vital components, pandemic preparedness is a whole of government effort. We'll be putting forward recommendations on how to transform global leadership for pandemic preparedness and response. The co-chair and I look forward to discussing this further with you in the coming weeks. As I stated earlier, our report will be released on Wednesday, the 12th of May. We have a closed briefing for health ministers on May 10, which I would encourage all of you to attend. I would like to end by asking all of you to take this report and use it to ensure that COVID-19 is the last pandemic to cause devastation on the scale we are witnessing today. Allow me to invite Precious to make comments before we open the floor for questions that you may have. Thank you for this opportunity and for allowing Precious to take over.
Thank you, President Siliff. Your Excellencies, honorable ministers, colleagues, and all protocol observers. Yes, we have heard from the Africa CDC about all the efforts that the continent has taken, and also from the WHO regional office and WHO HQ from Dr. Tedros. The guiding principles that I think are going to be important in our future response to make sure that we are prepared for the next pandemic is to ensure that we work seamlessly, globally, regionally, and at country level, but to also recognize that there's interdependence of health, economic, and social sectors, and that they're inclusive of community of organizations, local government, and the private sector. Equity has been one of the key issues that has come up, equitable health services, but also during the response to this pandemic. It must be equitable for and within all countries with a focus on people who do not have the necessary support. It must respect and advance gender equality and human rights, but also we need to recognize that every hour counts as actions need to be faster than the spread of the virus. It must be transparent and accountable, and we must also be ready to learn from the mistakes. The health workers and others in the front line have COVID fatigue, but also our leaders sitting in this meeting have COVID fatigue. We should not be complacent as we prepare for the third wave in some countries, as the Africa CDC presented. Health threats must be elevated to the highest level, and they need to be addressed to the same degree of concern and resolve as all other major societal, political, and security challenges. Most of the issues President Siliv has already addressed. I thank you.
Thank you very much indeed, Your Excellency, and thank you, and I'd like to recognize the presence of my sister Precious in this session as a member of the panel. You outlined for us very extensively the reflections, the approaches taken by the panel, and I'd like to thank you especially for having decided to go and speak to those at the front lines, because only their reflections on the realities will inform very much those who make policies, provide resources of the realities that are there to be confronted. So I'd like to thank you both for this very thoughtful overview of all that needs to be considered as we seek to learn from what you have outlined. Has been an experience that has been very mixed, that has underlined some lessons that we have learned from the past, but frankly failed to take action based on. I'm very hopeful that this time this will happen, and I look forward very much to the conversation at the end, towards the end of this session. Just to add on your urging us to analyze the situation, that WHO coordinated with partners the analysis of the international health regulations of virtually all of the countries. The gaps are known, plans have been developed, and just to underline what you said, they need to be invested in now rather than later as we face the next pandemic. So we hope that we can learn from this experience. We look very much forward to your providing all the reflections, the recommendations that you are making as a panel next week, and to learning from your reflections and to taking those actions forward into the future. So it's my pleasure now to hand over to my co-chair or co-moderator, Dr. John Kenderson, to run the rest of the session. Thank you.
Oh, she's a David, you're supposed to
Hi, John, as agreed, handing over to you for the next
Yes.
part.
No, I'm on meeting. Sorry, it's just thank you, Chidi and Excellency President Ellen Johnson, for that. And Precious, good to see you. Good to see you, and the nice presentation. I just wanted to leave the floor open for the questions or remarks to Her Excellency. Take the unique opportunity that she's here to hear comments from and feedback from the audience, which is really about 400 people are present on this platform and other outlets there. It will be a missed opportunity not to get remarks from the Excellency on her reflection on where do we go from here as a continent. What does her remarks relate to what we are doing on the continent, especially with vaccine and vaccination on the continent. We are working hand in hand with COVAX. The African Vaccine Acquisition Task Team is there. President Johnson talked about a vaccine inequity, which is clearly a big issue there, and I hope it will feature prominently in her report coming up next week. But without further ado, let's open the floor for, we'll just do the hand raising. I will check the hand, using the little yellow hand to ask for the floor if people have comments there. So I'm checking as I'm waiting for people to just weigh in. So I see 4 hands, but I don't see them here. Okay, yeah, good. Nala Suleiman, please. Then we go to Sarah Jevons, and then Chiwe. Let's take those three questions first.
Hello?
Yes, please, go ahead, please. We can hear you.
Yeah. Okay, thank you, Dr. John. Thank you, Dr. Tedros. Thanks, Ms. Johnson, all of the presidents and representatives. Pandemic make us one hand, and everybody will think about the others before he think about himself. Nahla Suleiman. I was running the with my other colleague team in Sudan with the ICC managers, and we start the situation of isolation and treatment center for COVID-19 at the beginning of the wave in Sudan. But my point that before we go to that isolation to be started, we do have history report from WHO that online at the beginning of the wave in the world that our country is zero. But unfortunately, when we opened the border, and the border was open because there is one flight hanging for 48 hours, and you know the political leaders, those who make the decision to open the airport, then we start to have the cases. Now in Sudan, we have the third wave. We have the same situation now. We do have citizens in India. We do love India, but my concern that I wish and I hope the decision maker sounds, either WHO or African Union, CDC, World Trade Center, those who will have impact on the political all over the countries, that when they have no cases, they will not allow cases to enter. We do have now the variant was changed. So this is exposed us because I'm frontline. I was being in charge as an IPC head of the departments, and at the same time IPC professionist. We don't have front healthcare workers. They would like to come and join. So we do every job. We do every job for the patient to save them. We start the critical care areas. We establish a dialysis unit. We establish all the need for the patient to save them. Because any wrong decision from the political leaders now with the current situation of the pandemic, it is safety of the person and safety of the patient. I will be highly appreciate if we could hear that. No political will take decision only for their country. We do think about patient safety, because save life. My second point, any gap in the preparedness will happen. All it is conflict. We have to respect each other opinion, but we do have to have the standards that if the countries will not follow that, they will expose their nation to danger, then they should be penalized from the top. And thank you for the opportunity, and wish the pandemic will be over. Thank
you. Thank you for that very, I take that were suggestions and recommendations and not necessarily questions. So just Sarah Jevons and then Chiwe, then we'll open that up to Her Excellency or anyone else to respond.
Thank you so much. I'm Sarah Jarvine. I'm a journalist with DevEx. Could President Sirleaf please provide more information on what sort of recommendations there are for WHO to reform to become more effective in responding to epidemics? Thank you.
Yes, thank you. Let's go to Chinwe, please.
I'm calling all the way from Nigeria. And my own question is out of curiosity. So, as a president, is the AstraZeneca vaccine that is in circulation presently in Nigeria? And with our RCC agents, it's come to realize that most times, I think people have more trust in the Johnson Johnson vaccine. So I'm just asking, when is the Johnson vaccine expected to come to Nigeria?
We have a challenge hearing you. I think none of us heard you. So if you can adjust your microphone a little bit, and we'll see if that will help.
Hello, can you hear me now?
Yes.
Hello, can you hear me?
We can hear you. Please go ahead.
Okay, my own question is out of curiosity, because as of present, is the AstraZeneca vaccine that is presently in circulation in Nigeria. I'm obviously calling from Nigeria, and with the basic RCC engagement, I've come to realize that I think most people have more trust in the Johnson Johnson vaccine. So I'm just asking, when will the Johnson Johnson vaccine be expected in Nigeria? Thank you very much. Over.
Thank you. We now hear you. Let's set 3 questions. Let's get a question from or comment from Moise Kitete. Please ask your question or share your comment.
Oui, je suis à la ligne. Je voulais juste savoir, hier ici à Kinshasa, on a...
Thank you very much. Here in Kinshasa, we have discovered a facility that are giving out false COVID-19 vaccination results. Therefore, I would like to know, how can we limit cases of these false COVID tests in order for us to cut down on the propagation of the virus? Thank you.
First series of questions. Excellency, there are some questions for you, and then I believe Chidi and I can answer some of the questions on the specifics of vaccines, and also the question from Moise as well with respect to the travel and tests. Excellency, let's start with you.
Thank you. I think, first of all, given the devastation caused, our report will expect that there will be some kind of political declaration to which all countries will commit on carrying out the recommendations. We believe that there will be a council who will be recommending that will comprise a level of political leadership that will have the power to be able to put some of those recommendations into action, and will be able to monitor the performance of all countries to ensure that the objectives are met. We will put forth a financial instrument that will call for contributions based on capacity to pay that will be sufficiently in its totality, not only to address in the short term what is required to combat the virus now, but in the long term to prepare to avert any further pandemic, including flexibility for surges with a procedure that would be without going through long procedures, as can be the case now. We expect as I said, there will be means to strengthen WHO in a very substantial to enable them to undertake the task. And we hope that an overall convention will be agreed upon by the member states. All the recommendations. If I seem a bit halting, it's because the report and everything in it will come out on May 12th. But I think so. I've given insights on some of the key recommendations that will come for the detail. We would like to wait until May 12th to get into them point by point with all the details. So I hope I've been sufficient. And let me just say that looking at what Dr. Kengesong has put forth and Dr. Moeti today as a roadmap for all of our countries, if that roadmap is adhered to, I believe that our countries, which has fared, we would see enhanced results from all of our countries. And I just ask everybody to also, in all your think about compliance. We can have all the supplies, we can have them properly distributed, have all the workers, but if we do not convince our citizens on the need to be able to get the prevention, we don't get the results, some of what we're finding in my country today. So let me thank you all for this opportunity to have us just brief you, and we look forward to the next briefing, which is set for May 10th, and for the report May 12th, when you get all the details.
Thank you, Excellency President Elif Johnson. Precious, is there anything to add before we go to Kidi for her reflections?
Yes, just to say that we've also recognized the importance of the regions, and that with the call for access, that the struggle to obtain basic protection and medical supplies during a pandemic has actually shown that at different levels you need to be prepared, but we also need rapid and dedicated financing at right scale that can ensure that appropriate tools are available. And those tools, of course, whether it be vaccines or diagnostic tests or therapeutics, it's important that we do not just focus on two, vaccines and diagnostics, but also recognize that therapeutics also require certain investments. Thank you. I think those are the things that we are highlighting without also giving detail. Some of the things will come out in the report. Thank you.
Thank you, Precious. Chidi, any reflections on the questions on vaccines?
Thank you very much. First, again, a profound thanks to Her Excellency and also to our sister Precious, really, for dedicating the time for sharing this reflection with us. I think as far as the vaccines are concerned, there was a question or a concern about people having trust in certain vaccines and when is another vaccine going to be available. I know that, and I think you said yourself, that through the AVAT you're procuring the Johnson & Johnson vaccine. But I think the point is how to build people's belief in effective vaccines that are available. So for example, of course, we've had a very difficult few weeks with some vaccines, the AstraZeneca vaccine, for example, showing some adverse effects, and countries' uncertainty about continuing to use this vaccine or not. There's been a lot of investment in analysis of the data and information to people. I think what is very important is for us to understand people's views, beliefs, fears about vaccines, to really get out there and to obtain the information about what people are exchanging and to address these, so that when there is an effective vaccine available on the market, people don't fear to use it, because this becomes a big problem. We in WHO, working with the Africa CDC and others, have established a so-called infodemic platform where we are tracking on the social media and in other means what people are saying, thinking, fearing. What I think needs to happen better is how to translate the messaging to address these fears, some of which are not based on facts, in such a way that people understand them in unscientific ways, so to speak, so that people have access to this information and it changes what they feel, and through trusted carriers of the message. It is fine for me as the regional director of WHO to go on TV and say something, but it's different if it's the local priest of a church, if it's a leader of a women's group. So we need to get this work down to the grassroots level through trusted carriers of the message and affect and influence people so that they're ready for the vaccine. If I may say one comment to our colleague Nala from Sudan, who was expressing concern about border closures, and the colleague who expressed concern about Indian people who came into the country. My view is that if we carry out effective public health measures of detection at the borders, it can influence the decisions that have to be made about drastic measures like lockdowns and closing borders. I think our leaders have constantly needed to balance the public health needs against the economic needs. And it's already been said very eloquently what a profound economic impact has been had mainly by the lockdowns and stopping travel. So that always has to be taken into account. And what is needed is what was said by President Johnson, by Dr. John Kenasong as well. The public health measures have to be meticulously put in place, consistently put in place at the level of individuals, which we need to support in the public health system, starting from the most peripheral level. And we need to really monitor what happens and use the data to inform decisions and actions in real time. This is what I'd like to say. Thank you.
So let me just add my own comments to that and to what Chidi just said, is that we should be very careful that we do not make the people the enemy. The virus is the enemy, and which means that if someone is traveling with a valid PCR negative test, that person is not an enemy. It is the virus that is the enemy. So that is why we last year, if you recall, we launched what we call the Trusted Travel Platform that many countries and airports and airlines are beginning to use now, together with Panabaus and Econet. And that is the platform, one of the technologies that will be discussed this afternoon that we should all endorse. That way, the results are trusted, and we begin to target and focus on the virus rather than on the individual. I just want to say this, that the variants are telling us that they can transmit very quickly, but it's the same public health measures that we have to put in place to avoid the variants. So we don't have any set of different measures that will be applied separately for the new variants. If we just do the right things, the public health measures that we've all know work, and then target the virus, not the individual, then I think we will get the issues that we have are beginning to have now, where we are discriminating countries of origin and people from certain countries would diminish. I think that is important. Second is we, as the African Union, have secured signed contracts for up to 220 million doses of the Johnson & Johnson vaccines, with an option of increasing that to about 400 million. It is my strong appeal to all member states that they should go through the AVAC platform and secure those vaccines. The delivery period is the third quarter of this year. We hope that it can actually happen sooner, but that is, that is the sure way to guarantee that you have your own future, your own health security in your hands. So it's a strong appeal to all the ministers on this platform to, for those who have not done so yet, to go to the platform immediately to secure the vaccines. The Afro-Exim Bank has taken a commitment to underwrite this, and if they put in, their board have approved up to $2 billion that it will be available to support this process. So please, let's make use of the vaccines that we have, and know that we've all agreed as a continent that we will vaccinate up to at least 60% of our people. So let me take the last set of questions, since we have just about 8 minutes. I thought I saw Minister Austin Dembi's hand up. Minister Dembi, please, if you are still there, please ask your question. Then we'll go to Matthew Ahmed, and then Richard. Unfortunately, we have to draw a line at that because we are approaching the time allotted for this session. So please, Minister Dembi, if you are still with us, the floor is yours.
Okay, the minister is indicating in the chat that he's having difficulty accessing his microphone, John. So
Okay.
Somebody else while he gets sorted.
Okay, let's go to let's go to Matthew Ahmed. Please, over to you.
Can you hear me?
We can hear you, Matthew.
Thank you very much. Well, President Johnson alluded to my question, and I think Dr. Modi also. This has to do with the public awareness issue. I have been raising this issue at the AU COVID Response Fund, BOT. I believe that one of the key challenges we face in Africa, I believe in most of our countries, is that at the grassroots level, there's still a huge lack of awareness. And this is being compounded by the increasing social media posts we see, often said to be by medically qualified people, that is against the vaccines in particular. And certainly against COVID. I think there must be a massive public awareness campaign across the continent. And I wanted to ask if the panel has any strategy or is developing any strategy for this kind of massive awareness that will counter the social media negative campaigns that we hear. Secondly, I also want to ask what information is currently available on the Partnership for Africa vaccine manufacture. I think this is very critical at this moment to mobilize our people. I chair the African Manufacturers Association and the Nigerian Manufacturers Association, and I believe that this initiative needs to be promoted very strongly beyond the public sector, even at the private sector level. Thank you.
Good. Thank you, Matthew, for that comment. And you've always been consistent and vocal with that at the COVID response steering committee or advisory board with President Orama. Let's go to. So we'll come back to your question. Let's go to the next person. Ganazi Richard, please. Mr. Ganazi, if you are still on, please ask your question or share your reflections. So if not, let's move on to the next person, Sahan, who is up.
I think the minister is okay now.
Okay. Minister Dembi, please, if you are on, Excellency, the floor is yours.
Thank you very much, John. Thank you very much, Sidi. I think this is really just an inspiring meeting today, and I really just want to applaud all of the panelists and the leadership that you've shown so far. I think right now for us in Sierra Leone, we have a bit of a moral dilemma where we have some vaccines and we've prioritized the use of these vaccines. However, since these are 2-dose vaccines, we're worried now if we use up all of the vaccines that we have and then don't have the follow-up vaccines when we would need them the most. So our dilemma is, what are the interim measures that the AU will help us with, even as we look for the Johnson & Johnson products that will come later in the year. We're ready. We've reduced the eligibility age to 40, and we're only using about 17% of our vaccine stock. And we'd like to reduce the eligibility age to about 18. And we think that that will absorb all of our stocks right now. And we worry that we may not be able to follow up even after we raise the demand and we raise interest in these vaccines. So how do you plan to help us out? Over.
Thank you, Mr. Dembi. Let's go to the next hand and the last one. Unfortunately, because of time, Simano Sekati, please ask your question.
Thank you very much. I joined the meeting very late. Maybe my questions have been addressed. I have two questions. One is, I saw in the presentation that outlined the challenges that face us, that it's about the rollout. But in my country, in Lesotho, the biggest challenge is actually delivery of promised doses, particularly from COVID. And I've just heard from the AU that the delivery will come towards the third quarter of the year. But can we get absolute dates or precise dates on when these deliveries can be made? The second question relates to the development of vaccines in Africa. Do we have enough muscle to request for the removal of restrictions on the patent so that we can develop our own vaccines in our own countries or in Africa at least? Thank you very much.
Thank you. And let me attempt to respond to some of those questions so that, because I don't think any of those were directed to Her Excellency President Ellen Johnson. So with respect to massive campaign, the question from Masu is, yes, I think if you look at the strategy we are proposing, and which aligns very much with what Dr. Tedros was outlined at the start, is really engagement with the community. I mean, we really have to develop strategies to engage the community and risk communication. I think that should be a cornerstone of our adapted strategy going forward, because we have to admit that this virus is circulating widely in the community. The sero prevalence data speak to that. I'm happy that in the next few minutes, Dr. Chikwe from Nigeria will be here and can comment on some of the findings they saw in that country. We have done our own studies at the Africa CDC across multiple countries, and many, the sero survey is showing that many more people have been exposed. It means the community engagement has to be very, very much enhanced. With respect to manufacturing of vaccines, yes, you're right. I mean, the partnership for African vaccine manufacturing that President Tshisekedi launched about 4 weeks ago is moving on. I mean, there's various consultations are going on, different partnerships, including with the private sector, is ongoing. And we hope that in the coming weeks, some clarity will begin to emerge with respect to which countries, where. And the good news we just learned this week is this, the waiver, which will go a long way. It doesn't solve the problem immediately, but at least it's the right step in the right direction. And on that note, I still want to join my voice to that of others to really congratulate the strong diplomacy applied by South Africa. The African Union issued actually an executive council decision in support of that. And I believe there was also at the head of state assembly decision on that. Minister Dembi talked about the situation in Sierra Leone, which is not only unique in Sierra Leone. And I'll invite Dr. Moeti to speak on this as well, that the vaccine situation is extremely complex now because of the situation in India. We were hoping that we're hoping that through the COVAX facility, we'll get more vaccines from India.
No, I'll check it.
Sir, could we ask that you mute your mic so that we don't have interferences with the conversation? Yeah, we're hoping that there will be continuous supplies through COVAX from India, but we are all watching in total horror and disbelief what is going on in India, and we don't expect that vaccines will be shipped out of India anytime soon. But we remain optimistic that through the COVAX facility, other avenues for vaccines will be secured. When we negotiated for the AVAC to August, it was based on the understanding and an assumption that the countries will be covered to achieve the 20% of the vaccine through COVAX, through the continuous supply mechanism. But what has happened in India was completely unpredictable. So if I were you, what would I do? I mean, I'll kind of prioritize healthcare workers and maybe those with underlying diseases and just limit the vaccination to that. And of course, continue to create awareness, but with expectation that the vaccine market situation will begin to open up around the beginning of the third quarter, if not earlier. The colleague from Lesotho talked about delivery dates. For AVAC, you can be sure that the beginning of the third quarter will be, that is end of July, beginning of August. We are working very hard to see if we could accelerate that delivery timeline, but nothing is really guaranteed. Do we have the muscles to request for pattern shift? I don't think it's about muscles so much. It's about us as humanity doing the right thing at the right time. I've said this in several of my press briefings that everybody, all of us, want to be at least recorded in the right side of history when the history of this pandemic will be written, that we did the right thing at the right time to ease the problem of vaccine manufacturing and other commodities that are needed to fight this pandemic. So what we saw from emerging from the United States earlier this week was a welcome sign, and we hope other countries that are still not in the mode of moving in that, join the movement and make it easy for us as humanity to win this battle. Maybe I'll stop here and let Chidi comment, and then we can move forward. We are already 5 minutes over our time allotted for this session. Chidi, please.
Okay, thank you very much, John, and thank you, Minister Austin Dembi, for that question, which is a worry for many members. As we have seen, first of all, admittedly, the production capacity is initially estimated, then turned out to be an overestimate. And then I won't refer to the India tragic situation and the huge amounts of vaccine. What we are advising in WHO is that the countries should vaccinate as many people as possible with the vaccines that we have already, because of course we're also concerned a little bit about the expiry dates. At the same time, there is a lot of work going to source additional supplies so that we don't have countries falling beyond the period, beyond the 12 to now perhaps 16-week period of people who got the first vaccine. So the WHO guidance at the moment is to use the vaccine and vaccinate as many people as possible, understanding that you may not get then optimal levels, but still it is best to take that opportunity. At the same time, we're working very hard within the COVAX platform to try to source the vaccines. The Indian government has and the Institute of India have responded positively despite the problem that they have and are really undertaking to do their best. I think at the same time, we also need to, and I'll say this because this is a meeting of the African Union where we have political entities who have relationships with the wealthier stockpiled many hundreds of millions of doses of the vaccines that could be seeing some movement now in some promises of dose sharing by sub-countries. We would like to sooner a very crucial point where some of the vaccines, especially the AstraZeneca vaccine that has already been used in African countries, could really make a difference in terms of the second dose. So we hope to see some movement there as well. And then finally, to the Honorable Minister, I think, or colleague from Lesotho, we are trying through the COVID to be as precise as possible about dates. I think this is not a question I can respond to here, but we are constantly updating information about it as prepared as possible for what is coming. It's a difficult situation, we know, but I just like to urge here that can we work together to persuade those who have vaccine supplies that they are not using to provide them, to particularly. Thank you.
Thank you so much, Chidi, for that. Let's conclude this session and then move to the next, the last of this particular, this topic, and move to the next topic under this session. And we have two distinguished colleagues on this to discuss this session, which is really about data sharing, the need to share data in a timely fashion. And without data sharing, it's like we are piloting a plane without a rudder. So we are very fortunate to, Her Excellency, that.
Yes, please. May I just make one?
Okay, please.
One small, well, two issues. One on awareness for more leadership levels in society to be able to improve awareness. Leadership is the key. As regards the waiver, the recommendations call for a meeting of the pharmaceutical leaders, of WHO and others to agree on voluntary licensing and technology transfer, and a call for the waiver of trips within 3 months if those agreements are not made for the voluntary action. We include transfer agreements. Thank you. Just wanted to make those points. Thank you very much. And thank you for the opportunity to the two of us.
No, and thank you so much for creating the time to come and discuss the very night working with you all to implement the outcome of it. Bye-bye. So it is my honor to invite Dr. Chikwe, who needs no introduction. Dr. Chikwe is the director of the CEO of the Nigeria CDC, and Dr. Nat, the deputy director of the National Institute of Communicable and friends for many, many years. They've been outstanding in the battle against this terrible pandemic. And I really hope that we would win this over, Natalie and Chikwe, soon, and be able and make these meetings face to face. I miss our meetings, our usual NPHI meetings face to face, the inspiring discussions. But we really wanted you to discuss the importance of data sharing for economic and health security in Africa. And this is going to be a discussion. I mean, and we'll start with Chikwe to share your thoughts on what we should be doing as a continent to share more so that we can use the information in a timely manner. And then we go to Natalie and just have your reflections from where you sit. So let's start with Chikwe.
Thanks, John. I think we'll actually start. We decided to start with Natalie this time, but I'll share the screen here, and then Natalie will talk through the first few ideas that we've put together with your kind permission.
Yes, that will work.
Okay, so thank you, Dr. John, for the kind introduction. His Excellencies, Honorable Ministers, Honorable Directors, prestigious guests, colleagues, and friends. Thank you for giving us this opportunity for data sharing in the context of improving our economic and health security in Africa. Certainly the journey has begun a few years ago, in 2017 already. Next slide, please, Chikwe. When the NPHIs and Africa CDC crafted the strategic objectives for improving surveillance. This is absolutely a pivotal point for advancing our intention of prevention, preparation, detection, and response to this outbreak and any outbreak. Our objectives at that stage, under the leadership of Dr. John Nkendezong, were to design and implement a continental data sharing platform for all member states by linking the Public Health Institute's activity within each country through the networks and the existing networks and the Africa CDC. We also, as one of the strategic objectives, identified the organization, the convening, and the supporting of working groups to enable and achieve our first strategic objective. That was realized by a meeting in June in Liberia in 2018, where the group of technical experts got together and crafted an action plan. Certainly the need for supporting of training through the regional operation centers for informatics, GIS systems, network domains, data analytics, hardware and software, and improving laboratory capacity was identified as an acute need. And there was a thought at that stage to at the regional collaboration centers. So fast track forward. Next slide, please, Chikwe. These were the action principles for action across Africa, which we identified as key priority areas. The acceleration of all our existing data throughout all systems. And by using accelerating, we could strengthen healthcare systems, laboratory capacity, and health system capacity. And the capacity building initiative was at the heart of all our efforts in collating data, processing it, analyzing it, and it relied on human capability to information through to utilization. But a fundamental principle was there had to be transparency and trust. How do we ensure that there's data protection, that the individuals who we're collecting data from are protected, and how do we utilize sensitive information to advance public health policy interventions? All data undoubtedly needs to be used for impact assessment to lead and direct program implementation. And the presentations earlier today, made so eloquently by our colleagues, have all relied on good quality data. But to benefit from the systems, we need one architectural platform. And Africa CDC has advanced these data architectural platforms through the various Africa CDC portals that currently exist on the website. but importantly, to ensure that nobody is left behind, where every African counts, every death counts, and every birth counts, and that we know exactly that baby born, what is the lifelong history of data through the journey of that individual through the healthcare system. So next slide, please. And what has been our experiential learning during the COVID outbreak? We have rapidly had to accelerate our experiential learnings of trying to implement a policy framework that we had envisioned. And some of the key lessons that we learned are bullet pointed in the slides, the next two slides, but are certainly not comprehensive in capturing all the lessons learned, but some of the highlights. Data is just a tool. It's a tool to enhance and promote science. And I think we need, as a continent, possibly to reconceptualize our use of data. It's a promotion tool for science that's going to inform policy decisions, good, sound policy decisions, to review our interventions and the outcomes. What is the outcome? And how has our data supported a good outcome of an intervention? Sharing of data is part of our research continuum. And citizen science, our lesson in COVID has been citizen science should not be underestimated. We need to leverage on the capacity of our citizens in engaging with data and interpreting the data, and we collectively interpret it to make sense of the data. There are hundreds of well-established networks that exist on the continent. We need to leverage on those existing networks, enhance them, and make them work as part of an integrated data management system. Certainly, the balancing of generation of data and policy needs to be constantly weighed up. But also, we're not utilizing at this point in time economic benefit cost analysis, costing data on the impact of our interventions. And I think this is something, as we move forward as a continent, we need to build and strengthen capacity. Certainly, the sharing of data on equitable terms, and again, weighing the risks of collecting data versus the benefits. And it translates then into the ethical imperatives and the relevance of why we collect data. Certainly, this platform is here to engage in the challenges and opportunities. Data quality issues remains a concern. And why are they a concern? Some of them relate to basic definitions. How we interpret, for example, as a definition of a COVID death, are we all on the same page? Not local transit case, or is it an imported case? We need to fundamentally, and our foundational, foundation where Africa CDC can play a key role in that with our partners and with WHO, is defining the definitions of what the data we collect, whilst constantly ensuring frameworks within each member state is upheld. And that we can only do with our community engagement that has been already alluded to in these discussions. Certainly, our moving from ownership of data to curatorship, grounded in the fundamental principles of trust. Apologies, the trust dropped off there. So as consideration for a way forward, we are in an ideal position now to craft Africa's research agenda. What is our capacity to generate our sustainable long-term data storage principles across the complete data value chain? How do, at grassroots level, a sister or a facility manager, How do they utilize good quality data to process the data, to share it, to engage with it, and to implement change? And how do we focus on our integration with agriculture, our environmental data, social change and social behavioral change data, health and health economic data? And that data harmonization needs to be a conscious, deliberate decision to integrate different technologies, to integrate different databases and different structures to ensure good quality data. And the unique identifier where we have mobile populations, migrant populations moving across countries, across member states, and how are we going to utilize longitudinal data to inform policies if we don't have a unique identifier that is unique across the health system, whether it's a laboratory system, whether it's a hospital system, whether it's a district health information system, whether it's at primary healthcare level or in the private sector. Those unique identifiers have got to be identified, and it's a fundamental principle across all our data systems to have that unique identifier. Our conceptual differences and definitions is something that we need to unpack. How do we define a household in a rural versus an urban area, from one member state to another member state? What do we define as educational attainment between our member states? And what do we define as socioeconomic status? These are fundamental definitions, principles, which are going to assist us. Our health data system must now start focusing on our non-communicable diseases, our antimicrobial resistance, the vaccine-derived polio, and our other programs that have been compromised as a result of COVID. We're starting now to see emergence of vector resistance, and we're going to have upsurges of malaria. But we ask ourselves a critical question. Who is responsible for data curatorship? And then what? What do we do about this data? Because whatever we do, we need to harness this data for public health action and for improving our public health systems. I thank you for the attention of the platform, and I thank you for giving us this opportunity to share some of our experiences. I hand over to Dr. Chick.
Thank you very much, Natalie. And again, I'll join Natalie by really thanking John and for really your leadership and pulling together this event today, and your leadership in the last 1.5 years and beyond. So I think Natalie has really made the case very clearly. I thought just to leave, pull together the conversation around 5 key points. Firstly, to really think about this in terms of having a single platform. So from countries, it's impossible for us to have means and mechanisms to share our data, to collaborate with the various global and regional organizations whose authority we agree with, whose need is obvious, who we want to collaborate with, but obviously we can't have different mechanisms of sharing data with different international collaborators. So we need to find one platform through which is trusted, through which we can establish and agree on the parameters, the confidentiality and all the other issues around it, through which all our data will ultimately be shared. Move away from any short-term ways of data collection, no Excel, no paper, no Google Forms, and really agree on the standards for collecting data that will lead to the confidentiality and the confidence through which this data will be utilized. Secondly, how do we integrate new data sources? Whether it's social behavioral data or even things that have happened in the pandemic. ICU beds in a country. things that have never really been part of a public health surveillance architecture that are now obviously relevant for the work we will have to do in the future. Number of dialysis machines that are functional if you have an outbreak of a viral hemorrhagic fever such as Lassa in Nigeria, which requires dialysis. So these are the things we now have to think about how to integrate into our data collection systems. And Natalie included the agricultural data from the agricultural sector, the animal health sector, through the principle of One Health. All of this we need now to think about. The third point is maybe the most critical of all, is building trust across all of us, across our institutions, across the individuals. Trust cannot be built if we're not working together. So we have to work together to have confidence in each other to build that trust. So like John said, sometimes the level of trust that we need requires something beyond Zoom. So we look forward to going back to a world where we can actually meet so that we can learn to work together, and through working together, build that trust that we need in each other. Fourthly is who does all of this. At the country level, it's pretty clear. If there's no other lesson from this pandemic, is the critical role of national public health institutions in operationalizing all the great ideas that we have. And in a way, that word institute is a little bit of a challenge for us as we move forward, because it leaves us with the idea that there's an institute that is mostly science-oriented, which it should be, right? That is responsible for collection and making intellectual sense of the data, which is all true. But the primary purpose for this data is disease control. So we've got to find a way of giving our NPHIs the teeth that they need, the authority that they need, the mandate that they need to move from just research-focused organizations to also adding the disease control part of what their mandate should be. And finally, this idea of collaborating across countries, whether it's through the RCCs of Africa Center for Disease Control, using WHO established platforms. We've got to find ways of breaking our language barriers, political barriers, and really work on the technical level to collaborate so that the ease of access to data across regions, across the continent is made as simple as possible. So I thought, just to summarize Natalie's excellent presentation that we put together into these 5 points. And John, I hope that is a good segue into the conversations which we now look forward to having with all the attendees. Thank you very much.
No, wonderful, Chikwe. It's a wonderful segue into the conversation. We have to share the data, not burden countries, be trust. Trust capital is extremely valuable in this. And without data, we fly blindly. So Kofi Annan once wrote in Nature, one of the Nature worldview, and I remember that vividly. So very well summarized. So this brings us to the open question discussion part of it. Let me go back to the little yellow hands and see who is up. Okay, good. Motayo, good to see you on the platform. And greetings from Africa CDC. Again, we'll go to secondly, Naha Suleiman, and then Kennedy Malama. We'll take those three first before we take the second set of questions. Motayo, please.
Maybe on mute.
Motayo, are you on mute? If not, Naha Suleiman, let's move over to you while allowing Motayo time to fix her.
Thank you for the opportunity. I have two concerns. The first concern regarding the artificial intelligence. What are the implementation do we expect it to happen in Africa? Because we do know some countries now apply it and it helps them on the tracking system. The second point, we do have gap for the data information documentation because we do have students in all the institutions and they do have their graduation research thesis, but it's not documented like we do to have to track, for example, my specialty in the critical. So we need to track all over the country states for how many numbers of ICUs, how many number of beds, how many numbers of machines are working, because they do have they have machines. It is new and it is working, but unfortunately they don't have a biomedical engineering to do the follow-up, so it will be as nothing. Plus the system itself for the tracking of the reporting the unused equipment that is affecting the accurate number. For COVID-19 experience, the patient when enter one center, this center should be full infrastructure complete. The patient will be in emergency room, will be transferred to ICU or hemodialysis or step down units. Then he need a highly critical ICU. Then during the highly critical ICU, he need the dialysis. So dialysis unit should be ready. After discharge from those units, he has to be in step down units. Then he has to be in the floor until discharge home. So my recommendation, all the isolation centers for COVID-19 is still ongoing. The infrastructure should complete all because we will save the patient transfer. And by this, we can easy tracking how many numbers of equipment missing. We do have a problem with the neonate. Examples in Sudan, Jabra Center was maintenance for the second time and transfer. Then we do not have an ICU, which is neonatal ICU. We established with the support of the UNICEF, with Federal Minister of Health, to establish a neonatal ICU. We have to think about the mother. So like the complete system will be in one area, it will support. And thank you for the opportunity.
No, great. I mean, thanks for those comments. Let's go to, I just asked that all the colleagues, you keep your comments brief so that we can take as many as possible for Natalie and Chikwe to address. Was that Kennedy Malama? And then Ismail Sabu. And then we end up with Ngabo Zima.
Thank you, John.
Close the floor on that. Yes, please. Kennedy, over to you.
Thank you very much, John, and just to commend you for the exemplary leadership on the continent, and also to acknowledge WHO global and also at regional level. The issue of data sharing is so critical to the thinking of the last pandemic. But even in between, we need to ensure that we don't scratch on top. It's clear that no state is safe until we are all safe. But what we see, we come up with very, very robust strategies for now to share data. But at the end of the day, compliance remains weak in some aspects. We also see member states sometimes completely failing or refusing to share data, which can go a long way in prepositioning regions and indeed the continent to respond better. So as we discuss this, we also learn lessons from robust systems. The regional integrated surveillance information and laboratory networks, for instance, a lot of potential, but it can only be responsive and helpful to all of us if as member states, we are submitting this information timely, correctly, consistently, and in a complete manner. So to us, John, the key question is, within the spirit of solidarity, how do we make member states compliant? And those who are not, what action can be taken? Because it would be pointless to talk about data sharing, robust systems, huge investment, but at the end of the day, the data is not available for decision making. Thank you very much, and I commend Chikwe and Natalie for those very important insights. Thank you very much.
Thank you, Kennedy. And then let's go to Ngabozima. Ngabozina, please, the floor is yours. If not, Tariq. And then we take a Serge Blaise.
Thank you so much for this opportunity to ask my question. I'd like to thank the presenter for the good presentation, and would really like to know, what are the real factors behind the lack of or none of data sharing, what really the factors behind the resistance in terms of the data sharing in Africa, because data, reliable data is the only thing we need for long-term planning. So what are the factors behind resistance in terms of non-data sharing? That's one. The secondly is, what is the capacity of Africa CDC in terms of storage, the capacity of storage and security for data shared for long-term planning? Thank you.
Thank you. Excuse me. Tariq and Serge, and we close on those two, and return it to Chikwe and Natalie for response.
Thank you very much. And thank you to the panelists. I'm just wondering, in hindsight, is there anything Dr. Chikwe and Natalie would do differently?
Thank you. And lastly, Serge, the floor is yours.
Thank you very much for the presentations. And my question is about you. In one of your presentations, you mentioned that there are lack of data about countries' capacities. So, what are the way to overcome those difficulties you face during the implementation of the response in this outbreak? That's the first. And secondly, we found, I'll go back for the vaccine, we found that there a slow rollout of vaccine when available in some countries. What are the way forward to overcome those difficulties? Thank you.
Wonderful. So we've taken enough questions and given the time constraints, we'll go back to the panelists to respond. Natalie and Chikwe, over to you.
Natalie, do you want?
You can go ahead, Chikwe. I'll follow you.
Okay. So thanks. I think these are all very interesting questions. The first one on AI, this is really so important for the future of the continent and something we have to really get off the starting blocks. But remember, whether it's AI, whether it's modeling, whether it is sequencing, all of this depend on the primary data collection. So if you don't have good data systems from the very beginning, incorporating specimen data, human data into centralized databases, then you can't do AI, you can't do modeling. So I'm very keen to get the discussion started on AI, and it's very important that we play our role. But we've got to focus on the basics to be in a position to leverage on the opportunities that AI and modeling and the rest of them will bring for the continent. I love the point on theses, as a thesis from students. And I see this as really being an example of a bigger issue, that we do have a lot of data on the continent, in our countries, but they are hidden in books, in PDF files, in ministry PDF reports, in places that are simply not accessible. So that's why Natalie mentioned the idea that we had in one of our meetings where all the MPIs were available to create data observatories. So where we start pulling together these data points in data libraries that we can then start curating, managing, accessible. This will not be a one-off project. It is an ongoing program. But the earlier that we start in collating some of these key data points together, into a data observatory that we can then use to extract data points when we need it, the better it will be for all of us to make continent-wide decisions about our health security. The point on country capacities, yes, we do have human resources across the continent, but also, I mean, this outbreak has really been such an eye-opener around the capacities that we do have in our countries, because many of us were stretched to such an extent that we now had to pull in capacities from places we normally wouldn't pull them in from. In Nigeria, we had young people at NCDC, you know, building data systems, working in the lab, defining new lab processes. So I think there's a lot of human resource that we have. What we haven't been very smart about is how to use them effectively in delivering public sector goods. And that's something we just need to learn, not necessarily from outside the continent, but just to look more innovatively around where the skills are in our country and how, in our countries and continent, and how to leverage on those skills to make things work better. The point on trust was already made. This is something that we have to continue working on. And this has been a great opportunity. The level of knowledge we now have of each other is really has increased exponentially, even with the restrictions of the outbreak, and one we now have to build on. And the final point, reaction I want to make to one of the questions was about data sharing. And I honestly don't think that most African countries have been hesitant to share data, especially during this pandemic. I mean, at NCDC, we have shared our data proactively. Our website is updated with the most recent data. We've shared data sets with whoever has asked. We're now sharing our new sequence data. I know South Africa has been doing the same because we follow their data almost on a daily basis. We've used this for action. So I think the era of hiding data has really gone, because where are you hiding it from? You know, the data will come out anyway, because it's just the way it is. The systems make it inevitable that data can hardly be hidden. So we've taken a very proactive approach in Nigeria, and I've seen the same approach across many other African countries, across many other national public health institutes, who have been very proactive around sharing the data, because we all need this data interconnectively to respond. If Ghana is not sharing their data with us, we're in trouble, because we need to know what's happening in our neighbors in order to make public health decisions about ourselves, and vice versa. So I think there's one area where actually on the technical level, the leaders of national public health institutes have been very, very proactive in sharing with each other the data that we need. What we now need to do is make this data better and more inclusive of data points that are not naturally housed within our institute. So I'll pause here and Natalie comment with a few other points.
Thank you, Dr. Chikwe. I want to begin with the topic of what we would do differently. And I think certainly we were not prepared. I think as public health institutes, we were not prepared. As countries, we were not prepared. Globally, we were not prepared. And what we would do differently is certainly have a health system approach to data, the data continuum. So you have all aspects of not only the health data continuum, but those that data. So issues around a GIS map with water, sanitation, sewage systems mapped, climate change, temperatures, water quality, air quality mapped on a map, because that is key in terms of predicting future outbreaks, in terms of preparedness. So one is having a health system approach, but having an integrated approach with other systems within countries and within the regions and on the continent to be able to make informed decisions. So I think the level of preparedness is something that we strengthen. Many of the systems were rapidly deployed. We now need to evaluate the effectiveness of many of the systems that we deployed. Maybe forgot key questions that we needed to ask
around vaccine and with a travel history, for example, post-vaccination. I think these are things that we will be constantly having to evaluate as we progress. We weren't afforded the luxury of time. And I think we need now to reflect very carefully what we've implemented. Is it working? Is it what's working? Strengthen that. What's not working? Change it. Or what do we do differently? Health traditionally has not harnessed the capacity of information technology. And we were forced into a situation now where we had to use information technology. And we were not prepared, and we did not have the capacity nor the understanding of some of the AI tools, the large data systems, integration of large data systems, the linking, the interfaces, and all the IT technology, which is housed in the data scientist world, in the data analyst world. And we now need to bring these together and merge them. So the job descriptions in health are still to be written, I think, for the future. And I think this is what we need to start crafting our way forward now. And we need to ask ourselves key questions. If genomics is going to be our next key way that the world is going to go in terms of disease diagnosis, do we still want to focus on, for example, having electron microscopes, on having PCR tests? And I think these are key questions that we have to grapple with. And unfortunately, I don't think many of us have the answers yet, but we are all grappling with them, certainly in our institution as well. I want to also just pick up on the issue of every citizen has become an epidemiologist. Every citizen has become a data scientist. And they are making interpretations and communicating these interpretations that has resulted in the infodemic that we have to manage on a daily basis. But I do think we need to harness that scientific citizenry to the benefit of public health good. And we need to steer it in the correct direction to be appropriate, to be able to assist us and enable this, our capacity, our limited capacity, rather than to work against it. I think that's a key important point for going forward. So I think that I'll stop there. Over. Thank you, Chair.
Thank you, Natalie. I think we have come to the end of this session. We have, this is it's been a very exciting session, and the key messages are clear. We need to share. Let's make it easy to share. Let's build trust around it, and make sure that we recognize the value and importance of timely sharing of the information and trust, building that trust there. I think that is, you hear more about the trusted travel, some of the platforms that we are putting in place at the African Union. I think Edem, the session coming up after this, the next one, we'll discuss that. So, but I'd just like to return this session back to Dr. Moeti to conclude, and then we transition to the next session. Chidi, over to you.
Okay, thank you very much, John, and thanks so much to Dr. Natalie and to Chikwe. Chikwe, great to see you again for this well thought through, wide-ranging summary analysis of the situation of data and some really excellent observations and recommendations. I think that what you are suggesting is going to build on a great deal of work that's already been going on in countries on data, in public health institutions, in different programs, disease programs in countries. We do have a very fragmented architecture of the data systems in countries around specific disease programs, and a lot of capacity there too that could be drawn together. I do think that the public health institutions are a very solid basis for this. We in WHO have been working with the programs, with the outbreak and disease and epidemic systems in countries. And of course, we very much welcome now the dynamic presence of the Africa CDC, which is coming on board to work on all of this together. I don't have much to say except the key recommendations that you've made are very much agreed with. We need to pull all of this together. We need to adopt the technology that has left many of our systems behind because it's going to leverage so much capacity to build the kind of data systems that will have us ahead of the game in making decisions and most importantly, in taking action. And again, that notion of building trust. Chikwe, I've seen countries sharing data, but not the level of granularity that will help make the difference. So it's how to build the trust to be able to more openly build reveal that information, and therefore how to manage that data in ways that respect what could be risks in terms of confidentiality, as those of us who are collecting the data in such a way that the trust does really get built up. I loved the concluding statement by Dr. Natalie when she said we need to harness the scientific citizenry, because I think at the end of the day, it rests with people. Even those who make decisions about data are people. And if we have people on the ground, individuals, young people exchanging and linking up to the technology that exists, I think it can only work for our own good. So I hope very much that we will create the opportunities with some of the platforms that are being put in place to put all of the work on data together. At the end of the day, it has to serve for our countries and it has to serve for the individuals, even people living in the most remote parts of our countries. So I can only add my own thanks for a fabulously thoughtful going over this critical aspect of public health, and say that in WHO we're very ready and prepared to work with the Africa CDC, with the institutions in countries, with our communities on this very important aspect of health. Thank you.
Wonderful. So this brings this session to a close, and we will now go to the next session, which is begin to look at the impact of how COVID has impacted on other challenges that we have on the continent, including TB, HIV, and malaria. And we are really fortunate to have Winnie, who has agreed to moderate this session for us. And it will be my pleasure to welcome Winnie on this platform. She needs no introduction. She is the Executive Director of the UNAIDS based in Geneva. Winnie, thank you so much for your support, always been there, and the partnership, strong partnership with Africa CDC right from the beginning as we engage with the community. Winnie, over to you. Is she muted? Okay. Yeah. So I've just been advised that excuse me, that is a health post for a little break for about 5 minutes before we regroup and start at 10 minutes past 4. So we have a few minutes to walk around, stretch before Winnie. So my apology for bringing that session up a little bit earlier. So at least it shows that we are on time. So let's regroup here in the next 5 minutes and listen to and follow the next session.
Hello, can you hear me?
I can hear you. I think they took 5 minutes break.
Yeah, I know. Just wanted to know who is in the room.
Yeah. Well, nobody is here back.
Listen.
Hi, Winnie. This is Winnie. We can hear you.
Yeah, Winnie, good to see you. Good to hear you.
Good to see you.
Yeah.
How
Good.
favorite people?
No, good. We almost started a few minutes early, but I was told that there was a little break in between. So now we are here. I think we are really honored to have you on a Saturday afternoon join us to evaluate where we are with 1 year of this pandemic. So it's been a very exciting discussion, and we're truly honored to have you. You need no introduction.
No.
And it's a pleasure, colleagues, to welcome Winnie here, who is the executive director of UNAIDS. I was saying, just telling the group early on that, I mean, the partnership with UNAIDS has been remarkable. And now that we're moving into a whole new phase of this battle, where the virus is in the community engagement is so necessary. But it would be good to hear from this panel how the impact of the COVID and other challenges that we had before COVID, HIV, TB, and malaria. So over to you, Winnie.
Thank you very much. Just checking to know that all our panelists are here now. We have someone checking for us. That is
I think
Honorable Dr. Obiang Ndong, Professor Murira, Peter Sands, and Abdrahman Diallo. Do we have them all here? Let me check on the panel.
Yes, madam, all of them are there.
Great.
Yeah, Winnie.
I see Peter. Welcome. So, Excellencies, President Felix Tshisekedi of the Democratic Republic of Congo and Chair of the African Union, President Cyril Ramaphosa, President of South Africa, Excellency Musa Faki Mahamat, Chair of the African Union Commission, Honorable Ministers of Health, Dr. John Kengasong, my brother, Director of Africa's Center for Disease Control, distinguished panelists, guests, congratulations to the African Union for holding this high-level meeting of African Ministers of Health on implementation of Africa's joint continental strategy and the role of digital innovation in the COVID response. I really thank the African Union and Africa CDC for leadership during this pandemic. Today's high-level meeting is yet an example of that leadership. Thank you for inviting on other disease control efforts in Africa. We will be exploring how we can reduce the impact of COVID on the three diseases, HIV, TB, and malaria, and seeking innovative and digital solutions. To discuss this, I'm joined by distinguished panelists who will be asked 2 questions each to share their perspectives and concrete solutions, share concrete solutions. We try to be solutions focused. And of course, depending on how well we use the time to answer the first round of questions, I hope we'll have the second round. So distinguished panelists, I request that you use 3 to 5 minutes to answer the first question, and I'll come back to you with the second one. So our distinguished panelists are the Honorable Dr. Patrick Obiang Ndong, Minister of Health of Gabon, Honorable Professor Amon Murira, Minister of Higher and Tertiary Education, Innovation, Science and Technology Development of Zimbabwe, and my friend, Mr. Peter Sands, Executive Director of the Global Fund, and my friend, Dr. Abdraman Diallo, who is the CEO of the Partnership to End Malaria. Distinguished panelists and guests, we are over a year into this pandemic. In Africa, I've learned that we've lost close to more than 120,000 lives to COVID and more than 4.5 million cases confirmed. Even if mortality rates are lower than in the rest of the world, we are facing extraordinary challenges, as you know, especially as new variants emerge. The pandemic is pushing the response against HIV, TB, and malaria even further off track and threatening our gains. It has caused severe disruptions of health services. According to the Global Fund, and I'm sure Peter will speak to this, HIV services, especially prevention, screening for TB, and malaria have been disrupted. In 2020, HIV testing fell by 41%, TB referrals by 59%. We also see countries are shifting efforts and repurposing funding towards the fight against COVID, but this is a mistake. Why is it a mistake? Maintaining health HIV services during COVID pandemic would outweigh the risks of additional COVID-related deaths by 100 to 1, according to UNAIDS and WHO. Disruptions in health services put the most vulnerable at risk, especially in Africa. In high-burden settings, people living with HIV and TB are more at risk of deaths, with increases up to 10, 20, and 36% of projected deaths for HIV, TB, and malaria over the next 5 years. We've seen rapid introduction of digital innovations for health during COVID-19. That's a real positive, like telemedicine, uptake of telemedicine, drones, as people are forced to social distance. Technologies we see can save lives and reduce inequalities in accessing healthcare, especially for the most vulnerable and marginalized. Africa has a unique opportunity to build back better by investing in digital health, health service infrastructure, and local production of health products, including PPE, medicines, and vaccines. So that's my introduction. I now want to turn to our speakers with our first round of questions, reminding you that let's not take more than 3 to 5 minutes. So I'll start with you, Honorable Dr. Guy Patrick Obiang Dong of Gabon. Gabon appears to have successfully managed COVID-19 medically, testing and treatment, and has one of the lowest fatality rates in Africa. However, according to analysis done on the impact of COVID on efforts to control other diseases, on the socioeconomic impact, we see that there is something there that we need to explore. So, Monsieur le Ministre, could you tell us about the major changes, the major challenges you have faced, and how you've organized yourself to minimize the negative impact of COVID on the control of other diseases, especially for the poorest and most vulnerable? Over to you, Excellency. You're on mute. Your Excellency.
Bonjour, Madame Dr. Winnie.
Good afternoon, Dr. Winnie. Good afternoon, Your Excellencies. Apologies, we have a connection problem, so I want to apologize to you. Well, I want to congratulate you for being the moderator of this session. And yes, other continents, the African continent was greatly affected by the COVID-19 pandemic, and this had a major health impact. And of course, we can see a very high morbidity and mortality rate. We see our health structures that have been saturated. And at some point, we couldn't have certain services because we had to cater for the patients contaminated by the COVID-19 virus. In our health system, we've been able to reassign some of our doctors in order for them to strengthen the teams that are taking care of the COVID-19 patients. I mean, this is just to say that there is absolute need in Africa for us to train and to improve our health system in order for us to rise to the occasion when we have such situations. Here in Gabon, like I said, just like it happens in the rest of the world, despite the spread of the COVID-19 pandemic, we've been able to slow down on the spread of other diseases. For malaria, in 2020, we actually launched a campaign, a rollback malaria campaign. And during the COVID crisis, we worked with community centers with the support of the International Monetary Fund. So we try to see how best we can actually ease access or facilitate access to medication with people living with tuberculosis. And with all the COVID-related measures, we tried our best to work with the communities and with support of the IMF to ensure that people have access to tuberculosis medication. Still in 2020, despite the problems, we also try to focus on combating HIV. But despite all these efforts, most of the medical doctors were actually reassigned to combat the COVID-19 virus. And so this had an impact. This had an impact on those who were suffering from HIV, from tuberculosis. With the text that we have today, I think that in our various countries, we're now learning to better manage or to better care for those who are suffering from these other diseases. We have all these communicable diseases that have actually been impacted. And to get ourselves reorganizing, there was panic. We were so scared, there was panic. But now we are all calmed down. We are doing our best, because before it wasn't obvious. We didn't know what to do. But today we've taken time off to ensure that in all the various services, these services should be operational, especially those who are in charge of combating HIV, the service for tuberculosis and malaria. But there is an impact on the prevention aspect, because we need to fully comply with the measures, the safety measures. And so, but you see people who have to move around. There is limited movement. There's limited movement. So we really cannot go towards the community to sensitize them on how to stay safe. In the days to come or months to come, we're going to use the social media, we'll use the television in order to raise awareness on the prevention of all these, of the three diseases that I mentioned, malaria, tuberculosis, and HIV. So, Madam Moderator, this is what I had to say. The strategy that we put in place in our country, Gabon, I must say that the COVID-19 pandemic really affected the budget allocated to health by our respective governments.
Well, thank you. Thank you, Excellence. I think the points you have made, we will have further exploration with the next minister. Would that be okay? Can I move on to the next panelist? Hello, Mr. Minister, did I interrupt? Did you have one more point to make?
D'accord.
Thank you.
That's fine, that's fine.
Thank you, Excellency. So I wanted now to turn to the Honorable Professor Murira of Zimbabwe. Zimbabwe.
Thank you.
I wanted to pose this question to you, Honorable.
Yes.
Your country was able to impact of COVID coverage, the coverage of antiretrovirals, and scaling up during 2020. What measures did your government implement to ensure that people living with HIV could continue to access their treatment? And what recommendations do you have to make to ensure that we maintain the gains achieved in the fight against HIV?
Thank you very much, Madam Chair. We really appreciate our participation in this program. Madam Chair, like another country, COVID hit us very hard, but of course, when you are hit hard, you react. And one of the issues is on HIV. We actually received a case of COVID-19 on 21 March 2020. And soon after that, 6 days later, we issued as a Minister of Health and Child Care a rapid guidance on the implementation of essential HIV services in the context of HIV, of COVID-19. So we knew as COVID came that we would be in trouble with the issue of HIV, with the issue of TB, with the issue of malaria. So we actually issued a guideline on the 6 days later when we received the case. And basically our solution was to give guidance on what we have to do with people that are receiving treatment. And we actually had to give prescriptions for 3 months, front loading our prescriptions so that we are able to cater for the problem that we had. In terms of HIV testing services coverage, which had declined actually, we observed 44% testing for HIV. So we went for the solution of self-testing as a solution to our problem. Next, we also had the issue of voluntary male medical circumcision coverage, which had declined actually because anyway the logistics and the movement had to be restricted. We locked down the country very hard. And it meant that we had a problem concerning our HIV programs. So, but what we basically did is that some of the facilities that are used for voluntary male circumcision, we had to repurpose some of our facilities to make sure that these the male circumcision voluntary one be done. But on the antiretroviral therapy, it had declined by 36%. So what we did was actually, in order to facilitate access to treatment, the government made provision for the multi-month dispensing, as I said before, of antiretroviral medicines from 3 to 6 months supplies. This policy shift reduced the frequency of patients visiting health facilities, reducing their risk of COVID-19, at the same time alleviating the workload among the health workers who were already overburdened by the issue of COVID-19. And finally, on the issue of mild transmission TCT, the country is actually committed to eliminate this, but we had a challenge because of COVID-19. But what we actually saw was that there was a decline in ART, maternal antiretroviral therapy coverage. It declined from our usual 91% to 87%. This was by 4%. But we worked very hard in this area, and we made significant improvements. There were actually significant improvements in the women who booked for antenatal services from May 2020 onwards. This was basically also an education issue of just making sure that we knew we had a problem and we knew we had to solve it. Although we were also hit by COVID, we were to make actions. It might not be enough, but it's a step in the right direction. I thank you, Madam President.
Thank you, Excel. Indeed, very inspiring examples from Zimbabwe, what can be done to adjust quickly to our new pandemic and keep other services going. I now turn to my friend Peter Sands, Executive Director of Global Fund. Peter, the Global Fund has been raising the alarm on the risk of disruption to health services for HIV, TB, and malaria right from the beginning. How do you see the knock-on impact? What can we do to mitigate this and ensure countries keep critical health services going even as we battle COVID-19? Over to you.
Thank you, Winnie, and thank you to the Africa CDC and the African Union for giving me the opportunity to participate today. You, in some ways, you've already stolen my thunder, Winnie, by quoting some of the numbers from the survey we did of 500 health facilities across Africa and Asia, mainly in Africa, which showed, as you said, that HIV testing fell by 41%, TB referrals by 59%, and malaria diagnosis by 43%. If you model through the maths, and numbers are not inconsistent with the numbers the two ministers who just spoke were talking about in terms of the initial impact of the crisis. If you model through the impact of those kinds of falls in treatment services and diagnostic services for the three diseases, it is clear that in some countries, the knock-on impact on HIV, TB, and malaria of this crisis is going to be as large or larger than the direct impact of COVID itself. So what are the consequences of that? Well, the first is that we need to recognize that, and we need to recognize, it was great to listen to the two ministers just now, because they clearly have recognized this, is that the COVID-19 response success cannot just be measured in minimizing the number of COVID-19 deaths. It's got to be measured in terms of the total impact. Now, we do have a big challenge there, because, and very interesting, having listened to the earlier conversation on data, is, well, in many countries, we have effectively real-time data, not perfect, but real-time data on COVID. We don't actually know the impact on malaria, TB, and HIV in nearly quite such an immediate way. And I think one of the imperatives is we need to be tracking it far faster than we are at the moment. The second big imperative is health workers. And John and I have been talking about the importance of community health workers as the backbone of practically everything that happens in much of the continent in delivering services to those who most need them. We talk a lot about health systems, but if you don't have the health workers, the rest of it doesn't work. And that means thinking about capacitization, how many health workers, how they are trained, and also critically how they are protected. And one of the other disconcerting things that we found in our survey is how many places community health workers aren't getting the kind of PPE they need to keep them protected from infection. And also, as you will know well, the infection rates among health workers from COVID are much higher than they are in the general population. We do need innovation, as you said, and as both ministers stressed. And sometimes these are things that we knew already, but were being piloted or gradually rolled out, but now are being used much more assertively. Self-testing, as the minister from Zimbabwe said, is a good example, but also things like PrEP, and also more integrated services. So simultaneously testing for TB and COVID, or taking a febrile management approach when children present with a fever, not just testing for malaria or not. The critical issue is, as I say, that we need to be understanding the total impact of this pandemic and managing it as a whole. And as we think about these knock-on impacts, we need to distinguish the different sorts of disruption. Sometimes it's the direct impact of the virus. Sometimes it's the indirect impact of public health measures that stop people moving or interacting. And sometimes it's diversion of resources. So an example of something that I'm quite concerned about is that in many places, community health workers are going to play an absolutely central role in vaccine deployment. And that's absolutely the right thing to do and absolutely logical. But we also have to problem solve as to how using community health workers in this way doesn't stop or interrupt case management for malaria. Because if it does interrupt case management for malaria, we will end up with a spike in malaria mortality. And that would be a huge price to pay for a vaccine deployment we need to make happen. So there is going to have to be, and I applaud the amount of innovation and leadership that ministers of health and communities are showing across the continent. There's going to have to be sustained innovation, real-time learning, and sort of problem solving to make this happen. And certainly the Global Fund is fully committed to helping through our COVID-19 response mechanism countries across Africa in doing this. Back to you, Winnie.
Thanks, Peter. You really raised an important point about how we measure the impact of COVID, at measuring the total impact, and not just the direct impact of COVID, but also the indirect impact from health measures and the diversion of resources from other diseases. Measurement, surveillance is key. So I want to move on now to my friend, Dr. Diallo, the CEO of Partnership to End Malaria. According to an analysis of health facilities in Africa and Asia, again conducted by Global Fund last month, there was significant decreases in malaria diagnosis and treatment due to COVID. Shortages of drugs, diagnostics, and other commodities have also been noted in many countries in Africa. And we know that Africa is the home of the largest number of malaria cases in the world. What has been for you the biggest impact of the pandemic, the COVID pandemic, on the fight against malaria this last year? Tell us your perspective there. Over to you.
Thank you very much, my sister and friend, Winnie. And thank you, my brother, Dr. John, for the invitation. And I'm honored and happy to be here with the excellencies and my friend and next door neighbor, Peter. Yeah. So a lot to say here. I mean, listening to all the comments that we heard, for some of us who have dealt with more or less a similar situation in the past, as a former minister of health of a country that dealt with Ebola, many of these things are deja vu, at least at the country level, the difference being that then it wasn't a pandemic, but some of these disruptions at the country level are the same. Just reflecting on what Peter just said, that the measurement of the impact of the disease shouldn't be directly related to the number of cases or death, but looked at more or less globally. So specifically speaking about malaria, I just want to put this in context. Before COVID, looking at progress made since 2000 because of the global effort of all the players in the fight against malaria, great progress was made, saving more than 6.6 million lives and avoiding around 1.5 billion new infections. Interestingly, over the past few years, we had already observed a stagnation in the rate of progress before even COVID came in. And that's why a number of partners were working on getting back on track. And interestingly, COVID came around and disruptions were immediately observed initially. Look at the local level disruptions, as we heard here. Typically what happened, all resources get immediately moved towards dealing with that emergency. And when I say resources, it's financial resources, it's human resources, it's the infrastructure. You add to that all the restrictions in movement because of COVID and the fear of seeking care. And on top of that, the global level disruptions, global supply chains, and also the financial resources mobilized to that. So definitely, there was a major concern, and that's why early, around April of last year, WHO did a modeling that showed that in the worst case scenario, we could observe a doubling of the number of deaths due to malaria in sub-Saharan Africa. Interestingly, because of a heroic effort of countries in Africa and an unprecedented mobilization of all the partners involved in the fight against malaria, that worst case scenario was avoided as more than 190 million mosquito nets were distributed. More than 20 million children benefited from seasonal malaria chemo prevention, and hundreds of thousands of houses were sprayed as part of the indoor residual spray program. But with that said, the full impact, the full consequence of COVID on malaria is still not completely known. Peter just mentioned the drop in diagnosis of malaria. You add to that a preliminary report from the WHO that showed that at least 1/3 of countries experience at least partial disruption of the delivery of malaria services. So while overall prevention services were carried out in the majority of cases, it's not necessarily the case for case management. So we're yet to learn more about the overall impact of that. With that said, all the partners again involved did great work facilitating the development and dissemination of guidelines to countries on how to safely roll out malaria programs, shifting from mass distribution of mosquito nets to door-to-door, encouraging communities to restore their care-seeking behavior and so on and on. Basically working with countries to ensure continuity of malaria services, pushing for one message: it is not either or. Yes. It is not either fighting COVID or fighting malaria, but doing both simultaneously.
Thank you, my brother. Already in the first round, we've heard some great innovations. We've seen what needs to be done immediately. We see the gaps, what we need to know. We need to have real-time information about how services for other diseases are being affected. Now I'm going to my second round of questions. And again, I'm asking you to help us to tease out innovations, what works, what we are learning. And I'm going to go back in the same order that we did the first round in. So I go to the Honorable Dr. Obiang Dong, my second question to you is, how do you see innovations and digital technologies which we have acquired in the fight against COVID being used to strengthen equitable access to screening and monitoring of patients suffering from other diseases such as HIV, malaria, and TB? What are we learning? Over to you, Honorable Dr. Byang-Dong.
Merci, Dr. Winnie. Je pense que la COVID-19 a permis à beaucoup de pays de pouvoir renforcer leur...
Thank you very much. I think COVID-19 has enabled many countries to strengthen their health system, especially their testing systems. The PCR testing mechanism, which enables us now to do shift testing, as well as the testing for many other diseases, such as the HIV/AIDS and tuberculosis, are all welcomed initiatives. I do believe that some of the assets that we have acquired and the experience we have acquired so far in the fight against COVID-19 must be capitalized on. In the same vein, monitoring and evaluation in the context of COVID-19, all countries have been monitoring their health data in terms of COVID-19. We must therefore capitalize on the current data that we have in order to enable us to have comprehensive data to take informed decision on any future pandemic and the current pandemic. I believe that our respective countries should make more effort to mobilize resources to extend their data storage capacities. May I also call on our partners to support our countries in that regard. Health data is something that we cannot underestimate. We can combine this fight and eradicate not only this pandemic, but tuberculosis and HIV/AIDS as well. I thank you so much.
Winnie, you're on mute. We can't hear you.
Okay, it goes on mute automatically. Yes, thank you for that answer. And the importance of health data and building databases that help us capture real-time data and also systems we can use every time there's a new pandemic. Thank you. I now move to the Honorable Professor Murira. What is being done to reduce disruptions due to COVID to reduce disruptions on prevention programs and testing uptake in Zimbabwe? And tell us your most innovative approaches in that area.
Yeah. Thank you very much, Madam Chair. One of the issues which Zimbabwe, we have done several interventions, basically to make sure that we can take care of COVID and at the same time not disrupt significantly the other services. Was on the COVID to make sure that we have started a general practitioners network that looks after COVID patients, therefore reducing pressure on our institutions. Number two was also to make sure that we have started the concept of a virtual hospital where we take care of the mild to moderate cases at home, using health practitioners around there and providing them with the necessities that are needed around that place. And also, we have started a mobile app to make sure that our patients and the health practitioners are interacting and we are able to actually take care of the problems. and call centers also have been set up. The whole idea is to reduce pressure on our institutions and make sure that our high dependence units are free to a certain extent, so that we don't have overflows. But we also have done a simple innovation of human resources stabilization. Zimbabwe had initially had problems of human resources, people going on strike and so forth, but I'm sure that you last heard about this story in August last year, no more. So it means we have been able to make sure that we have increased the availability of our human resources to this issue. Also, lastly, I want to talk about the issue of making sure that in order to make available the resources for the other diseases, we started using our higher and tertiary education institutions to manufacture PPEs, to make sure that we are making sure the sanitizers, institutions of higher learning are producing over 3 million liters of sanitizers, which makes sure that the money that we have available, because Zimbabwe produces ethanol, so, and these are all local. So the money that we then were supposed to use for import is then imports drugs that are for the other 3 diseases rather than COVID alone. So we tried by all means to rely on our human resource, our human capital. Zimbabwe is privileged to have over 90% literacy. So we're trying to convert this literacy to action. And these are some of the innovations that we have made, besides mobile apps, virtual hospitals, stabilizing the human resources, and also call centers to make sure that we reduce the number of people that come to our health facilities. Some people might not have to come at all. So these are the issues that we have done. I thank you, Madam President.
Thank you so much. These are really very inspiring examples of what can be done to fill the gaps. And yours is a country that has a long history of self-sufficiency and innovation to keep it going. I'm really excited to hear how you can use your education institutions to fill the PPE gap. That's fantastic. I now want to move then to Peter. Peter, my second question to you is that the COVID-19 response mechanism, tell us about that. It's a mechanism through which the Global Fund supports low and middle income countries to respond to the COVID pandemic. What are the opportunities of that mechanism? Tell us.
Thanks, Winnie. And the COVID-19 response mechanism, or C19RM as we called it, is an example of an innovation. It didn't exist until the beginning of April last year, and was a mechanism we put in place to enable us to provide fast and flexible response support to countries, support for the COVID-19 response itself, for interventions to mitigate the impact on HIV, TB, and malaria, and to do urgent fixes to health systems. During the course of 2020, we deployed $1 billion to Global Fund eligible countries, to well over 100 countries, through the C19RM mechanism. This April, we launched the second phase of C19RM with an initial capacity of $3.7 billion. And all Global Fund countries, and that means pretty well every country in Africa, are eligible for support through that mechanism. We communicated base allocations and potential above base allocations to all the potential recipients on April the 7th, and have just begun making our first awards to countries. But to give you a sense of it, we received the request from India last Saturday, and we approved it on Thursday. So we are turning these around at a much faster, nobody ever accused multilaterals of being nimble. We are to be as nimble as possible. And my message actually to all the health ministers and government leaders attending this session is, please do use the support from CDC, in particular, make use of the fast track mechanisms to get rapid support on COVID-19 diagnostics, tests, PPE, oxygen, and so on. Having spent some time over the last couple of weeks working with the Indian authorities, once you're hit with the full force of COVID-19, it then becomes much more difficult to deal with the situation. And the more one can get ahead of that and be putting in place the protection for health workers, the testing, the oxygen capacities and so on, and reinforcing the clinical care in advance, the better. And if your country turns out to be lucky enough not to have a second or third wave, then frankly, the downside of having been well prepared is very small. If your country is unlucky in the way that India and others have been, then those extra days of preparation and extra investment in preparation will save a huge number of lives. So we are very keen to get the funding requests in from the countries as soon as they are available, and the fast track process in particular, we will ensure that those requests are turned around swiftly.
Yeah.
Thanks, Winnie.
Well, thank you. And that's really important information for all the African ministers of health. We supported very much your fundraising for this and congratulate you for securing this funding so fast and now dispersing it so fast as well. Peter, now to my brother Diallo, or should I say Abdurrahman? Okay. Okay, digital technologies are being harnessed to support public health response to COVID worldwide, and they present a real opportunity to modernize healthcare systems and improve data management and support evidence-based decision-making for health. How do you see the use of digital technologies to strengthen the fight against malaria and across other diseases for surveillance and case detection?
Thank you again, Winnie. Very interesting, and this builds up on the conversation that started earlier. I really would like to take this opportunity to insist on the need to invest on improved, robust data system to facilitate agile, timely, effective responses, not only to malaria, but to all other diseases. I think COVID has shown the importance of real-time, accurate, quality data, the importance of modeling in shaping the response to basically any disease. In the malaria field, we've observed a lot of progress recently in terms of data collection, sharing, and analysis, but there is still a lot that needs to be done. At the national level, we've been talking a lot about strengthening the data collection analysis system from the bottom to the top, starting from community health workers, equipping them with exactly what they need to collect data, recognizing the importance of community-based surveillance. That's the beginning of pretty much everything. So equipping them with what they need, not only to collect the data, properly transmit it, and also at the higher level, having the capacity to analyze that data and make decisions based on that data. At the regional or sub-regional level, also encouraging countries and facilitating data exchange across countries, because we've seen the importance of that Ebola, we've seen the importance of that during COVID, but also for malaria programming in terms of aligning, harmonizing, coordinating campaigns across countries. That is absolutely important. We've seen actually very good recent examples in the context of COVID where countries were able to redistribute malaria commodities, avoiding major stockouts in different countries. With that said, we're talking data, but data is political. This is why President Kenyatta, in his role as the chairperson of ALMA, the African Leaders Malaria Alliance, has data as one of his legacy points, as one of his priority items. And we're working very closely with him to make sure that this message is passed on at the head of state level within the African Union. Just quickly, just putting malaria in the context of COVID, the RBM partnership is hosting the Global Malaria Dashboard. Although we're hosting it, we don't own it because it belongs to the whole partnership, to all involved in the fight against malaria. It was developed in close collaboration with USAID PMI, with the Global Fund, with WHO, with ALMA, MMV, CHI, and then the countries. So the purpose of that Global Malaria Dashboard is not to duplicate data collection tools that exist in countries, but have those systems fit into that dashboard, be able to monitor what's happening, identify bottlenecks that can handle solutions within countries, escalate them to the global partners level so appropriate response could be proposed there. So tracking supply chain information to see whether a country is stocked out, about to be stocked out, or actually adequately stocked. Tracking the status of the implementation of malaria campaigns and the number of cases to see if there is any sudden increase somewhere, financial gap, and so on. So just to say that that capability is there, we've been closely working with partners and countries to leverage that technology to propose solutions in terms of addressing implementation bottlenecks to countries. A lot more to say, but I'll just stop there for now. Thank you.
Thank you so much. I really want to thank very much the Honorable Ministers and my distinguished colleagues on this panel for such a rich and engaging discussion, very concrete in putting on the table work, innovations that have worked. And based on our exchanges, I'd like also to make a few suggestions on how to reduce and to fight colliding epidemics. The COVID pandemic has seen the introduction of new technologies rapidly in the health response, and you've spoken to some of them. We need to leverage and integrate them into our health systems to fight the existing and future pandemics and ensure equitable access to all, including the most marginalized, particularly women, poor women, and young people in the ways that work for them. We must ensure that the vital lessons of the AIDS response are brought to bear on the COVID response. I'm passionate about that. The AIDS response brings together a diverse and robust set of approaches and instruments for meeting the challenges of future pandemics, from the hard-fought gains on human rights and inclusion, to resilient and empowered communities, to equality, to science, programmatic instruments. All these are essential for pandemic preparedness. We've seen from this panel how implementing differentiated service delivery models of care and investing in community works. We've seen how these can help to reduce the burden on overcrowded health systems. For HIV, this was done through innovative approaches like home deliveries, what you've heard of multi-month dispensing of ARVs, and so on, self-testing and so on. Investments in health commodity security, local production, research and development of medicines and vaccines are critical to address this over-reliance on imports. I think this is an agenda that now our leaders are very, very serious and prioritizing. would need a strong continental strategy on digital health. This will require political commitment and financial support and a rights-based approach. Overall, this is really about being deliberate about ending the inequalities that drive pandemics and upholding everyone's right to health. That is the way to beat pandemics. I'm so grateful to all of you. I'd like to pass to our convener, Dr. Kenga Song,
I'm here
to have the last word.
No, thank you, Winnie. And unfortunately, I don't know why my video has been locked out, but I hope you can still hear me.
We hear you.
Okay, so somehow they can, I mean, so let me see who started my video. Okay, good. Now they have been kind enough to bring me back on video. So thank you, Winnie. What an exciting session. And thank you, Peter. Thank you, Diallo, Excellency. Really wonderful. I think we in Africa are challenged with syndemics, and including what we live with every day, the HIV, the TB, the malaria that the three of you represent. We are challenged with issues of emerging and re-emerging infections. And Dr. Diallo has lived this in when he was minister there with Ebola, the non-communicable diseases. And COVID came in and just kind of wrapped all three together. And I mean, who would have imagined that 1 year later we'll be, or before we'll be dealing with a virus that actually plays on comorbidities like hypertension, diabetes to use that pathway to attack us. So I think severe. We are extremely concerned, as you, Winnie, Peter, and others have said, on the knock-on effect that will result from this, that there may be many more deaths due to COVID, not necessarily because of COVID. So I think this is, I'm really pleased that the ministers are here, the recommendations, I'm sure they've taken note of. And of course, as we expand the next strategy and building on community engagement, as Peter said, we have to harness the power of community healthcare workers to expand our vaccination program, then be mindful of the fact that we have to be very deliberate, that we do not take rob Peter to pay Paul, and make sure that we do that in an additive way and not in a way that disrupt other programs there, because we believe strongly that community engagement will be key. Community health workers will play a central role in our vaccination program, and community trust and ownership. But doing that collectively, doing that with a focus on protecting the existing programs will be very important. And let me just conclude by saying that the reason we thought it absolutely important to include this section and the next session here was because the Continental Joint Strategy, the third pillar of that was harm on our economy and harm on other non-COVID infections. So we want to be sure that we learn from you all, and we have learned from Gabon, from Zimbabwe, and from all of your experiences there. They will be captured in our recommendations to member states, and we hope that working very closely with WHO, we will continue to advise member states and work with them to implement some of your very apt recommendations. Thank you so much for your time, taking the time on Saturday, all of you on this panel, to share your reflections on some of the extremely concerning effects of COVID on our continent.
Thank you. Good to see you all.
Thank you. Now I have the honor to call on Dr. Seth Barkley to moderate the session on impact of COVID-19 on immunization programs and the need for the African Medicine Agency. Over to Dr. Barkley. Dr. Buckley, are you with us?
Dr. Benjamin, there's some connectivity issues. He's just going to try and dial in again. Just give us a little moment.
Okay.
So, Benjamin, we're waiting for Seth to connect. Maybe just check with the roll call on the panelists to see who is, if everyone else on the panel is available.
Okay, on the panel, we have the Honorable Dr. Enir from Nigeria. Yes, he's online. Dr. Leah Tadese from Ethiopia, Minister of Health from Ethiopia. Dr. Jean-Jacques Bugani Banda from DRC. And Honorable Mr. Michel Sidibé. Okay, we have Dr. Buckley online, and we have 2 panelists for now online. So over to you, Dr. Seth Buckley, CEO of
So thank you so much. I'm sorry there was a problem with the login for me. So I am delighted to be here. And I first of all want to thank you, John, for putting this very important meeting together, given the emergency that exists in Africa, as well as in other parts of the world. So for this session, the idea is to look at some of the effects of COVID-19 on the situation in health in Africa, so particularly on the immunization programs, and then also talking about how they've engaged their regulatory bodies and efforts for COVID-19 vaccine approvals. And then we're going to hear, after we hear from the distinguished panelists, we're going to hear from the AU Special Envoy for the African Medicine Agency to discuss the issues in terms of the need and importance of having a regulatory framework. At the moment, we have a few of our panelists, not all of them. We have the Honorable Minister of Health of Nigeria, Dr. Asaji. We also have, is Dr. Tadesse here? No, not yet. No. And how about Dr. Mbanda? No, we don't have a. So I suggest, given that everybody else is here, we begin to put the session together and start having a discussion. And as others join us, we'll bring them into the discussion, if that's okay with you, John.
That's absolutely okay. And I thought, absolutely okay, Seth. And I thought I saw Dr. Tadese's layer flash a bit. Maybe she's trying to connect. She was going to be traveling south of the country. So I agree, let's start, and they will, I'm sure they will definitely join after sorting out the connectivity issues.
Great. Well, let me start and just open with a few comments. Obviously, we've seen the effects of COVID-19 around the world. We've seen countries take on social distancing and lockdowns to try to stop the spread of disease. And with that, we've seen a dramatic effect on health systems. In terms of immunizations, we saw routine immunization disrupted very heavily in the previous March and April. Since then, continent-wise, we've seen numbers begin to come up. We certainly wanted to be as helpful as we could, and Gavi reallocated up to 10% of its health systems to try to help with that. The other thing, of course, that's been important is trying to make sure that there's access to COVID-19 vaccine. Vax, of course, is putting together vaccines which will be available over the course of this year to try to cover those at high risk. So those are some of the things that are moving forward. And let me start by asking the first question, and we'll start with the Honorable Minister of Health of Nigeria. On maybe you can say, sir, what has been the impact of COVID-19 on your routine immunization services as well as primary health care in Nigeria?
Well, thank you very much, John. Thank you for putting this together. It's been an excellent moment to learn and exchange ideas. And then thank you, Berkeley, for moderating this session. Now, the outbreak of the COVID-19 and the subsequent declaration as a public health emergency did create a lot of fear and trepidation in Nigeria, and as I believe in many other countries too, especially since first we did not know much about this virus. It was a novel virus and nobody knew much about its behavior. And secondly, because we all knew that our health systems, particularly here in Africa, were not that strong. So during the first wave, what is now the first wave, there was so much fear to participate in anything regarding health on the one hand, and also too much focus by the health sector, the health system, on trying to understand and respond to this virus, this outbreak. So a mixture of fear and excessive focus let many things fall in between the tracks and between the cracks, and among those were the routine immunization and primary healthcare services. And it didn't take long before in Nigeria we began to hear reports of unexplained clusters of unexplained deaths in certain areas, and we sent in teams to look into these unexplained deaths. And as it turned out, verbal autopsy was performed, and as it turned out, they were not all related to COVID. A lot of them were related to several other disease patterns, malaria and diabetes and other things that had fallen between the cracks and became neglected. By March, between March and April, we had also observed a sharp decline in routine immunization. And a combination of these put the health system again on alert to start to rearrange its priorities. And we started first with training of health workers. At least 200,000 were trained in infection prevention and control protocols, and also advocacy with state governments and local governments and community health workers on understanding the little bit we knew about COVID-19, and on understanding how to pay attention to COVID-19 without losing attention to other diseases and particularly to immunization. So the benefit for us was to bring confidence back to some extent. We were able to differentiate what was routine and what was not. We were providing PPEs to the health workers, a lot of, so that there was no shortage. It increased their confidence to do their work. And trained also community workers, community and members of the community on providing support to health workers. So the result was that we could gain the lost ground, and we reestablished routine services and increased routine immunization, so that by the second wave, which we suffered later in the year, we did not have such serious effects anymore. So we did learn quite a lot from that initial response, and quite early response. We were able to gain grounds lost in that respect. Over.
So thank you for that answer. And before I go to other questions, let me just see as Dr. Tedesse joined us, or Dr. Banda. No, well, we'll keep on the conversation if it's okay. I think it's really gratifying to hear that you kept a focus on the routine health systems in addition to what you had to do around COVID-19. And there was a very good modeling study at that period that showed that if you stopped routine immunization to try to prevent deaths from COVID, for every death you'd prevent, you'd have 84 deaths from vaccine preventable diseases. So I do think that's a very important factor, and it's one that we have to keep reminding of the importance of the routine is to try to deal with many of the tragic diseases that can come back quickly if we don't keep vaccinating against them. So very glad to hear you were able to do that. Maybe I'll move over to our second question, which is really trying to understand a little bit in what lessons were learned in doing that. You've talked about the importance of PPE and training the health workers. What had to happen with your communities in terms of educating them? How were you able to get the very large number of communities in Nigeria to pay attention and keep the work going? What were you able to do, and are there lessons for others?
Yes, we had a very strong focus on communication, risk communication, and community engagement. And the president had set up a presidential task force on COVID-19, which met and regularly, in fact, on a daily basis, sent out briefings, which were transmitted live all over the country. And you will also recall that we had just come out from the polio exercise, which made Nigeria now polio-free, giving us a very strong team from National Primary Healthcare Development Agency, and a lot of manpower and a lot of community engagement officers. All of these came in very useful in reaching to the grassroots and reconnecting. As you know, the polio eradication effort went with a lot of grassroots connectivity with traditional rulers, religious leaders, and it was not difficult to remobilize all of them to the same effort. So particularly also to counter the social media, the impact of social media, most of it was negative. And we were in fact reminded that that was one of the reasons why we had to strengthen communication and public enlightenment to keep the population on the right side, on the side of science and on the side of the strategy of the government to follow and adhere to non-pharmaceutical interventions and the public health and social measures that had been instituted. So they came in very useful in that regard. We had a very good relationship with communicators and the grassroots and right down to the village level.
So one last question on this theme. In other parts of the world, there was a lot of misinformation, active misinformation versus not information. And we saw a lot of vaccine hesitancy as a result of that. You talked about the importance of social media and the negative activities on that. How much of that was local in Nigeria? How much did you do anything different to try to counter some of these, misinformation that we saw in so many other places?
Yes, we had a mix of both local, or say domestic and international misinformation and disinformation that was actively consumed here. And that is why we have to do a lot of work to counter all of that. The very frequent press briefings and the engagements we had, and also engagements on television, radio, helped to put the correct perspective and the correct picture for the public to see. Much of all of these were just, some of it was based on religious or political motives, but I think in the final analysis, the effort of government prevailed, and the traditional media, television and newspapers were also very helpful on our side. So we didn't have too much of a disruption. But with the vaccine acceptance, we started even before vaccines arrived to make it clear that this was going to be the last and perhaps the most important intervention in getting control of COVID-19. And that intervention paid off very well. There was a lot of good cooperation and collaboration from the public. The president and the vice president took their vaccines on television, and it was shown right in the country. The ministers also had their own vaccines also shown on television, so that the safety of this injection, of this vaccination, was clearly demonstrated. The members of the National Assembly, the Senate leaders, and House of Representatives also had theirs televised for the public to see, and they'd put on headline news. So that increased confidence. But I think that later on we had a mix of still some hesitancy and anxiety. There were many people who now wanted the vaccine and started to panic if they hadn't had theirs and make calls for the vaccine. So we have a mix of those who are calling for the vaccine, high demand, and still hesitancy existing side by side. Our belief is that the more people take it and the more they see that nothing has happened, then the more the hesitants will have to change their minds. And I know a lot of people who changed their mind, who had said they will not take it and ended up actually going to take the vaccine.
I think we've seen that experience in many countries. I think, you know, it's a new thing. You're absolutely right. As people see it being used and see people being more comfortable after being vaccinated, it will help with some of this hesitancy. One last question on this, and then I think we'll move over to the second part of this, which is you did a very remarkable and quick movement of the doses that came into Abuja, and you got them out to the states very quickly. And I must say that was very impressive in terms of seeing that. How was it when you went to some of the more hinterland states, less advanced states? Did you see a differential in understanding, or had this reach that you talked about, the steps you took, the political leaders, the Senate, the others embracing this and encouraging that? Did you see differentials, or did that disseminate well enough that you saw, in essence, similar problems and similar successes in all of the states?
Well, the messaging we worked upon had gone very far, penetrated into the remote areas also. So hesitancy was very rare, and there was acceptance. In fact, we had just over 4 billion doses, and our strategy is to ensure that at least 2 million people get 2 doses so that they are fully vaccinated. We had intended to use all the 4 million at once, and then in the understanding that next dose of vaccines will finish with this one. But when we saw that there's some delay in delivery, we decided to change strategy. So we are starting, in fact, on the second round of vaccines now. The second doses have been applied so that the 4 million will have been applied to 2 million people will be fully vaccinated. I hope before then we'll get a new batch that will begin to be given out. But back to the question, we had very good response. Let us say even response, whether in urban areas or rural areas, the response was quite good. There is one state, as we know, where the governor was actually the leadership there was very strongly against the COVID vaccine, the COVID itself, but they agreed to accept the vaccine. And so even in that state, we were able to get an inroad, make an inroad, and apply the vaccines to the citizens in there at the same rate as others. Over.
Great. Well, I'm glad to hear that, and I'm glad you're able to convince state leaders, even if they personally have hesitancy, to allow things to move forward. That hasn't necessarily been the case everywhere else. So I think that is a good lesson for your colleagues. We want to move a little bit now into the issues on regulatory. And one of the challenges that this whole global effort has had was we went from having no COVID vaccines to have vaccines that are being used in different areas and different places. And I'm curious how you approach that in Nigeria. You know, what steps did you end up doing? I personally can't remember the engagement you had with WHO and your own local regulatory agency, but how did that play out, and how quickly were you able to move on that? And did you have the information you needed? Because we obviously want to, at the end, talk a little bit about moving towards the African Medicines Agency, but I want to hear a little bit about the national challenges that are there as we think about moving to a more continent-wide effort.
Well, yes, the first challenge we had, our regulatory body is NAFDAC, National Agency for Food and Drug Administration and Control. And the first challenge was getting the dossiers on the vaccines. It didn't seem as if there had been much thought in sharing the dossier. So we had a lot of issues getting at the dossier. And the first we were able to get was AstraZeneca, and much later we got the others. In fact, we had to literally hunt for the dossiers. And by the time we were able to get the dossiers and work on them, we rely on also the assessment reports of mature regulatory agencies, like in the US and UK, for example, to inspect and see what how these vaccines will be adapted to our own use here in country. The relevance of the vaccine itself to our population, looking at the age group and the cohorts that were used in the clinical trials, and how they cope with our own, and they're also adapting to the conditions which we thought applied here in our country before the other tests were done. And until recently, only the AstraZeneca had passed the test of our own regulatory agency. And just recently, Johnson & Johnson and Pfizer just a few days ago. But of the 13 that you're talking about, not received dossiers, and so all the dossiers are incomplete. Information was incomplete, and we requested for more information on them. So that's the situation we are so far. But we have applied only one vaccine, and that's the AstraZeneca.
And Minister, you talked about reaching out to the stringent regulatory agencies. What role did WHO play in this process? And were they helpful? Did you get dossiers from them? Were there others, or were you able to get them from and have discussions with other countries? What type of coordination were you doing in terms of moving forward on this? Because I know you were under pressure of time, and of course people weren't traveling, and so it does make it challenging to move forward. So maybe you can tell us a little bit about how that played out in Nigeria.
Yes, we were under pressure. By the time the vaccinations were going on in other countries, and the question started to arise here, well, what about us? What are we doing about it? When are we getting our vaccines, and when do we start? And if we do not get a vaccine, we might not be allowed into other countries. So that pressure was there. But we know that other countries had their own pressures too. Those who had vaccines were trying to accelerate the rate of vaccinations, and those who didn't have yet were all, well, let us say, scrambling for vaccines. We were fortunate to have had this first tranche that came in through the COVAX facility, which we use in here. But on the whole, the experience was not very good, because we didn't get information directly from the manufacturers themselves. In some cases, we had to ask the ambassadors here. For example, we asked the the Indian ambassador, High Commissioner, to support us in getting the dossiers. In some cases, we had to ask the Africa CDC if they could support us, get us the dossiers, so that we could start, even before the vaccines came anywhere here, before we could obtain the vaccines, we could start work on them. That part was a challenge. And there are some we have up till today, some vaccines that have been used from beginning, of which today we have not received any dossier to begin our regulatory process. So I think there can be a lot more improvement if we share information, if the dossiers are provided, and there is a better collaboration among regulators so that they can fast track their own processes and live up to their mandates. Over.
So you mentioned you mentioned both the AU and you mentioned reaching out to individual countries. How about surrounding countries? Was there a discussion of regulatory agencies across West Africa, for example, or with the Southern African groups, or was this mostly trying to get the dossiers from outside? And did others to try to get this information? How well organized was it? How chaotic was it?
Well, I would not say it was well organized. Chaotic, I would also not say, but we're just looking for this information. And as I said, we had to approach the embassies of the countries who produce vaccines. And many of them could not help us. A couple of them offered us to help us and did actually provide us the dossiers. We did not ask other countries directly. We would have had to go through their, not every country, let us say, that we asked. We didn't, but as far as the West African region, sub-region was concerned, we had regular meetings. The ECOWAS CDC. We had our own meetings through the West African Health Organization in which we shared information, but we all were in faced the same dilemma in that the information was not well distributed to help us. And we looked also to what the NCDC the Africa CDC was able to provide in that respect. But information only just trickled in, not to the extent we would have liked.
Some other countries have actually used the WHO pre-qualification process as the surrogate for their regulatory systems. And I understand from you that you're doing your own regulatory approvals there. But you didn't mention WHO as a source for information. So they did not provide you the dossiers you needed as well. Is that correct?
Oh, no, that's the WHO did its job. They provided us all the information they had, and they worked with us. Yes, they did do that quite clearly, and we take it for granted that they did that for all countries where they are located to try and support them as much as possible. So they did provide us information. We had a lot of discussions with them and made a lot of phone calls. Do you have any additional information on this? And when are you going to have your own emergency use listing for this or that? And they tried to give us dates on when they would get their information on Sinovac, for example, or on this, or on Johnson & Johnson. They did support us with information. So that is taken as in all countries.
Thank you. I wanted to make sure I explicitly asked you because I think that's a very important issue. I'm going to bring Michelle in a minute, but I want to ask you one more question, and that is pharmacovigilance. These are obviously new vaccines. They're being used now newly on the continent. I know that Nigeria has a strong pharmacovigilance program. Again, how is that collaboration going? And are you hearing from other countries in terms of the collection of information and any types of concerns or issues that are coming up, and particularly given the discussion we had before around hesitancy?
Around which one? Can you repeat that part of it?
Sorry, I'm asking about the pharmacovigilance.
Your voice was breaking.
Yeah, the pharmacovigilance that is necessary for a new vaccine. And again, how much discussion are you hearing from your other countries, from your regional groups, in terms of the process that is being done now to collect information on these new vaccines and to, understand any side effects or issues on the continent, which is obviously important for helping on the issue of making sure that there's not vaccine hesitancy.
Yes, of course. Yes, we have a very robust pharmacovigilance section here that is managed by NAFDAC and supported by MPCDA, carrying out very strong follow-up on vaccination. The causality for EFIs are all being well documented. But we also follow very closely what goes on outside, what is distributed for public information in news, and compare all of that with the data we have here. But establishing causality with vaccines is a study that takes some time and is going on here. In the region here, we are having a meeting on Tuesday, the West African region, African Health Organization, in which that will come up. We shall have experience sharing on that, the AEFIs, and to see what the experience of neighboring countries has been. But on the whole, the level of vaccination has been so low that the value of such information has to be taken with a pinch of salt, and also based on what experience we have so far, we are not. Of course, one is worried by the information that's come from Europe about the blood clotting and other incidents that have been mentioned in connection with AstraZeneca and even Johnson & Johnson, insofar as they were suspended from use for a while in this or that country. All those ones are noted here, but we do look at what we have experienced and weigh it against what others have experienced, and then look at the lesser evil. Our decision is that the vaccination is much better, is much preferable than hesitating to use those vaccines.
So thank you for that. Let me bring my dear friend Michelle into the conversation. I don't think Michelle needs any introduction. Former executive director of UNAIDS, former minister of health of Mali, now serving as the AU special envoy for the African Medicines Agency. So let me just start, Michelle, and ask you, I think in a way, the minister set you up very well for some of the challenges that are there in terms of trying to work across countries and with others. But given that there is already the World Health Organization, including the regional body of WHO, the African Medicine Regulatory Harmonization Initiative, the African Vaccine Regulatory Forum, how do you see added value for a harmonized regulatory body for Africa, given the pandemic and future routine vaccines where we started the conversation here? Over to you, Michelle.
Merci, Seth, et je tiens aussi à remercier John pour vraiment coordonner cette
giving me this opportunity
rencontre qui me semble
attend this meeting, which to me is quite opportune and timely. We know,
j'ai pris du temps pour réfléchir sur notre situation.
We've taken time to think about what we're doing.
Et quand je vois ce qui a
when
été dit,
I see what has been said,
je pense que ce qui est le plus
I
important,
think what's most important here
c'est de ne pas
is
oublier que
not
l'Afrique
to
représente
forget
aujourd'hui
that Africa represents today
17% de la population mondiale.
17% of the global population.
Mais plus que cela, ce qui est important,
But above
c'est
that,
que
what's
nous
most important is
représentons
that we represent
plus de 25% 25% du poids de la maladie au niveau mondial.
Over 25% of the weight of the diseases that affect the world.
Mais à ce jour, nous ne produisons pas de vaccin.
But to date, we are not producing the vaccine.
À ce jour, nous ne produisons que peut-être 3% des médicaments que nous consommons.
To date, we are producing only 3% of the medicine that we use.
Et quand vous regardez le marché du médicament aujourd'hui,
and when you look at the market of medicine today, of drugs today,
ce marché représente plus de 1 400 milliards de
that
dollars.
market represents over $1.4 billion.
Et l'Afrique ne représente que 1% ou même moins
And
d'1%.
Africa represents out of that 1% or even less than 1%.
Donc, je voudrais dire que la création d'une agence africaine du médicament est indispensable.
So I must add that the creation of the African Medicines Agency is quite something that is essential, necessary.
Et je pense que à cause de la COVID-19,
and I think that because of COVID-19,
nous avons assisté à la fois à de grands progrès
we have seen
et à des défis importants pour les programmes d'immunisation.
We have seen a lot of progress, and we have made steps towards the immunization programs.
En termes de progrès, les infrastructures d'essais cliniques en Afrique ont été ressuscitées.
We have revamped infrastructure in terms of treatment and clinics.
À court terme,
That's
je
in the
dirais.
short term, I would say.
En partie grâce à des approbations rapides d'essais cliniques recommandés par l'AVARES.
And this thanks to the approval of these clinics by the officials that are responsible.
Et les vaccins ont été approuvés pour une utilisation mondiale dans des délais rapides.
And the vaccines were approved to use at the global level in short deadlines.
Mais des défis subsistent.
But we still are faced with many challenges.
Par exemple, la dépendance de notre continent à l'égard des vaccins importés.
The dependence of our continent on vaccines which come from elsewhere.
Dont l'approvisionnement est insuffisant. On l'a entendu tout de suite et qui a entraîné quelque part le ralentissement même du déploiement de l'initiative COVAX, qui est une initiative bienvenue.
Work, which is a very important organization.
Et nous observons aujourd'hui d'autres défis tels que l'entrée dans la chaîne d'approvisionnement de vaccins de contrefaçon.
Into the supply chain of vaccines, and we have seen that there have been problems of fake drugs, fake vaccines.
Ou de mauvaise qualité.
Or poor quality vaccines.
Et la mise en place de systèmes naissants de détection des effets indésirables.
And the establishment of the systems to detect side effects.
Donc, il est de l'intérêt de tous, à mon avis, après avoir écouté le ministre qui vraiment a fait un exposé très clair des différents problèmes.
And having listened to the minister, I think it's high time that we, all of us, take this thing on board and
de mettre en place les conditions réglementaires optimales
and put in place optimal regulatory frameworks and arrangements
et qui vont nous aider à aller plus vite vers l'adoption de vaccins sûrs, efficaces et innovants sur le
continent. So that you can move towards the establishment of vaccines which are safe and which can help the African continent.
Cela devrait inclure une coordination continentale.
So there is need for a continental coordination in this approach.
Des décisions et des orientations données aux pays concernant les démarches d'essais cliniques.
And orientations and guidance given to countries concerning the approach to this effort.
Et surtout l'assurance et l'application de la qualité, l'examen des dossiers.
Quality and looking at all these nitty-gritties carefully.
Et les autorisations de mise sur le marché ainsi que la pharmacovigilance dont parlait tout de suite le ministre suite à la bonne question de Seth.
And the pharmacovigilance and the marketing, just as the minister rightly put it in his speech, following a question put to that effect.
Donc, l'Agence africaine du médicament va permettre de remédier à la fragmentation.
So the African Medicines Agency will help in tackling the problem of fragmentation.
En matière de réglementation,
in terms of regulations,
ce qui ralentit la recherche clinique et l'adoption des
because this slows down clinical trials.
Elle peut offrir une approche plus puissante de la mise en application contre les producteurs de produits de faible qualité, et c'est un moyen de renforcer la capacité réglementaire.
This would enable us to tackle the production of counterfeit diseases and counterfeit drugs, and this would enable us to make headway in the work we are doing.
Et pour permettre aux producteurs
African producers of vaccines
d'exporter sur le continent et au-delà,
to export throughout the continent and beyond, which they cannot do right now.
Et vous savez que à part peut-être le Ghana,
apart from Ghana, maybe,
et peut-être la Tanzanie,
and maybe
nous
Tanzania,
n'avons aucun pays avec
we do not have a country,
niveau
any
de
country
maturité
with
3.
a maturity level which is to that
Donc,
level.
L'avantage de
So the
AMA
advantage of AMA
en termes de santé, ce serait
in terms of
d'aider
health would be
les pays
to help the countries
d'ancrage à atteindre le niveau de
to try to
maturité 3.
achieve the high level of maturity, the appropriate level of maturity,
Ce qui leur permettra d'exporter des vaccins de
so
qualité
that they can be able to export quality vaccines.
AMA accélérera aussi la recherche clinique.
AMA will also aid in speeding up clinical trials.
Améliorera la disponibilité de nouveaux produits répondant aux
And
besoins de la population locale.
will help in the production of new medicines that are appropriate to the challenge that we are faced with of COVID-19.
AMA réduira
And
aussi la
it will
prévalence
reduce the prevalence
de médicaments de qualité inférieure et falsifiés
of poor quality and fake drugs.
grâce à des inspections mieux coordonnées
Thanks to
et un partage d'informations plus systématique
better coordinated supervision
et une pénalisation
and
significative de ceux qui
ensuring
ne
that
respectent pas les
there is
fondamentales.
significant sanctioning where necessary.
Donc, je voudrais, pour
So allow
ainsi
me
dire
to say that
que ce qui est
what's important here
ce qui est important
for
pour nous,
us
c'est de ne surtout pas
is not
oublier
to
que
forget
la procédure
that
continentale accélérée
the
de l'AVAREF pour l'évaluation des demandes
AVRF
d'essais
must
cliniques dans
ensure
le
that
contexte de l'urgence
it moves towards this process put in place,
ce qui nous a permis
which has
d'accélérer
enabled
le
us
temps de
to
mise en
speed up the job we are doing
sur le marché dans
of
la
vaccines
préparation contre les
and
menaces sanitaires
the
mondiales.
preparation of the mitigation efforts towards the threats we are faced with.
Donc, pour nous,
So for us, AMA
peut aider à
can
soutenir
help in supporting
la défragmentation
at the country level
recherche clinique en
when it comes
Afrique
to clinical research in Africa,
et
and
surtout en allant vers
especially when
la
we are
création
going
d'un espace
towards the creation of space
coordonné pour la
coordinated
production de
by the
médicaments.
production of drugs and medicines.
Donc, à notre avis,
So in our opinion,
les exportations ne sont pas autorisées si les produits ne sont pas fabriqués
exports are not authorized if the products are not, they're not produced
dans les pays
in
dont les régulateurs sont
the countries
certifiés
where
au niveau
the
de
regulators
maturité 3, comme je l'avais
are
dit,
certified elsewhere. As I said,
et nous devons aller
we
dans ce
must
sens. Parce
take this
qu'aujourd'hui,
direction because today,
même l'Afrique du Sud
even South Africa
aurait du mal aujourd'hui,
would find it hard today,
même si on produisait
even if they produced
des vaccins,
to face difficulties.
Donc, je
That's why
dirais
I
que
say that
il est très important qu'on aille AMA et qu'on puisse installer l'agence l'Afrique du Sud, la RDC,
South Africa, DRC,
l'Éthiopie, Kenya doivent rejoindre
must join AMA as quickly as possible.
Nigeria. Une fois que les grands pays auront adhéré,
once the big countries join,
les autres
then
vont certainement rejoindre AMA.
It will be easy for the others to join AMA.
Et l'ensemble des autres pays africains pourraient bénéficier
the other African
approche
countries will benefit from this unified approach.
Particulièrement avec
notably with the help of AFCFTA. I thank you, Chair.
So thank you very much, Michelle, for that passionate call for the AMA. I'm actually old enough to have watched when the EMA got formed and the controversies that existed where member states said, well, we have our regulatory agencies and we're happy with them. And, you know, there was this question of the national versus regional. I mean, today the EMA is a very accepted body. It's, you know, has a very substantial budget, close to 400 million euros, most of which, by the way, is paid for fees by people seeking advice. But of course, it's been very important in pharmacovigilance, as you talked about, and on engagement. So I'm curious, I understand that 34 states haven't yet signed or ratified the treaty in the AU. You've named some of those. Is that mostly now just because of the difficulty of the time and COVID and all of that, or is there some of this same concern of national versus regional engagement? And I'm curious, I understand that a new plan and budget is going to be made, which is obviously important. And how's that going and the timing for that? Thank you. You're on mute, Michelle.
I want just to say, excellent question to come back to your point. I personally feel that it was not by lack of interest. If you look at what is happening today with AMA ratification, it's certainly the fastest process of ratification we had in African Union. What is happening, of course, we were all faced by COVID, problems of priorities were shifted. Most of the countries were signing, were in process of signing, or the countries who signed were not going through the ratification process. That's what we are trying to do now. We have 21 countries who already signed. We are moving from one country to another to make sure that we can convince those countries for the rapid ratification, because we need 15 countries, and today we have already, after the visit in Guinea-Conakry, we can say that we have 8 countries who ratified. We need 7 other countries to be able to say that this African Medicine Agency can come into force. So for us, it is a process which we are trying to really push to make sure that it could happen quickly. But more than that one, it's important for us to project ourselves, to not wait only for the signing, ratification, and then what? I think it's very important listening to all the regulatory bodies in the continent, meeting with the Minister of Health who are engaged in this process, discussing with them to learn from their experience. We are talking about pharmacovigilance, we can talk about clinical trial, we can talk about so many different things, but what lesson we have been able to learn from those experiences and how we can combine them to really create an agency which will not be European agency of medicine, but which will be African agency of medicine, which will take into account our specificities, but take into account also the whole dilemma we had. For example, if you look at what I was saying at the beginning, it is a key for us to think about the commitment of leaders, political leaders, like President Kagame was taking this like one of the major tasks for him, because he considered that it is with effort for ZLECAf, with all the others presidents. But now that this treaty has been signed, is a opportunity, unique opportunity to really use AMA as an entry point to really create this unique market I was talking about. So I think it is, for me, a key momentum which we should not miss. This discussion today is timely and is topical. And missing that, we will regret, because it will not come back again.
So thank you, Michelle. I want to give the Honorable Minister from Nigeria a chance for a last word before we end the session. We're running out of time, and to see if you have any perspectives on this.
Well, thank you very much, everybody. I've listened to Dr. Sidibe's passionate presentation, and Nigeria does actually agree fully that we need AMA, we need AMA. We need to have it, and there are a few, one or two small technical issues that we believe need to be resolved, which we would like to take up with Dr. Sidibe. And once those ones are resolved, we are ready to go along. We do believe it's very useful, because in Africa you have quite a few young or weak regulatory countries with weak and young regulatory bodies, who will definitely need to come together to jointly review dossiers. And that's where AMA comes in as a platform for that, and also to bring together the total potential of Africa and harmonization of all facilities in there. So we'll be quite glad to take up a conversation to look at one or two technical issues that need to be resolved, and we are game for AMA. So as I think those are my parting words for AMA, and also to thank you very much for your for leading this conversation, and to again thank Africa CDC for setting it up. And thank you, Dr. Sidibe.
Thanks, my brother.
So I'd like to thank both of
I'm coming to see you soon.
You'll be welcome.
Thank you.
So I'd like to thank both of my panelists, and I'm sorry that the other panelists were unable to join due to connectivity issues, but I think we've had a good conversation. I'm not going to try to summarize, but just to say that the global community agrees with both of you and wants to be as helpful as we can to move forward. It is evolutionarily certain we will have more epidemics and pandemics, and we need to be better prepared. And I think, as the minister has said, we need to make sure that we support all countries, including the countries that have the weakest systems, in addition to those that have the strongest systems. And that solidarity and work is going to be very important going forward. So thank you both very much for the vision and the work that you're doing. And John, I think I'm handing back over to you.
Thank you, Seth.
So thank you, Seth, and Michelle. Good to see you. Good to see you again. And I hope Ethiopia will also be our next stop, not just Nigeria. An honorable minister, it's so close to a year and a few months that we were all in Addis Ababa, and we remember you rerouting your trip from Europe to Addis Ababa for the ministerial meeting, the emergency meeting of ministers of health. When the pandemic, we just had the first few cases in Egypt. That was a great sign of leadership there at that time, which actually led to the joint continental strategy. So Michelle, let us know when we can receive you here in Addis Ababa. And sir, thank you for the great moderation. We apologize that Minister Leah is actually, she and I spoke yesterday, but she was going down south of the country to do work that is in this pandemic. So I'm sure she has tried to connect several times, but was not able to, which is not quite unexpected. So thank you so much. Let's move on to the next session, and which will be moderated by Ahmed Okwer, who is the Deputy Director of Africa CDC. Ahmed, please, if you're on, take it and run with it.
Thank you very much, John, and a good morning, good afternoon, good evening, colleagues, wherever you may be. All protocols observed, and in the interest of time, we are moving into the last session, really, of this high-level emergency virtual meeting of African health ministers and all the health ministers that have managed to join. We are grateful that you found time. Now we are moving into this session 4, which is really going to look at a bit of an update on the vaccination landscape on the continent. And then we will tackle the issues around travel, because they are very closely linked with vaccination. The panel today are in 2 groups. The first portion of this session, we are going to have Nikes Ndembi from Africa CDC, followed by eminent Africans, Strive Masiwa, Professor Benedict Orama, and Donald Kaberuka, to speak about the Africa Vaccines Acquisition Task Team's work. And then the second section of this session will focus on trusted travel across Africa, particularly the innovative tools that are being developed. And of course, we will end that with a presentation from our Commissioner for Infrastructure and Energy Tourism, Her Excellency Dr. Amani Abu-Zaid. So we have those 2 sections within this session. So to start us off, I would like to call upon Nikes Ndembi, who is our Senior Science Advisor here at the Africa CDC, to give us a quick update on what the status of vaccination is on the continent. Nikes, you have the floor.
Thanks, Dr. Ahmed. Thanks, Excellencies, Honorable Ministers, partners, distinguished guests. Let me really stand on the existing protocol to share with you the status of the COVID-19 vaccinations on the continent. So really, I hope this is a good segue to the panel discussion that will follow with those eminent, really Africans working tirelessly to ensure that we secure enough vaccine doses for Africa. So one, I think we have set a continental target at vaccinating at least 60% of the continent population by 2022. And this is really not, as we usually have we've stated earlier, I mean, it's not unambitious, because if you look target, Look at the US, it's about 80% of the American must be vaccinated. That's Tony Fauci. I think China aims to vaccinate 70 to 80% of the population by mid-2022, and Italy aims to vaccinate at least 80% of the population by the end of September. I think this is based on the really some scientific data, scoping data, at least scope review data on the strong correlation between vaccine efficacy, coverage, and at some extent also vaccine effectiveness. I think the key public questions here is to really, what is the target really required to really achieve herd immunity? I think that's really from that background that we've set that threshold or that target at 60% to really create that herd immunity and block SARS-CoV-2 transmission on the continent. If you look at the R node here, that's the basic reproduction number. And also, if you link it with vaccine efficacy, at least if you look at it, and then with an R node of 3, I think to reach herd immunity, really it needed coverage of about 60 and above, 60% and above. So we've set that target with respect to this data and also finding and scope review. So it's quite clear if you look at the map on the right, on the left hand, that is really a shocking disparity in terms of vaccine distribution across the globe. But we're making significant progress on the continent. We quite want to appreciate that from when the first doses started really arriving on the continent. So we still have a long way with doses administered per 100 people. It's still at 1.5 with over 20 million doses administered. So Africa CDC really launch a website, a dashboard, which is live on a website, which provide information on the really vaccine administered, the supplied, the type of vaccine acquired through the COVAX facility, as well as the AVAT supply. I really urge you to visit our website and then get those informations, disaggregated information by member state, as well as also, as we said earlier, visiting the African Medical Supply platform for member states that have not placed their order yet for the vaccine that will be available from the Johnson & Johnson's COVID-19 vaccines. So as of the 7th of May, 2021, as clearly mentioned, over 20 million doses have been administered from 47 countries. We still have data missing from a couple of countries that you see on the gray on the map by your right side. So what's in terms of coverage, with the target we've set at 60%, we have 32 countries with less than 1% in terms of vaccine administered so far, and then 13 countries with a coverage between 1 to 10%. 2 countries are in Morocco at 13%, and Seychelles at least reach that target over at least 64%. So at Africa CDC, we really vaccines plus vaccinations. That formula stands for us as Save Lives. And it is quite important that with this concept that we're driving around vaccination centers that will really drive the vaccines at mass scale vaccination rollout on the continent. And this will require really some minimum financial support, and also ensuring that with the current overstretched vaccination program, that we have facility, a storage facility for vaccination, the personnel and vaccinated have been trained, the supplies that have been provided, IT infrastructure, and then also emphasizing on the previous comment around community engagement and risk communication. That's quite important to drive that effort. So the expectation was that by May 2021, we'll be expecting at least vaccines, at least over 70 million doses from AstraZeneca vaccine from the COVAX facility, and over 300,000 from, again, Pfizer vaccine from the COVAX facility, leaving us by at least June 2021 with a gap of 45 million doses. But you're quite aware that there are some challenges around the vaccine distribution, also access to the vaccine, to COVID-19 vaccines supplies. So to address some of this, and I just want to be re-emphasizing that 20% of the 20 to 25% of those vaccines will be provided through the COVAX facility, and then the African Union through the AVAT African Vaccine Acquisition Task Team will be actually complementing that effort to reach the target of vaccines at least 60%. So through the African Union initiative, we've been able to secure at least 400 million doses, 220 million doses secure, with an option for 180 million doses from the Johnson and Johnson, and also provisionally secure over 200 million doses. There are key challenges that we would like to really emphasize on: the low uptake of doses in some countries, and secondly, significant logistics challenges. We aim at least to vaccinate 35 to 40% by the end of 2021, and then also that's been spotted on the challenges of the spread of viral mutant, the new variant, SARS-CoV-2 new variant across the continent, which has a significant impact on vaccine efficacy and also on vaccine coverage and probably also on herd immunity, as earlier mentioned. And I will leave you with three key priorities. The first one is on vaccine acquisition. As we mentioned, it's really urging member states to placing their orders on the African vaccines, African AMSP, the African Vaccines Supply Platform. And then the vaccine deployment, including mass vaccination sites, that will probably drive the process, and as well as the community engagement process, and as well, finally, technical support and capacity building that can be provided to member states to be able to achieve the 60% target that we have set. Thanks, and over to you, Dr. Ahmed.
Excellent, Nikes. That's a very good introduction to the situation of COVID-19 vaccination in Africa. And now let's move on to the three eminent Africans, and I will ask first Mr. Strive Masiyiwa, who is our AU Special Envoy for COVID-19, to begin before the other two eminent Africans also make their contribution. Strive, you have the floor.
So, Ahmed, it seems Strive just sent a note that because of emergency family meetings, family issues, he had to be pulled away. So I think Professor Orama can help with coordinating that roundtable conference, since he works very closly with Strive. And
yeah, absolutely, and I can see Prof is ready. Prof, I will not introduce you, it may take too long. So I will just say that Professor Orama is president of Afrexim Bank and indeed chair of our board of trustees for the Africa Union COVID-19 Special Fund, and is a very key engine behind the AVAT team, the Africa Vaccines Acquisition Task Team. Professor Orama, you have the floor.
Yeah, thank you very much, Excellencies, Honorable Ministers. Let me begin by thanking His Excellency President Tshisekedi Chilombo, Chair of the AU, and His Excellency Musa Faki Mahamat, Chair of the AUC, and John for inviting us to speak today on this very important subject. I also like to thank the ministers who are here, who many of whom we've been working with over the past 1 year as we try to combat this pandemic. I also know that this must be close to the time, or is the time for some of our colleagues, Muslims about to break their fast. I say Ramadan Karim to them. This matter, the matter we are about to talk during this session, is very important for so many reasons. But key, I think Nikesh touched on them, and of course, presentations in the morning, including the one made by Dr. Kegason, also emphasized it. The continent is not about to rid itself of this disease yet. We've had several ups and downs, peaks and troughs, several waves, if you want to call it that. But we've seen from what is happening in India and Brazil that each wave comes with even more intense ferocity. And the challenge for us on the continent is that if, God forbid, we face the kind of situation that we are seeing in India today and even Brazil, it will be disastrous. And it will be disastrous not only from the health point of view, but also political point of view. Because as we all know, many of our countries are dealing with a couple of issues. So when countries now are faced with those challenges, some of them will flare up into other issues that can derail the country for the continent for decades. I think we must do everything to try to avoid it. I take us back to August 2020. I think at the meeting of the Bureau of Health of State, which was convened by President Ramaphosa, the Africa CDC recommended that Africa should aim at achieving 60% vaccination rate for herd immunity. I think Nikesh also provided the scientific basis for that recommendation, and that was adopted. In November, again at the meeting of the Bureau, President Ramaphosa constituted and set up the Africa Vaccine Acquisition Team. At that time, about 2 million cases had been detected on the continent, and about 50,000 people had died. But it was becoming obvious that Africa had to do something to complement the expectations of deliveries of vaccines from COVAX if we hoped to deal with this pandemic just like other people we are trying to do. That Africa Vaccine Acquisition Team was the founding members at that time were His Excellency Musa Faki Mahamat, Dr. Zweli Nkize, the Honorable Minister of Health of South Africa, Mr. Strive Masiwa, the AU Envoy for Procurement, Dr. Donald Kaberuka, the AU Envoy, Special Envoy for Economics, myself, Her Excellency Amir Fadil, Mohammed, the Commissioner for Social Affairs, Dr. John Kengason, the Director of Africa CDC. And we were asked at that time to help define the requirements and also to help negotiate with the different vaccine manufacturers. By that time, it was becoming obvious that the vaccine market had become very, very tight. So the AVAT was also tasked to help secure vaccines. And the third main task we were given was also to help arrange the financing for those procurements. It is following all of that that AVAT started work. And the work of AVAT was underpinned by two key AU, decision of AU organs. Can you move the slide, please? So the F-15 in October made a decision, as you can see on that slide, and one of them was that AfriCIMA should be supported through a capital increase to enable it support the procurement of vaccines. Then in February, the Executive Council also made an urgent request for AfriCIMA to support the continent and the procurement of COVID-19 vaccines, which, as you can see, that's the first bullet point there, kind of reaffirming the decision made by the F-15. And they requested us as a bank to work with the envoys, with Africa CDC, with ministers of health and ministers of finance to be able to do this. It was based on that AVAT then worked with AfriCIMA to create a structure that will help it implement the decision. Next slide, please. As you know, there is the idea of creating the Africa Vaccine Acquisition Task Team was for it to enable the procurement of vaccines on a whole of Africa approach. It was obvious that individually, our countries will find it difficult to negotiate with vaccine manufacturers who were inundated with orders and who were not going to pay attention to countries coming to negotiate very small orders. It also felt that that was the most cost-effective way of negotiations, because the pooled approach will make it possible to achieve lower pricing. But having said this, there was no institutional arrangement to be able to do the whole of Africa approach. So what the AVAT did was to create a trust called the Africa Vaccine Acquisition Trust, which was created with the trustees being members of the Africa Vaccine Acquisition Task Team. AfriCIMA was the settler and the enforcer of the trust. With them, made it possible for an institution to be created to face the manufacturers for these negotiations. And our team at the bank worked with the Africa Vaccine Acquisition Task Team to negotiate with 7 manufacturers. We covered more than actually 7. We negotiated with literally all vaccine manufacturers that had made progress with regards to production of vaccines, including Johnson & Johnson, Pfizer, the Serum Institute of India, Bharat Technology in India, the Gamaleya Institute in Russia, the Sinopharm, Sinovac, and so on. We negotiated with all of them. The idea being to see if we could get a portfolio that would address the needs of the continent. The structure we created had a number of entities, as you can imagine. We have, as you can see on that slide, the Africa Vaccine Acquisition Trust as a center. That is the entity that was entering the contract to purchase those vaccines. But because the Africa Vaccine Acquisition Trust has no balance sheet to back its mandate, then AfriCIMA provided was providing the guarantees to back up the commitments the Africa Vaccine Acquisition Trust was making on behalf of African member states. Before making any commitment, the Africa Vaccine Acquisition Trust was supposed to have received pre-orders from different African states. And then based on those, they will be aggregated, and that will be the order to be negotiated with the manufacturers. Also, the Africa Vaccine Acquisition Trust negotiated services agreement with the UNICEF to provide procurement and payment services as necessary, and other logistic services. It also negotiated service agreement with Africa Medical Supplies Platform, which, as you know, was created last year in collaboration with Africa CDC, through which the whole of Africa approach was being implemented in terms of allocation of available vaccines and distribution of any supplies. And Afrexim Bank, as I mentioned earlier, providing guarantees, providing financing to entities that needed it, also to provide payment services. Afrexim Bank is also the entity to negotiate the no-fault compensation fund that the manufacturers needed and put it in place. So following this, creating this structure, we then opened a very serious negotiation with Johnson & Johnson for their COVID-19 vaccines. And the reason we prioritized Johnson & Johnson was one, because it was a one-shot vaccine. So we thought that would be the most efficient for Africa because it would reduce the logistic cost of administering the vaccines. Again, the temperature, as you know, is also similar to what we have with AstraZeneca in terms of it being easier to manage also in vaccinating even in rural areas. And finally, a very important factor, it was also being manufactured under contract in South Africa. Aspen Pharma was also manufacturing. We had looked at it because we saw what was happening with vaccine nationalism, where even countries who had entered agreements and paid money were not able to get deliveries. So we thought that it would be safer entering a contract with an entity that has a contract manufacturing arrangement with an African entity. So those were the main reasons why we prioritized the Johnson & Johnson. And as I think Nikesh mentioned earlier, we were able to sign an agreement on March 28 for 400 million doses of vaccines. Those doses included 220 million committed doses and $180 million doses in option. That option we have to exercise by September. The reason we entered the option was first because we expected that if countries follow the recommendation of the Africa CDC and COVAX deliver the commitment, that we will need actually 400 million doses to be able to reach 60%. We also thought that notwithstanding that there will be a need for booster shots next year. And because there will be a need for booster shots next year, and we were already seeing that the Americans, the Europeans, some other countries in Asia, we're already making orders for 2022, 2023. We might get to 2022 when we need that booster shots and find that we will not have capacity. There will be no manufacturing capacity. So it was important to have this option. In September, countries who need it would indicate so that we can also then place the order to make it possible for them to do the boosters as may be necessary the following year. The situation with that, the arrangement we have with Johnson & Johnson is that we are now asking countries to sign the firm commitments. Afrexim Bank has already paid on behalf of all the countries the down payment, which is a 15% non-refundable down payment in an amount of $330 million. That was paid about 2 weeks in the middle of April. 2 weeks after the agreement was signed. So we are now asking the countries to firm up their orders and to pay the down payment so that their orders will be fully regularized. Can you go to the next slide, please? The slide you have there, it shows the status of uptake of the vaccines as at today. I would say that they have been a bit slow. You can see the countries in gray that have not yet confirmed their orders. So those countries, one of the things that peers are making today is for them to confirm their orders. There are about 21 of them, and their list is there, and we would be able to provide this information for those who need it. Those orders can be made through the African Medical Supplies Platform, through the Africa CDC, or through Afreximbank directly. Can you move to the next slide? What I need to add here is that the firming of orders will not be an open-ended. At a particular time, in a matter of a few more days, we will have to close it so that we can finalize the delivery arrangement, working with UNICEF, working with Johnson & Johnson. So we want to make an appeal to all of you, especially those who have not made their orders, to please make your orders. This is a continental arrangement, and what the bank did was to just facilitate this. So countries should take advantage. We are also working with the World Bank to make sure that countries also obtain concessional financing and grants if they meet the requirements of the World Bank. We know that about 39 requests are on the table, and that the World Bank is processing them quickly. We are engaged with them on a regular basis to make sure that the approvals are granted as quickly as possible. Afreximbank itself has the financing in place, the installment to payment plan, which is being provided at a subsidized rate for countries to be able to pay if they do not have the budget to make the payments immediately. There are also a number of African banks. The Arab Bank for Economic Development in Africa is also offering support to some countries in the form of grants. There are also other banks that are working with us to make it possible for different countries to access financing should they need to make these procurements. Now, once again, thank you very much for the attention, and thanks to John and his team for the wonderful work they're doing on this.
Thank you very much, Professor Rama, for that impassioned call to all countries represented here today. Make your orders so that we can be this continent, that 60% that Nikes talked about earlier. We must get the vaccines onto the continent. Now it's my pleasure to invite Dr. Donald Kaberuka, who is another of the AU special envoys for COVID-19, so that he can be able to complete this section of this session. Dr. Kaberuka, you have the floor. Dr. Kaberuka, you may be muted if you're trying to speak. I see he's online, but maybe connection issue. Dr. Kaberuka, can you hear us? in the absence of that, we can be able to take one or two questions for this particular section to both Anikase and Professor Rama, so that we will be able to shift into the next section of this particular session. So those who would like to ask a question, this is the time. If you can use the raise hand button, then we can be able to proceed. Let me start with Dr. Kennedy Malama.
Thank you.
And then followed by John.
Thank you very much, Dr. Ahmed, for this very important session. Just a few points I would like to bring up, which some of them will call for some response. I think we would like to add a voice that the African Union should also continue impressing upon the COVAX facility so that those commitments which were made to member states or to the prioritized countries can be fulfilled. As you are aware, many countries in Africa have given the first dose of AstraZeneca, and we continue depending on the AstraZeneca next consignments to come for us to fulfill the second dose. So a strong voice from the African Union will be highly appreciated. It will be also good to hear from the panelists there how the indemnity contracts or agreements under the AVAT are being navigated. Again, we learn lessons from the COVAX on what has been done. Again, we note that WHO has given emergency use listing or emergency use authorization to Sinopharm in the last 24 hours or so. Would like to hear whether through AVAT there are initiatives also to engage the Chinese authorities so that we see if Sinopharm can also be available. This is coming from the fact that we need more than 1.4 billion doses for the continent for us to ensure that our people are vaccinating. And also we've seen an emerging trend which is positive, the US raising the voice on waiving the patency on the manufacturing of the vaccines. Again, it will be good for our African Union to add even a stronger voice at this stage so that ultimately we can have better availability of the vaccines in the continent, including manufacturing. Thank you very much, Dr. Ahmed, for this opportunity.
Thank you very much, Kennedy, for those comments and the two questions. John?
Yes, thank you, Ahmed. Let me, mine is a comment and a reflection. And first of all, thank Professor Benedict Orama for your really extraordinary leadership in this fight against the pandemic that is sweeping across the world, but particularly on our continent. Unfortunately, Dr. Donna Kaberuka and Strive Masiwa are not here, and Vera Sungwet. They have been truly inspirational and my heroes in the fight against COVID-19 on the continent. We work very closely. We are on coordinating calls nearly every evening from 9 p.m. East African time to 11 every night, and I really mean every night. And it's been a great learning lesson from people with such a big heart to solve public health problems on the continent. So I have a couple of reflections. One is that as a continent, we must take our own health security into our hands and actually do what we as the continent have agreed on, and which is to work with AVAC to secure the doses that we have made available. That is, each country has to really approach that and then take their own allocations. The Johnson & Johnson vaccine, as the previous speaker indicated, is a single-dose vaccine. So if we have signed contracts for up to 220 million vaccines, with an option of going to 180 million additional doses. That brings us to a total of 400 million vaccines, which is, if you compare that with the 2 doses vaccine, it's almost 800 million doses there. So that brings us almost close to half of our requirements. And if COVAX COVAX has indicated that they were ready to provide up to, I think, 700 million. Said is here, you can clarify that. Then we are very close to our needs, but there need to be uptake and movement there. So we've worked very hard to secure those as AVAC, the African Vaccine Acquisition Task Team. It is up to countries now to show the leadership that and what I call the fierce urgency of now to protect their people and protect their economies by securing those vaccines while waiting for the COVAX vaccines doses to be available. I think this is will be a great mark of leadership for all our member states if they did that and do that urgently. The doses will begin to arrive the third quarter of this year. And we believe that we have a challenge now, but that challenge will be a question of 2 months or so. That challenge will be unlocked if and only if member states take on their own responsibility and engage with doses. My last comment is the question that was asked a few minutes ago from the floor about whether what we are doing as AVAC for the Sinopharm vaccines. We've talked to all manufacturers. All manufacturers have been approached, and including the Sputnik, including the 2 Chinese vaccines. So I think it's good news that Sinopharm was WHO was given the WHO emergency authorization use just the other day. I think that will increase the possibility for countries to actually buy directly if the volumes are there. But what I'm saying, and to end on this, is that AVAC has secured enough Johnson & Johnson doses that all we need now is for countries, member states, to approach that platform and provide allocations for their countries so that we can move that process forward. It is an extraordinary historic moment to have secured those doses there. So I thank you, Ahmed. I just wanted to compliment what Professor Orama has brilliantly stated.
Thank you very much, John. And that at least covers one of those questions that have been asked. I'll call upon now Moga Kamaliani. Please ask your question. Make it 1 so that we can catch up on time. Moga.
Hello. I work as a consultant to UNAIDS. So my question on Johnson & Johnson, first, it is brilliant that the AVAC secured the doses, absolutely fantastic. And by the way, thank you for today, for organizing today, and for all your wonderful, wonderful work. I really appreciate it. My question is the current status, the current problems with production of Johnson & Johnson in one particular facility in the US, and the regulators and the fact that the regulator in the US, the EU, and CDC kind of posed the approval or the acceptance of the Johnson & Johnson vaccine. How would that delay? I mean, obviously they will sort it out and the company will sort it out, but would that delay the supply to Africa? And did you get any information from the company about when they will resume production and therefore when they will give us the vaccine? Thank you.
Thank you, Moga. And for this round of questions, I will ask Sarah Jarvin to ask her 1 question. Sarah? Sarah, for your question.
Oh, I'm sorry, I was muted. Thank you. Dr. Roma, I'm wondering if you can talk about what is the interest rate that countries will pay the Africa Exim Bank back for these doses. Thank you.
Thank you, Sarah. So we'll go back to our panelists to take some of those questions, and we'll come back with another round, time allowing. Professor Am, I think there are two questions there for you. One is the issue of indemnity, and second is the issue of interest rates. And John, the issue of the possibility of knowing when the second batch of AstraZeneca may come, although I see Dr. Moeti has given her assurance in the chat that those will come. The only question is when. So we'll start with Professor Rama around the indemnity and the tax, and then John, you can weigh in on the issue of the second batch. Professor Rama.
Thank you very much. I think the first one, indemnity. I think there are two aspects of what the manufacturers ask. One is, of course, the indemnity, and the second is a no-fault compensation fund. I think the issue of indemnity, I must say that the negotiation with Johnson & Johnson on that particular matter has been not as bad as we saw in some others. So the indemnity side, I say, was easily navigated. It's easier. It's not that it is something anybody would have liked to do, but in the scheme of things, it was easier. And of course, there's a market for that also, for dealing with that. But the more difficult one, the more maybe somebody should mute.
Jira, please, can we ask you to mute, please? Jira, you are interfering with the conversation.
The second thing is the no-fault compensation fund, which people are asked to set up, which it was agreed that to also do it at the VAT level on the whole of Africa basis, so to say. So we are putting it together, negotiating that with Johnson & Johnson. That is still on, but they were also understanding with regard to the speed. So we are trying to finalize that front of WHO on it. So we believe that to find a landing that is not very different from what currently exists for the COVAX arrangement. With regard to interest rate, as I mentioned, we are providing this from our point of view at the subsidized rate is below the cost we normally would charge. And it is depends on the term of the loan. We are providing financing countries can take at their option for 1, 2, 3, 4 to up to 5 years. We are aware that the World Bank will approve lines. We are getting that. But once the World Bank approves, it takes a while for the disbursement to happen. The countries will need what call it a bridging finance to welcome for the countries to take that. So what we do is that those countries, some of them are taking 1-year facilities, some are taking even 18 months, as we've seen. But there are others that have chosen that they will just take the facility and have requested for 5 years, or they're going all the way. So what we see is we see spreads of under 3% to up to about 5%. That's what you see as you go to the 5 years. That is these are the terms for the finance. I think there was some question that Moga asked I don't know whether that was AstraZeneca. I think he was asking about Johnson & Johnson, about the facility in Maryland.
Yes.
About whether it's affecting the supply. We have not been advised by Johnson & Johnson that it will affect delivery. But we are aware that the issue is there. We expect that a decision or a position on the status of that facility will be taken in the coming days.
Thank you very much, Prof. Very clear answers there. I see Seth is here. So Seth, I think the burden of the AstraZeneca question will come to you about when we may be able to receive the second batch of those that had been promised. Seth?
So thank you so much. And let me just say that it has been a difficult time for supplies across the world. So, this has not been just in Africa, but in other parts as well. COVAX is delivering, as you've seen. We've delivered to 121 countries and now 54 million doses. The big delay we had was in India, which of course is the largest producers of vaccines in the world. And they have taken the doses that otherwise would have been available for the spike that they have now. And so we're behind by next month. It'll be 190 million that they will start providing vaccines again. Just say three things. So first of all, we're diversifying the portfolio. 8 vaccines in it. You've probably Novavax and Moderna deals this last week. We'll be announcing some more, plus larger quantities of the existing vaccines. And we plan to get up to 10 or 12 different vaccines in the portfolio. On AstraZeneca, we had commitments for 720 million doses. So Dr. Moeti talked in the timelines that there will be doses coming, but it is very hard to be able to say exactly when at the moment. WHO's guidance on this is to use the doses one has because a single dose does provide protection. And I want to say that we are looking hard to also get sharing of doses right now. There are 1.5 billion surplus doses that have been ordered by countries. One of the reasons there's a global supply constraint is because countries have ordered doses not knowing which are going to work. And now that they have surplus doses, and already France has not only donated doses, but provided them on the continent. And we have commitments from Sweden, Spain, Belgium, Portugal, UK. Every day we're hearing more commitments of sharing of doses. The US has excess doses as well. And so we hope to be able to provide via the commercial, but also via the shared doses going in the future. Since I have the floor, just a word on and Prof was right about J&J and Eminent. The work is going on in that plant, and we should hear in the next few days how that's playing out. But of course, J&J has a diversified set of manufacturing sites around the world, so that's not the only site. And so it is unlikely that that will dramatically slow down or change the rollout of the vaccine going forward. But we have a very close working relationship with the African CDC and the vaccines task force and continue to work going forward. We will be publishing new allocations in the next few days in terms of timing and what we think will happen in the near future. So thank you very much for letting me speak again.
Thanks a lot, Seth. Dr. Moeti, you had a comment in the chat. Maybe you want to share that with everybody by voice.
Yes, thanks very much, Ahmed. No, in fact, it's because Seth didn't have his video on that I thought I would slip in. Now that he's responded, I think the response has been very comprehensively provided. I think it just remains for me to really, again, congratulate the AVAT, the leadership, the actions, the agency, the strategic approaches, and the courage, really, to go on this very unprecedented initiative, which is delivering results. And just say that as a member of COVAX, WHO, we are committed to working with you, and we already are working together very much. The context is difficult, as was already said by Seth, but we are working to provide the information very much at the global level, regional level, and very much through our country teams, who are working closely with the ministers of health. Thank you very much. I'll stop.
Thank you very much, Sidi. So two final questions, Mansour Ahmed and Elizabeth Owiti. One question each, please, to the panel. Mansour. Mansour, we don't seem to have him able to speak yet. Elizabeth Owiti, one question. Elizabeth Owiti, one question. Mansour, are you back online? We don't seem to have either of them. Ismail Sambo. Probably connection problems. Professor Rama, Mansour had asked, and I will summarize his question, do the Afrexim Bank have any plans to support, in terms of financing, production of vaccines on the continent by providing longer-term financial instruments? Professor Rama.
Yeah, thank you very much. That's the question we ask all the time. If you recall, at the vaccine manufacturing conference, President Bank and the African Finance Corporation signed the cooperation agreement to work on establishing pharmaceutical manufacturing facilities and parks, including to have possibly vaccines. We've also had discussions with Aspen and also with the Pasteur Institute. The key thing about vaccine is demand. I think the best person to answer this question would be Seth, because the demand today for vaccines is driven by the public procurement. And most of that is done through the WHO, Gavi, UNICEF arrangement. And unless you have those demands come to Africa, the vaccine manufacturing will struggle. We are aware and we think that the commercial demand may begin to rise if the malaria vaccine comes on stream. And of course, the HIV vaccine becomes widely available. Maybe the commercial vaccines market will expand. But a lot will depend on the WHO, the Gavi, to make vaccine manufacturing a success on the continent. Unless they commit to give the orders as they are given to the manufacturers in India, it will be a challenge to manufacture vaccines successfully. And I think there have been discussions going on, and I think Seth can confirm that. But let's first get through with the studies that are being done, and then we'll see.
Thank you very much, Professor Rama. And then the final question here for Nikes, your slide number 2. This is from Dr. Christian Mawala. That your slide number 2 on community immunity is, he says, is very important, and is asking that, can you elaborate a little bit more, as many countries are questioning the issue around community immunity. Nikes?
Hello, Dr. Ahmed.
Yes. Should I repeat that?
No. I got the question. So I think it's quite clear that if you really want to block transmissions over time and also get rid of this virus on the continent, we really have to vaccinate at least, as we've said, 60% of our population. That's very important so that we can reopen our economies, reopen our borders. I think that's really it's quite critical. If you look at just for other infectious diseases, at least measles, to reach herd immunity, you really have to vaccinate about 90% of the population. I think those are really data that have been scientific data being used to substantiate the need to vaccinate about at least 60% of the African population. I think that's the information that I can provide with respect to that question. Thanks, and over to you, Dr.
Thank you very much, Nikes. And the very final question is from Her Excellency Deputy Minister Marie Khemes. You have the floor to ask your question, Minister. Minister Marie Khemes, can you ask your question, please? Dr. Marie Khemes, are you online? You're muted. In that case, then let's bring this very exciting
Well,
section.
I'm online. Hello.
Okay.
I'm online.
Please ask your
online.
question.
Can you hear me?
Yes, we can.
Okay. So, thank you very much for inviting me, and I thank the chair for the invitation. And I'm standing for the minister who is indisposed. So we followed with keen interest what has been said. I want to talk about the case of Senegal. I think that the African Union regularly receives information, and so currently there is a drop in the number of cases, but we are still vigilant. Now, what we must say today is that with respect to vaccination, we've started our vaccination, and we started first with Sinopharm, and then later on went to AstraZeneca, but we have some concerns. And so with respect to the second dose, and I think that between now and June, we'll have enough doses for the second vaccination campaign. So we align ourselves with Africans so that we can have enough doses for the second round. That's all that I want to say now. Thank you very much.
Thank you very much, Minister, for that very clear message of solidarity. And if we can now shift to the next section of this session, where we have a discussion around the Africa Union Trusted Health Digital Framework. And we'll have two presentations. The first will be by Dr. Edem Adzogeniu. I hope I got that second name right this time round. And the second will be by Her Excellency Dr. Amani Abu Zaid, the Africa Union Commissioner for Infrastructure and Energy, who will then speak about the Africa Common Position on COVID-19 passport. In between the two eminent speakers, I will ask the Honorable Minister of Kenya to give a very brief intervention on how practically the country implemented the Africa CDC trusted travel innovation. But first, let's start with Dr. Edem, who will speak to us about the Trusted Health Digital Framework. Dr. Edem, you have the floor.
Thank you very much, Dr. Ahmed, Excellency Chair of the African Union, Excellency the COVID-19 Champion, Excellency Chair of the African Union Commission, Director of the Africa CDC, Director General of the WHO, and Director of the Africa region of the same organization, other excellencies present, honorable ministers, dignitaries, and friends. As Dr. Ahmed has pointed out, we have the honor to try and bring up to speed all the delegates and representatives that are here on this very important issue of digital health, data, and interoperability across the continent. But I'll start off with a problem that has been mentioned several times on this at this conference, and that's the issue of trust. Trust among member states, trust at the levels of government and civil society, etc. And in the case of COVID-19, particularly in the early days when it struck, the challenge was how do you balance the twin interest of containing the disease, but also allowing movement in respect of the socioeconomic implications for that movement. So how do you enable people to continue to live their lives as normally as possible, but at the same time doing everything you can to break transmission and contagion? Air travel and travel across land borders were particularly problematic in this context. We couldn't continue to keep all the borders closed permanently. At the same time, we need to maintain a certain degree of control. The way that countries decided to go about this was to demand at the border that incoming visitors show evidence of non-infection. And traditionally, this would be a laboratory certificate of some kind. For the majority of countries, it was a PCR. For a very few minority, there was also a reliance on antigen tests. Now, the question was, when somebody showed up at your border and provided a particular test result or certificate indicating non-infection, how do you as a government, with a responsibility to protect your borders and your communities from imported infection, how do you determine that that particular certificate is genuine or authentic? Over time, a number of measures began to emerge, some of them at industry level, in airlines and the like, but it was quite clear that from government to government, there was a need, as we have in the area of anti-money laundering, anti-terrorism, etc., to provide a mechanism that governments can use to verify data that originate in one country. This data, in this case, being test results. So a particular laboratory in one African country, let us say Mali, generates a health credential, in this case, let's say a PCR test, for a citizen that wishes to enter Botswana. How do the Botswanan authorities find a mechanism that can give them assurance that the test result they have is valid? In addition, of course, to the long-standing issues around harmonized standards, etc., etc. So this was the problem that confronted the African Union. Luckily, the African Union, through the Africa CDC, rose to the challenge and implemented a framework which allows public health authorities, laboratories, airlines, port health authorities, and even hospitality operators to connect around a single interoperable platform so that data can move from one country to another within the full confines of the standards for privacy, human rights, to which the African Union URL for this initial implementation, and you are allowed to go on there and read as much as you wish to understand the full details of how the Africa CDC, on behalf of the African Union, went about implementing this solution. So this solution is currently implemented in such a manner that is fully interoperable with country systems, because most countries have also implemented different ways of solving the same problem domestically around the continent. We also know that regional economic communities have their own agenda in this area of digital health, data sharing, etc. So it's important that the mechanism interact with work that was underway in parts of Africa, such as the West Africa Health Organization, East Central and Southern Africa, etc. So the work that the West African Health Organization is doing with the biomass program, the work that some of the major health institutions in East Central and Southern Africa is doing with Delphix, and the work that the UNDP through their sponsorship have enabled with Global Haven, meant that we could create an interoperable system that benefits Africa, but also connects with regional programs and with global programs. It means that people coming into Africa from any part of the world are now covered this trusted data interchange model, obviously starting in the very narrow area of travel, have shown the power of cooperation in addressing even the most difficult problems. In this case, a problem that in the beginning appeared overwhelming, considering the number of stakeholders at clinical laboratory level, at the airline level, in the hospitality operations level, that needed to interoperate in order to create this. Some wondered whether international laboratories would be willing to integrate. Some wondered whether international airlines would be willing to integrate. We've proven that with the right frameworks in place and with the brand of the African Union, Africa CDC, and the trust that is accumulated over the decades, it is possible to build a trusted solution that enables data interchange for very practical, important areas. So what has been the journey so far? What has been actually accomplished? I'll break it down a little bit more, because this is important. A platform was built purely to enable countries to exchange data regarding the protocols that they were implementing in relation to travel and other control measures. So that was one platform. A second platform was created that had a digital lab registry in addition to data interchange models for laboratories around the continent to be able to connect with other relevant government departments across all the major countries. And this was therefore, in many ways, the very first time that such a digital lab registry allows real-time exchange of data with other parties, such as Port Health and the like. That obviously then enabled airlines and others to join, so that before an airline brings somebody into your country, whether or not you have on-arrival testing or not, so people don't carry, or airlines don't carry infected people whose infection may still be incubating, and therefore defeats the on-arrival testing mechanism that some countries had. And now we have the vaccination situation, which we will describe in a moment. Also, as I've already mentioned, there was a need to cover people that were coming from outside the African Union, and that has also been taken care of. And working together in a strict context of human rights protection, privacy, etc., to enable interoperability at all levels. What have we been able to achieve so far beyond building platforms? As many people really know, building it is not enough. You also need to go out and advocate. In the course of the Africa CDC's advocacy, it was possible for 49 countries to commit to provide the exit and entry requirements in a digitized format, which then enable all other stakeholders to access the system in real time, to know what kind of restrictions, etc., are prevailing in countries. So 49 countries have so far committed, 35 countries committed to implement the lab registries, which include providing data on the laboratories in their countries that are authorized to provide this testing. Of course, the system also provides the means for other countries to determine which laboratories across the union can generate health credentials that allow access into their country. And then end-to-end deployment is currently ongoing in 9 African countries. So 9 African countries have decided to implement all 5 platforms and are enabling the use of this system for health screening at the border, mostly at this stage at the air borders, but hopefully in the land borders very soon. We have 10 major airlines that operate at an international level that are participating, more than 2 million African beneficiaries to date. It's a very significant number. We hope that will increase to tens of millions in the coming months. And we want to give special credit to Ghana and Kenya for pioneering roles that they've played in making it possible for us not merely to implement these at a technical level, but also the political level, which often is lacking in some of the great ideas that African Union institutions come up with. And now we have the vaccination situation that has been under discussion in many ways around the table today. And most of you will be hearing very soon about the African Union common position that we wish a global moratorium is imposed that will prevent any attempt by any part of the world to implement a mandatory imposition of vaccine requirements for travel. That is the African Union position. Nevertheless, it's also important that African countries, African Union member states, build the capacity that is needed to digitize their vaccination programs so that citizens of those countries themselves can benefit from the vaccination that has been undertaken. So in simple terms, while we do not wish that this is imposed mandatorily, if somebody has nevertheless vaccinated, it is useful that we create ways in which that person benefits from having vaccinated. The nature of that is to encourage vaccination because we have these issues of hesitancy and other type situations. So trusted vaccines provide a toolkit that any African country whatsoever in any part of the region and any region of the continent can use to build their own digital vaccine system for things like scheduling, for things like cross-border management as an alternative or a substitute for PCR testing where it's necessary and where the science has been proven, for things like managing adverse effects, feedback, etc. That toolkit is available at no cost to member states, and we encourage everyone to visit the URL africacdc.org/trusted-vaccines to learn more about this and how they can benefit. Now that we've been able to prove that a common continental technology platform can be developed and the political will put behind it by major member states to drive a common agenda, it is time to move beyond merely travel into other areas of digital health, as speaker after speaker has urged us today. And that is why we're proud to be launching the 4D initiative, which brings together major AU departments responsible for a wide range of sectors, from education, technology, science, economics, all the way through agriculture, environment, and others, as well as, of course, other major Pan-African institutions, ranging from the African Academy of Sciences to the African Standards Organization for Standardization. The AFTA Secretariat is also on board, and that is great because of the fact that trade, economics, and all of these matters are now clearly interwoven. And it is this interdependency among sectors, which was already mentioned several times, lead to the socio-political and the socio-economic determinants of health that require that if we implement anything within health as a vacuum, we're bound to fail. And therefore, it's critical that these technology mechanisms that we've been discussing adopt a whole of society approach. The whole point of 4D, by being multi-departmental, multi-dimensional, hyperdata, etc., also allows us to address the issues of artificial intelligence, machine learning, and big data that have been mentioned several times. For every aspect of our response, we need Africa-developed algorithms and models that take into account developments and trends on our own continent in order to build these types of algorithms in a manner that responds to our unique needs and our unique context. That is very important. But how are we going to do that if we do not build enough automated data touch points so that the data can be hoovered and used for these kinds of very critical public health interventions and related interventions in development as a whole? How we do that really must follow the trusted health paradigm that we've already discussed. There must be interconnectivity and interoperability among major institutions in Africa, among different levels of the response element, and also obviously between governments. Which brings us to three major opportunities. One, since 1935, when the yellow card system was was promoted or promulgated, we've not seen an interstate health screening system emerge. Certainly not one that is digital and not one that is real time. Africa now has something like that. That is a major opportunity for a whole range of other things. The second factor is that having done it for a health screening basis, there is reason now to think within health itself to move beyond screening into other aspects of health. So we've talked about vaccination, serological activity that is ongoing, genomic sequencing that is ongoing, and we already have diagnostic data for health screening at the borders. How do we combine all of these things to do some amazing things? And how do we do it using models and algorithms, whether in the machine learning or the artificial intelligence area or in other areas that can help decision-making support in the different African countries? That's a huge opportunity as well. And the third opportunity is obviously that we cannot treat health and certainly not health innovation in a vacuum. We need multiple institutions across the continent, in civil society and in business to work together so we can integrate the socioeconomic layer into health response. Climate variability and urbanization, all of these are critical if we want to establish a holistic pandemic recovery strategy that is so more fundamental to our well-being going forward. So this is the whole concept of four-dimensional health, combining multiple streams of data, combining multiple stakeholders, combining the ability to respond in real time with the ability to share resources across the region, and emphasizing trust. If we did that, we can take solace from the fact that we've already begun to do these things in a fascinating way. The trusted travel mechanism that I described earlier on, which now is broadened into this concept of trusted health, already did that in the context of figuring out how to address the issue of fake certificates that may be generated by apparently legitimate laboratories, simply by comparing different data streams, such as on-arrival testing data versus pre-travel data, to see if there are patterns and anomalies that suggest a breach of the integrity systems that we require. So we already have the capability to use the data that we generate in diagnostics alone by adding geographical layers and mobility layers to detect fraud. If we were to add serological data, genomic data, and the likes of it, we can clearly take for granted the vast landscape that we will create for opportunities, not just in health, but in development across the board. So by broadening the surface area for innovation, we create powerful opportunities to transform the situation. What we started as purely anti-fraud and using machine learning to detect if a particular lab certificate is genuine or not can now move us into a broader notion of precision public health, combining all of these data forms in ways that respect human rights, privacy, and all of these other very important values, but which also enhances trust between governments, between different departments in the same country, among stakeholders, etc. And if we did that, there are practical things we can begin to do immediately. For instance, knowing where a particular person is coming from, combining that with whether or not they tested positive or negative in a particular area, whether or not they are immunized, etc. You can already begin to look at things like strains by adding the genomic sequencing data and helping you to select the right random samples and specimens for that genomic sequencing. And by using algorithms to reinforce the learning loops, you can begin to predict even where the next strains might be. This is a powerful, unique moment for Africa. And as I wrap up, I want to emphasize 4 key points. One is that we still have to do a lot better in telling everyone, including those of us in Africa and citizens in the different countries, the amazing work that is already ongoing. Some of this stuff that I've mentioned today in terms of work that is being done by the Africa CDC in this area of big data, analytics, etc., was not known to the majority of us on this call. That must change. The AU has a solution, but public engagement is critical. Now that we know that different continents are pursuing vaccine passports and the likes of it, like the Green Pass and others you might have heard of, first of all, in addition to asserting our political rights not to be discriminated against due to low vaccine coverage on the continent, we must also build capacity on the technological side so that we are not found wanting, we're not left behind. And then lastly, for far too long, Africa has been a passive taker of standards and innovation in many areas. That's changing rapidly, especially in digital technology, mobile and AI, and big data and the likes. Africa has shown that given the opportunity, we can do as well as any part of the world. And in many times actually, leapfrog a lot of the barriers that are ahead of us to lead the rest of the world. The AU has worked with the entire African continent to become a global systems shaper. And we believe that member states that are gathered on this call and other partners will join us in pushing forward this new innovation agenda. Thank you very much, Dr. Ahmed.
Excellent, Adam. I think the message is very clear that although we are in the middle of a pandemic, our capacity keeps on growing as a continent. And even in this new area of using technology to get some solutions within public health sphere, we are there. We have not been left behind. And I'm really looking forward to a time when everything that we are talking about becomes all very practical, and our governments across the continent support these innovations and make them a reality. Now, as part of that support, Adam did show that Kenya and Ghana were one of the first countries, indeed were the first countries to implement the trusted travel platform. And I'm going to invite the Honorable Minister of Health of Kenya, His Excellency Senator Mutahi Kagwe, to share with us from a country perspective the way that they have implemented the trusted travel platform. Honorable Minister, you have the floor.
Good evening, everyone. My name is Susan Koki from Ministry of Health, representing the Minister for Health, Senator Mutahi Kagwe, and I am pleased to give the Kenyan statement on the Africa CDC Trusted Travel Platform. Your Excellencies, distinguished dignitaries, ladies and gentlemen, it gives me great pleasure to be joining my colleagues, ministers, and our very good friends at the Africa CDC to review the joint continental strategy on COVID-19 since it was launched in February 2021. I am also proud to reaffirm and recommit the Republic of Kenya to this common continental effort to find innovative means of reopening our economies and societal, sorry, I am not able to get on video. Sorry for that interruption. I'm not able to get on video. I'm sorry, I have to take that again. I'm also proud to reaffirm and recommit the Republic of Kenya to this. I think I'm getting interrupted.
No, go ahead, go ahead.
Yeah, I'm not able to get on my video.
Just continue to read as they sort that out so that we catch up with time.
Okay, thank you.
Please proceed.
Just a minute.
Yes, we can see you now.
I'm also proud to reaffirm and recommit the Republic of Kenya to this common continental effort to find innovative means of reopening our economies and societies, even as we continue to maintain heightened vigilance about this devastating pandemic. Kenya strongly recommends and endorses the leadership of the AU and the African CDC have shown during this crisis and are thus proud to continue aligning our national policy objectives with the guidance the African Continental Task Force on COVID-19 has generated with such impressive regularity through the highs and lows of this difficult season of our lives. Whether in relation to the clinical case management insights or the program to accelerate clinical testing, our strong belief as a country in the African Common Front has seen us investing alongside other committed member states to ensure that the entire continent pushes in one direction to overcome the pandemic. I am particularly proud that Kenya was the pioneer country in the deployment of the Trusted Travel Platform. These are unified digital platforms built and sustained through a public-private partnership among the AU institutions. On the one hand, and the continued private sector with support from the civil society. Kenya has digitized the vaccine data records in a manner that is compatible with the Trusted Travel Vaccines framework. For so many leading public and private institutions to come together for the purpose of deploying a technology platform to make it easy for the citizens of one AU member state to travel to another member state and for laboratory tests results issued in one country to be verifiable in another country, we clearly must have arrived at a watershed as a country, as a continent. Kenya's domestic investment in this system has greatly reduced the inconveniences of travel for hundreds of thousands of visitors, many of them from within the AU, demonstrating the power of homegrown innovation in this continent's capacity to work together to address even the most difficult common challenges. As a country that has always believed in Pan-African policy innovation, it gladdens our hearts to no end to see African ingenuity not only on display, but supported and promoted by African institutions, technologies, and innovators. We therefore need no further convincing that the newly launched 4D innovation agenda of the African Union is the way to go. Regional harmonization and coordination in the reopening and multidisciplinary engagement across AU departments and the continent's multiple jurisdictions are not merely desirable, it is critical. Africa CDC and the AU institutions can continue to count on Kenya's staunch support for trusted health, trusted travel, 4D and broad innovation agenda. Thank you very much.
Thank you very much for that statement on behalf of the Minister of Health of Kenya, the inaugural country to roll out the Trusted Travel Platform. Now, let me check if Her Excellency Dr. Amani has managed to connect. Benjamin, did we manage, or should we move to the question and answer session? Okay, so let's move on to the question and answer session. And as people raise their hands at them, there are two immediate questions for you. One is how this particular platform is able to work with other platforms that exist. For example, the EAC Pass, the interconnectability of this particular platform. How is that, if you could be able to explain? And the second one is the interconnection between the interfaces of people, animal, and environment. If this is able to be captured in terms of surveillance using these new technologies. So these first two questions to you, Adam, before we go to those who will ask their questions live. Adam?
Thank you very much, Dr. Ahmed. Indeed, interoperability is at the heart of the architecture. The first level of interoperability was to be able to ensure that individual country systems can interconnect. So this has always been the priority of the African Union as a member states-driven union. So that was the first level of effort to get the country systems that were already in place. Some of them were digital, some of them were not digital, to get them talking to each other. Once that was done, we move on to the level of the subunits of the African Union and managed to engage the likes of the West Africa Health Organization, the EXA, and others. And that interoperability agenda is also ongoing with programs like Biomass, Delphix, etc. And we'll continue to press forward. The third level of interoperability, which will then emerge after these two are strongly in place, the member state engagement is strongly in place, and the regional engagements are strongly in place, will then be with other industry solutions that are also in the area. So it's been a matter of making sure that the foundation of the system is strong in the interoperability layer, and then being able to admit other solutions, even as we prove that the core interoperability between countries is working very well. Obviously, the issue around how do you move on health, that will be consumed, is what has driven us to this. We're talking about 4 days. Health.
Colleagues, can you mute? If you're not on the floor, please mute. Wesam, please mute. Go ahead.
Thank you very much, Dr. Ahmed. It's quite clear that we cannot be able to treat health innovation or health, the health response in a vacuum, in an isolated manner, or in a silo. And therefore, we need to create the mechanisms for other types of interventions that are going on the continent to seamlessly integrate with the health response. And when the question around, zoonotic disease and things like that arise, it becomes evident that the 4D agenda, which will ensure that there is integration of data from the climate side, from the agroforestry side, etc., and other types of socioeconomic data with the health response, will address the issue of human health, animal health, and how they intersect. Thank you.
Thank you very much, Adam. Very clear there. Now I will ask 3 questions at one time. That is from Mike Chisema, and then Amr Mokhtar, and finally Daniel Murenzi. IT, if you can give them the mics, please. Mike Chisema, Amr Mokhtar, and then Daniel Murenzi to ask their questions. 1 question each, please, colleagues. Mike Chisema. IT, if you can unmute Mike Chisema.
Hello.
Go ahead, Mike.
Yes, I think I'll just repeat the way I've asked my questions. There are 2. I'm from Malawi. One question is looking at the entire presentations and what Africa wishes to achieve. We have noted one challenge about the vaccine stocks, which I think we are all of us appreciating the challenges. We haven't been doing very well on first dose. And now we are looking up to getting the second dose, which has to run concurrently with the first dose. What can be done, or what is in place to ensure that we are trying to work to meet the demand, especially for both? I know we are trying to work towards making sure that at least Africa has an equal share and the vaccines are as available. But I think in the current situation, we really need to make sure that we have stocks that support both doses. I would like to know a bit of detail which AVAT and probably other platforms are doing to support beyond the COVAX. Secondly, I wanted to talk about the issue of the vaccine hesitancy and the delay in the vaccine delivery. We have had a challenge with the AU support, which we received, I think, vaccines that were only about 2 weeks or so, if not 3, to go. But you know, our ground was not very well prepared with a lot of misinformation, disinformation, infodemics, and many other things. But we had to strive through the 2 weeks to make sure that a proper percentage of vaccines have been utilized. And indeed, we achieved nearly 85%, if not 90%. What is it that's going to be in place to make sure that the vaccines do arrive in time and we have ample time to prepare the populations and at least be able to vaccinate before they expire, or at least we reduce wastage as well as expiry? So I think those are the critical areas which I feel, with the supply and demand challenges that we are facing, needs to be very well managed. Please, I submit my questions.
I thank you, Mike. I think one of those questions had already been answered in the previous session, but we'll see how to cover those 2 questions. Amr Mokhtar, for your 1 question. IT, if we can unmute Amr Mokhtar.
Hello.
Go ahead, Amr.
Yes, thank you so much, Dr. Ahmed, and thank you, Dr. Adam, for the excellent presentation. This is Amr Mukhtar from Egypt Embassy. I just would like to elaborate. Dr. Adam mentioned in his presentation that there are discussions with 10 major airlines in Africa to adopt the trusted travel platform. So if you can elaborate more and provide briefings about the discussions, any updates about how is it going, which airlines they are moving on, and what are the hurdles that they're facing joining the platform. Thank you so much.
Very clear there, Thank you very much. Finally, Daniel Murenzi for this round.
Yeah, thank you so much. Thank you so much, our moderator. I'm Daniel Murenzi from East African Community. I think, first of all, I want to thank Eden for a good presentation, and we have been having some chats for some time, which is good. We so appreciate the way forward for what the CDC and African Union is taking. But the special request was that as we are discussing for the better of tomorrow and the sustainability of our regions and the continent in nature, we need to go deeper and give more emphasis on how the regions are working. Someone has raised a good question about the interoperability with the especially ESC Pass, which is now functioning and operational. We started with the truck drivers. We are now going beyond. I have shared on chat. But the most important thing for our continent to move together, let's enforce the regions, because you find that the people we are facilitating as African citizens, the majority are on land borders, crossing from SMEs and trade and the rest. So when the REX, like the regional economic communities, who have taken care of that, now it would be helping the African Union level to now integrate the whole Africa. But it would take a big time and a big resources to now integrate all 55 countries of Africa in one platform. But once we know that we are integrating in one platform and putting the data and exchanging, because the technology allows that, it would now give the faster and we are able to address the current challenges. The same applies to also other measures that are being taken and the messages, and even these accredited laboratories we are talking of. You find that our regions, we are taking initiatives of doing accredited labs that are going to be in the system. So instead of duplicating a lot of efforts and what, so let's also look at what the regions are working on, the regional economic communities, Then we now integrate from there, and we are able to have one common solution for the continent. Otherwise, I submit and I will welcome you to see what we are doing on the ESC Pass. You can download it on both Google and the Android app, and the link I have shared it on the chat. Thank you so much, our moderator, and everybody. We thank you for this session that you had. Thank you.
Thank you very much, Daniel. Edem, two very clear questions there about the airlines and the challenges you're facing. And then, I mean, from Daniel, although he made a comment, for me, one thing that is standing out there is the issue of land borders and how we can be able to ensure that the trusted travel platform, indeed the 4D initiative, can be able to cover the land borders as well. Edem?
Thank you very much, Dr. Ahmed. So we've taken note of Mr. Morenzi's comments in relation to interoperability. I guess it reinforces the earlier point that was made, which is that we need interoperability at national level, interstate level, and then at interregional level. And that is already accommodated for in architecture. It's just a matter of operationalization. So some of the regions are ahead. We've seen the work that is going on in West Africa with the biomass program that enables the West Africa Health Organization and WAHO to be able to interoperate with the trusted travel system. So it's just a matter of emphasizing the operationalization of these solutions that are already there and which work is already ongoing to ensure that there is speed. So we welcome the strong emphasis on that point again. In respect of airlines, here also it was an interoperability question. The airlines have very elaborate and sophisticated systems, departure control systems, etc., that needed interoperability. That work has been done. And so now we have multiple airlines that are very effortlessly connecting, including some of the biggest names that you've heard of in the region. In respect of land borders, there are obviously 4 dynamics we need to keep an eye out of, and the new 4D and trusted health strategy clearly accommodates all of them. The first one is that the cost of issuing health credentials have to fall. So most of the people that are crossing land borders, as has already been indicated, are not wealthy, to put it mildly. So we cannot expect that they'll be paying $50 or even $30 per trip. So the cost of reducing health credentials have to fall. Vaccination might be one way, so long as the science holds up and we are able to convince ourselves that vaccination breaks transmission. An Africa-owned vaccine management solution, particularly a digital one, will be very important in that regard. The third area is that already the solution does exist, but there must be political will, as has already been mentioned, in order to move the solutions to the borders, to the land borders. And so we look forward to the ministers of health engaging with their colleague ministers for security, interior, and the rest, so we can move these solutions to the land border very quickly. And then the last point, which is quite critical, is that beyond working with the public health institutions, the private health institutions become important, because once you begin to increase the number of people who must be covered by the technology, then other actors in the private health sector become critical. And we think this is also going to happen for vaccination in order to increase coverage. So the technologies that we deploy must cover public health and private health facilities and systems. Thank you.
Thank you very much, Adam. Very clear there. So there are a number of questions. Mike, you asked 2 questions. One had already been covered around the doses, and Seth from COVAX had given a very clear answer about that. Then the issue of vaccine hesitancy, I think that also had been discussed a little bit earlier. But I will ask Nikesh to speak to the vaccine hesitancy piece very briefly, and then we can be able to move on to the communique. Nikesh, about vaccine hesitancy and the challenges around that.
Hello, Dr. Ahmed.
Yes, go ahead, Nikesh. The question was the hesitancy and the challenges around the rollout.
Yeah, I think that's it's quite obvious that we can based on the data, available data on the vaccine administered on the continent, that is there's an issue around vaccine hesitancy. I think in the early stage before the rollout of this vaccine on the continent, we had a very good feedback based on the continental survey conducted by Africa CDC. So it was quite clear that 4 out of 5 were willing to take the vaccines, safe and efficacious vaccines, when they will become available. But we've seen a change, a shift once the vaccine became available. So I think that has more to do around issues related to safety for some of the vaccines, and also the breach between fragmentation of information between what we have seen during the early phase and what's happening at the community level, which risk communication and community engagement could probably play a key role here moving forward. I think that's probably the explanation we can provide there. And Africa CDC and other stakeholders are working towards that to ensure that we bridge that gap and unpack the information that we actually generated from the survey and take it to really to the implementation phase. Thank you, and over to you.
Thank you very much, Nikes, and dear participants, excellencies. There are many points we could be able to continue to discuss, but time is not on our side. And as we had shared at the beginning of this particular meeting today, there is a communique that will be issued at the end of the meeting, and we wanted to share with you the highlights of that communique. I will step in for Dr. John to just take you through the communique so that you are able to see what it contains. And I will read through for purposes of interpretation so that we all can be able to see what the communique contains. So this is the communique of the high-level emergency virtual meeting of African Ministers of Health on COVID-19 situation in Africa, the theme being COVID-19 in Africa 1 year after. And it reads, "We African Ministers of Health gathered virtually under the leadership of His Excellency Mr. Felix Antoine Tshisekedi Chilombo, President of the Democratic Republic of Congo and Chair of the African Union, His Excellency Cyril Ramaphosa, President of the Republic of South Africa and the Africa Union COVID-19 champion, and the Chairperson of the African Union Commission, His Excellency Musa Faki Mohammed, on the 8th of May, 2021, for a high-level emergency meeting to evaluate the state of implementation of the Africa Joint Continental Strategy on COVID-19 and to discuss ways to adapt our response strategy in light of the continuous threat posed by the SARS-CoV-2 virus." In the preamble, it says, recalling the emergency ministerial meeting of 22nd February 2020, devoted to the COVID-19 under the theme Coordinated Actions to Prepare and Respond to COVID-19 Infections in Africa, that endorsed the Africa Joint Continental Strategy on COVID-19 and established the Africa Task Force for Novel Coronavirus, in short, AFCO, which is a continental platform to better coordinate our efforts across Africa. Cognizant of the fact that COVID-19 continues to pose a serious threat to socio-economic and health security of Africa's efforts to achieve its set goals of Agenda 2063, expressing concern about the morbidity and mortality caused so far by COVID-19 pandemic in Africa, the negative impacts on physical and mental health and social well-being, the negative impacts on economy and society, and the consequent exacerbation of inequalities within and between countries. Indignant at the fact that Africa faces delays compared to other parts of the world in accessing life-saving vaccines for COVID-19 and may experience similar delays in accessing vaccines in future pandemics or outbreak situations, recognizing the need for Africa to expand its ability to manufacture quality, safe, efficacious, and affordable diagnostics, therapeutics, medicines, and vaccines, essential health technologies to guarantee its health security needs, recognizing the concerning situation with the emergence of SARS-CoV-2 variants and the impact on the rollout of vaccines and effects on transmission. Inspired by the launch today of the 4D partnership, bringing together the Africa CDC, the Africa Continental Free Trade Area Secretariat, the Department of Education, Science, Technology and Innovation, the Department of Agriculture, Rural Development, Blue Economy and Sustainable Environment, the Department of Economic Development, Trade, Industry and Mining, all organs and policy are technical arms of the Africa Union Commission to advance a multidimensional, multidepartmental, multidisciplinary and multi-jurisdictional approach to development, and in particular, enable a fuller appreciation of the sociopolitical determinants of health within Agenda 2063. Cognizant of the fact that the 4D partnership's success relies on the public-private linkages it fosters across the continental public sector, represented by the African Union and the private sector, as well as civil society institutions at both regional and national levels in enriching the interactions among health, economics, and security, thereby hastening the emergence of a new innovation-driven public health order in Africa. Acknowledging the key leadership role of Africa CDC and the fundamental role of the Bureau of the Africa Union Assembly of Heads of State and Government and the African Union Commission in catalyzing and coordinating the comprehensive continental response to the COVID-19 pandemic and the central efforts of all Africa Union member states, welcomes the close collaboration between Africa CDC, WHO, and partners that has supported countries to strengthen their capacity to prepare for and respond to the COVID-19 pandemic on the continent, including 1, scaling up of laboratory diagnosis, including subtyping and genome sequencing; 2, enhancing screening at entry points and surveillance, as well as the use of uniform COVID tech platform for Africa; 3, strengthening infection prevention and control measures; and 4, implementing the public health and social measures. The high-level ministerial meeting welcomes the efforts by member states in response to COVID-19 pandemic, commends the efforts of Africa CDC, WHO, partners and member states in working closely under the Africa Task Force for Novel Coronavirus to coordinate our efforts across the continent, collectively endorse an adapted strategy with focus on prevention, monitoring, and treatment in order to meet the changing dimensions of the COVID-19 pandemic on the continent and the evolving nature of the disease globally. Also calls upon all member states to intensify their efforts for vaccination against COVID-19 as a critical component to prevent, contain, and stop the transmission of the disease and bring the pandemic to an end. Strongly urge member states to engage with the African Union African Vaccines Acquisition Task Team to acquire their COVID-19 vaccines. Also welcomes the United States of America's support to the World Trade Organization waiver and encourages other countries to join the Africa Union and the USA in making the right decision by supporting the WTO TRIPS waiver proposal. Acknowledges that the WTO waiver proposal is the first important step to expand manufacturing of COVID-19 related tools, including vaccines, and a relevant initiative to ensure truly equitable access to vaccines, medicines, and tools during the pandemic. Encourages all countries, including those home to manufacturing of vaccines and relevant COVID-19 tools, to fulfill their promises of vaccine equity by ensuring that the WTO waiver is accompanied by the necessary and relevant transfer of technology, skills, and capacity to support and secure African manufacturing. Endorses and supports the Africa Common Position on COVID-19 passport, which calls for a global moratorium against the mandatory and unilateral imposition of COVID-19 vaccine requirements for international travel in the face of low vaccination coverage in Africa, while encouraging the continued development of digital vaccine wallets and related technological tools, especially those based on the African Union Trusted Vaccines Toolkit, to maximize the benefits of vaccination to the African public. Appeals to all Africa Union member states to leverage harmonized continental digital technologies for the response to COVID-19, including for addressing its socioeconomic impact, paying particular attention to digital inclusion, patient empowerment, data privacy and security, legal and ethical issues, and the protection of personal data, which are values enshrined in the official African Union Trusted Health Framework and its digital archetypes, the Trusted Travel and Trusted Vaccines platforms, provided at no cost to all member states to drive the digitization of their COVID-19 response efforts. Support the mission of the 4D partnership launched at this meeting among African Union departments and organs to combine innovation-focused initiatives and technological systems, interconnect data streams, and build common electronic exchanges, repositories of algorithms and scientific models to address multiple developmental challenges that impinge on public health on the continent, such as the interplay of genomic diagnostic mobility and genomic data in the tracking and prediction of pathogenic variants and mutants, and climate variability and urbanization. Further, call upon partners to support Africa CDC, WHO, and Africa Union member states in the implementation of the joint continental strategy and in strengthening their health systems to respond to the COVID-19 pandemic and in maintaining the safe provision of all other essential public health functions and services. Virtually signed here today, the 8th of May, 2021. This, Excellencies, ladies and gentlemen, is the draft communique proposed to be issued at the conclusion of this high-level virtual ministerial emergency meeting. John, I take it back to you for finalization.
Yeah, so thank you, Ahmed, and the Excellency. The communique is open for any suggestions, modifications, additions, subtractions.
I think, I don't know whether you see me.
Yeah, Prof. Orama, sure.
Oh, thank you very much. I know the ministers would look at this and make their inputs. But I also thought that the call on the countries to take up their vaccine allocations is important, that which, based on the procurement that already been done by that, I thought it should be part of that communique.
Can we, Ahmed, can you move it down to where we talked of where the AVAT is mentioned? Or we just capture the comments. I mean, or you can just capture the comments and again, the ministerial communique. So please, this is for the ministers. If Benjamin correct me here as policy, that this is, I mean, we need comments from member states and for ministers.
Yes, you are right, Dr. John.
Yeah, not the general public. So.
Akona, just capture that, what Professor Rama has said around they call upon member states to take up their allocations as made by AVAT. We'll get the language clean, but that's the essence.
Yeah, which can go on the can be modified in the other section about AVAT. So that is well noted. Ministers and member states representative, please.
There are a few typos which I assume will be taken care of.
Absolutely, it will be edited, Excellency.
Use a spell check or something to remove the typos in there.
Yep. John, I see Professor Marufi's hand is up.
Okay, I don't see that. I don't think I've seen Marufi. Professor Marufi, à vous la parole, mon frère.
Oui, merci beaucoup.
Thank you very much. Thank you very much for this fruitful discussions as well as the recommendations made. I just want to propose to add something that is an idea that we encourage member states to further invest in the sharing of data regarding response to COVID-19 in order to reinforce the role of the African CDC, whose spearheading and then coordination of the response it entrusted to it. And our countries should make effort to share data with African CDC and assign an important role to African CDC Africa to play its role as intermediary in the sharing of data between African CDC and countries. Thank you very much. Thank you, Professor Marafi. We are going to add the recommendation that you just made. It's well noted.
If you see any hands, please alert me. I can't seem to be seeing all the hands. Egypt, is that?
Egypt, yeah. Next is Egypt.
Hello?
Egypt, please.
Yes. Thank you so much, Dr. John. Thank you, Dr. Ahmed. From Egypt delegation, we are fully supporting the articles and the final declaration, the communique of the meeting. However, there is one article that needs some elaboration for me. I think it's in page 3. If you scroll down, yes, endorses and support Africa. No. If we go up, please. If we go more up. Yes, collectively endorse an adapted strategy with focus on monitoring, prevention, and treatment in order to meet the changing dimensions of the COVID-19. Did we see? I wonder if Africa CDC circulated a strategy in this name. Otherwise, what's meant by adapted strategy? Is it a strategy for responding to COVID-19, or there is a different strategy that the communique is endorsing or adopting?
Very good question. You know, we had the joint continental strategy, which was approved by the board, by the Bureau on the 26th of March. And at that time, we didn't have any variant issues there. At that time, last March, there were no issues there were no vaccines. So all what this is saying is that, to give see where the pandemic is heading and the new developments, and then we need to go back to that a strategy and adapt it to what it is now. So that is that strategy that was endorsed already.
Oh, thank you so much. So can we just mention that it's the joint continental strategy and adapted one to meet? Yes, exactly. So
yes,
yes.
No, very excellent comment.
Thank you.
Yeah, can I say something, please?
Yes, Excellency, please.
Yes, I would like to see the drafting of the portion there regarding data sharing, how it has been captured.
Okay, can we just, I mean, maybe whoever, Akona, I think you're typing that, can you, Akona, type that and we see if we agree on the language, because that is important.
Sorry, Director, which page?
No, this is new. This is just new. You just go to the end and you type it there. It will be inserted appropriately. Just go back to the end of it, and you can type. Yeah, just create a new one that is support. And if Professor Marofi, please, you can. We may call you again to say that slowly so that it can be typed.
Okay. Je peux le dire en français.
Can I state that in French? Yes, you can go ahead.
Très bien. Donc, je voulais dire un peu de rajouter.
As I was saying, that I want us to add this.
On urge et on appelle vraiment les pays membres à s'investir davantage et à s'engager davantage dans le partage des données.
There is. Can he start? State sharing
in data.
Yeah.
De partage des données concernant
data sharing
riposte
on response COVID-19 response.
La riposte continentale contre la COVID-19.
Continental COVID-19 response to COVID-19.
Pour aider,
to assist
et soutenir,
support
le CDC Africa,
the African CDC,
dans la coordination,
in the coordination
de la stratégie continentale,
of the continental strategy,
de riposte contre la COVID-19.
In response to COVID-19.
Point.
I think we can dump it there, and we can, anyone native English speakers can help us to fix it.
Je peux rajouter la deuxième idée.
Can I add the second part of it? Can I add the second part? Go ahead.
Alors, je voudrais donc dire que
so I want to say that
de vraiment donner
another point, please.
Donc nous appelons à,
so we call,
nous appelons les pays
we call on member states
un rôle clé
to ensure that
de donner un rôle clé au point
focal point of member states
des CDC Africa pour jouer un rôle,
to enable them to play
un rôle central dans cet échange de données.
Key role in the data sharing effort.
Merci.
Thank you.
Voilà. Excellency, Honorable Minister of Health Nigeria, please, any suggestions on the wording?
Akona, the missing word is key role to focal point in country.
Yeah, key role. May I invite the Honorable Minister of Affairs of Nigeria to react on that, because he requested that.
Yes, I did. I'm just scrutinizing it now.
Okay.
The last sentence. All right, there's the word there to play in the exchange of data. Okay, good. Did you want to add a word about data security?
Yes.
Yes, you want to add something about data security.
Yes, I think, why don't we Akona go up and say, call upon member states to invest in data, acquiring data and ensuring the security, acquiring data with appropriate security, sharing, then I'll say I'll add something like a comma, sharing of that data in a timely fashion, to help support the continental response efforts, to continental response against COVID-19. Then I'll take to help and just say that to enable Africa's CDC to better coordinate the implementation of the continental strategy, something like that. Okay, so I don't see any further hands. So
I have my hand up, Mr. Chair.
Oh, Charles, sorry, somehow I'm not seeing him. Please go ahead.
No, thank you very much. I mean, it's an excellent statement, actually. So thanks to the team for putting this up. I mean, it's wonderful work. I just had my comment on page number 3, where we start with endorses. Yeah, it's, endorses, that part, yeah, which is talking about the position on the passports and so on and so forth. There is a statement which says that in the face of low vaccination coverage in Africa, I think that's not necessary. I think we need to delete that because the statement already makes sense without that part. That's my only comment, Mr. Chair. Thank you very much.
Oh, great. I think we should take, yeah, okay, good. That has been taken out.
Thank you very much.
And thank you so much. It was an excellent comment.
You have Minister of
Ahmed, if you see any hands that I'm not seeing, let me know.
Minister of Health of Malawi.
Okay. Yes, please. The floor is yours. I can't see the hands from here for some reason. I cannot.
Jirabulai.
Which country is that?
Sarawi Republic, Minister of Health.
Okay. Then unmuted.
I'm the Minister of Health, Republic of Sahrawi.
جميع العمل في هذه الأونية. تسمعوني؟ هل تسمعوني؟
نعم.
هل تسمعوني؟
Is there translation?
مساء الخير، مساء النور.
Good evening. Good evening. I want in the beginning to thank you for the work you are doing, and particularly in this year, the coordination you are doing. Particularly, I want to thank Africa CDC. I also want to thank whoever has worked towards the coordination of this meeting. I also want to thank you for this continuous work. But we have some problems in coordination, and there are some pieces of information which we have not had. And I have a comment on the trust, which is providing some financing to this project. For us as the Sahrawi Republic, we have been working towards implementation of 4 protocols. All of them are targeting the COVID. Some are talking about the vaccines and other areas, and also working on popularizing the vaccination, the ability to all working towards accepting. And we have worked through stages in our country. Yes, we have had some contradicting and misinformation about the vaccine, which has been negative, like you have also said. But we realize that there is not clear information about Sahrawi Republic about our vaccination, but we started the vaccination last month, and we are doing that in all districts, and we have centers of vaccination in each and every district, and I will give you a detailed report on the situation in the Sahrawi Republic. And we also need to inform you that we are working also, because of the lack of enough vaccines, we have prioritized some people, for example, the aged ones and all that stuff. Therefore, and we know that these aged ones, sometimes they have underlying diseases and chronic diseases, and they are the most vulnerable at a bigger risk in our society. And therefore, looking at vaccination, we have not done so much. We are using AstraZeneca, and we have also got help from Algeria to give the little that we have had to give. And we think that we need to thank God that we have moved some steps, positive steps, and we shall always be following your steps. And we have officials at different levels following research, science, and logic, and all that stuff in trying to understand the situation, so that we have good and safe vaccination. And we know that issues like freezing and all those things so that we have safe vaccination are very, very important. And we are also ready to put into consideration all precautionary measures that are needed. So therefore, finally, I want to say that we are going to evaluate the first steps we have taken, and actually we have been almost facing a second wave of this pandemic, the corona pandemic in our country, and we had a serious one also we managed to contain it, to contain the situation. And present the situation is lowering down, sort of being taken under control. And we think that we are having people in the field. Now we have a proposal. If there's if we can this document talking about, if it can be cleaned up and then sending to all member countries. That's one. We also suggest, if it's possible, that we get vaccination, since I've already said that we got very little help from Algeria. So if there is a possibility of having vaccinations extended to our country, we shall be very grateful. And also any facility which can be given to us to strengthen our health systems. And I know that I've talked a lot, but I'm sorry. I'm going to give some written document, and we shall give you that particular document, detailed report from our country concerning vaccination from our country through our Ministry of Education, Ministry of Health, sorry. And that is what we can say from our country, the Republic of Sahrawi Republic, in relation to vaccination. Thank you for listening to me. Thank you very much. I hope I've been clear. Thank you.
No, thank you. Thank you so much. We expect we'll be looking forward to receiving the report from you. So we have 2 minutes to close this session. And again, Benjamin, if you see any hands, or Ahmed, direct them to me so that we can finish at past the hour.
There is no new one, Dr. John.
Okay, good.
John, in the chat, there are 2 areas proposed. One is the need to protect schools.
Okay.
And then second, we'll get appropriate language. And Akona, you can just copy what's in the chat. And then second is for member states to conduct vaccine effectiveness assessments as they continue to vaccinate. I think those are the only 2 things, and we'll get good language for that later.
Exactly, and it came from Mozambique. That is not, yes. So with that, Excellency, let me, on behalf of Africa CDC and the Commission, really express a sincere gratitude for spending half a day to look back at where we came from and where we are today. Exactly 1 year and a few months over precisely on February 22nd, we met in Addis Ababa and decided to act collectively, decided that our strategy will be underpinned by joint coordination, cooperation, communication, and collaboration. And I believe we have exercised that all along. And the results are there to be shown. We are not out of the wood yet at all. We didn't know at that time that we will be challenged with the issues of variants. We didn't know at that time how challenging it would be to roll out vaccines and vaccinations. But here we are. We believe strongly that if we continue to work together in the context of the joint strategy, that is to enhance surveillance, need to strengthen our treatment and oxygen supplies, we will be able to continue to wage a strong fight against this pandemic. Partnership is key. I'd like to really, as we move to the conclusion, really recognize the important collaboration that we've worked as part of AVCOD with WHO. Chidi and I co-chair the steering committee, and we'll continue to, again, hit the reset button and re-energize ourselves. This battle is going to be long. I think I'd actually submit that in the next year or so, we shall still be fighting this pandemic, especially if we do not roll out vaccines aggressively. But it will require the collectivity and personal responsibility and accountability for us to win. Let me just conclude my remarks by saying that our move to enhance the need to prevent, to monitor, and to treat will become even more significant as we move towards, or some countries move towards the third wave, especially dealing with this virus that is terribly unpredictable. We should truly be looking at what is going on in Brazil and India with total concern. And I'm really pleased that today we discuss all of that, put our response strategies in the context of the evolution of the pandemic in those countries and in our own continent. And the strategies that we've adopted today, we believe will go a long way to enable countries to really prepare, know that we have some tools on our hands, like the public health measures. We are not totally desperate. We have to, again, step back and work hard and reinforce those public health measures while waiting to expand vaccines and vaccinations. So I thank you all for coming on this platform for the very active discussions that we've had. Unfortunately, President Tshisekedi has been called to other functions. And of course, you can count on his full support. He has always been with us for the last 4 months, and he's actually the one who called for this meeting. So the outcome of this will be presented to him and his office. So at this point, we'll officially close the meeting, Excellencies, but we ask that the ministers of health get into the closed session so that we can discuss some AVAC vaccines-related issues around AVAC. And President Orama, please join us in that. It will be very brief. I think we just want to have about 15 minutes to 30 minutes conversation on how do we get the AVAC process, you all going with the AVAC process. I thank you all for, again,
and you give us beyond the time that had been allocated so that we can communicate effectively. To be brief.
Exactly, it will be very brief.
Yeah,
maybe less than 15 minutes, please. Thank you all.